You all
असं पकडून एक मिनिट.
Welcome to the International Conference addressing the supply chain challenges of COVID-19, the Indian imperative. I am yours truly, Devendra Mishra, the Executive Director of the Bio-Supply Management Alliance, formerly called BSMA. I'm also the co-founder of BSMA, and it is indeed a matter of great pride to be leading this consortium of 8 eminent national and international institutions that bring this conference to you. We have all been witnessing the greatest apocalyptic tragedy of the century, where more than 9 million of our people in India have been afflicted with the coronavirus, and nearly 30,000 of our members of our families have lost their lives. While we see the light at the end of the tunnel, with the vaccines for the COVID-19 being approved, the task on hand is indeed a very daunting one, as daunting as the space program of Chandrayaan of many years ago. But it is very gratifying that the Prime Minister of India, Mr. Narendra Modi, has taken ownership for this and provided extraordinary leadership, where we are witnessing an unprecedented collaboration between the central government, the vaccine manufacturers, the state governments, the distributors, the hospitals, the medical centers. And it is this collaborative effort of all of us that will help us win this war on the COVID-19 crisis. I remember 20 years ago, the Y2K problem, where our Indian software engineers and programmers, particularly the COBOL programmers, navigated the COVID-19 has given the Indian biopharmaceutical industry a unique opportunity to build a strong supply chain for the industry and to allow our scientists and our manufacturers to develop drugs for the world at large and to get a disproportionate share of the $1 trillion market for biopharmaceuticals. It is opportune that America, that depends so heavily on China for its drugs, APIs, and materials, recognizes it must mitigate that risk. I believe India is a natural second choice. India is the pharmacy of the world. India does make more vaccines, probably 50% of the vaccines that the world consumes today. India certainly makes more generic drugs than any country in the world. So, out of this crisis, the phoenix shall rise. And I believe that for India to become the third largest economy in the world in a matter of a decade or two, the biopharmaceutical industry is going to be the critical driver of achievement of that objective. So let's have a very productive day of collaboration, and it gives me tremendous pleasure and the privilege to request my eminent colleague, my friend, the executive president of the Federation of Asian Biotech Associations and the professor from the University of Hyderabad, Professor Pallu Redana. Professor Redana, would you please take it away from here?
Thanks, Dr. Devendra Mishraji, for setting the stage for the conference. Let me join Dr. Devendra Mishraji in extending a hearty welcome to the keynote speaker, Dr. Venu Swarup, the Secretary, Department of Biotechnology, Dr. Srinath Reddy, Chairman, Public Health Foundation of India, the distinguished speakers, panelists, and participants of this International Virtual Conference on Supply Chain Challenges of COVID-19 Vaccines on behalf of the Federation of Asian Biotech Associations and other consortium partners. The Federation of Asian Biotech Associations is a not-for-profit organization established in 2005 with a mission of providing a global platform for the academy, industry, and government bodies to come together, interact, and discuss the issues of common interest with an overall aim of promoting academy and industry interactions and exploitation of technological advances to address the problems in the society. BioAsia has been the flagship event of FABA, which is being organized in Hyderabad for the past 17 years. Over the years, BioAsia has evolved as the most prestigious and widely attended global biobusiness forum. The moment the FABA and the BSMA proposed to organize this virtual conference, the response was overwhelming from various academic institutions, government organizations, particularly the Department of Biotechnology, represented by BIRAC, the Council of Scientific and Industrial Research, Central Drug Standard Control Organization, Association for Biotech-like Enterprises, ABLE, vaccine manufacturers, organizations involved in the cold storage and supply chain. A sincere effort has been made to assemble the best possible experts from all these consortium partners to present and discuss the issues and challenges and come up with possible solutions in addressing the problems of the COVID-19 pandemic. In addition, an exclusive session for the startups has been organized to showcase these innovative technologies for the last mile delivery of the vaccine. And we feel that these technological advances play a critical role in addressing the challenges being faced by the COVID-19 pandemic. Thanks to Dr. Manish Diwan from BIRAC for conceptualizing and coordinating this session. All these organizations have unique roles to play in addressing the challenges involved in the production of safe and effective vaccines, their storage and distribution, last mile delivery of the vaccines to the citizens of India, and protect them from the coronavirus infection. We are confident that together we can face these challenges and be successful in effectively tackling the COVID-19 pandemic. I am aware that this conference forms the beginning of showcasing our resolve to work together and confident that sustained efforts will be made in the next few months until the goal is achieved. I once again extend a warm welcome to the distinguished speakers, panelists, moderators, participants, sponsors, press and media to this virtual conference. Thank you.
Thank you, Devendra and Professor Redanna, for welcoming address. It is my pleasure to announce that a knowledge report has been prepared by two of our partners, CoolX and BioRx Venture, on the conference topic. I would encourage you to download the report from our website. Link is provided in the chat box. Before we move on to our next session, may I please tell the audience that if they have any questions, kindly put them in the Q&A box. In the interest of time, we shall try our best to answer them. Coming up next is the keynote lecture on the vaccine manufacturing and distribution policies and plans to save the life of the people from the pandemic through rapid vaccination, followed by special lecture on the vaccine supply chain will be shaped by choices and capacity. May I invite Professor Damodar Acharya, former director, IIT Kharagpur, to preside over the session. Professor Acharya, to you.
Professor Acharya ji, you have to unmute your audio.
Okay. Thank you very much. I have the first pleasure of inviting Dr. Renu Swarup, who is currently the Secretary of Department of Biotechnology, Government of India, and she is also Managing Director of Biotechnology Industry Research Assistant Council, BIRAC. She is also the head of National Bioresource Development Board. She is in the Scientific Advisory Committee of the Prime Minister. She had yeoman contribution to bioscience and biotechnology education and research policy and this cause of women in science. She is indeed a multifaceted personality with such a long years of association with the biotechnology or bioscience group. So may I now request Dr. Renu Swarup, Madam, to speak on vaccine manufacturing and distribution policies and plans to save the life of the people from the pandemic through rapid vaccination. Dr. Renu Swarup, please.
Thank you very much, and very good morning to all of you. And thank you so much for having me here, Professor Redanna. I think your whole conceptualization of this particular conference and your invitation, I'm very pleased to be here with you today. I think you all have identified a very important topic for discussion, and it's important that you have all the stakeholders here who are collecting together to discuss an important issue, which is not just any longer limited just to the science or to the clinical aspects, but it's become a citizens issue because everyone would like to know, when are we getting the vaccine? Who is going to get the vaccine? How will we get the vaccine? So these are issues which are definitely the topic of discussion today. And I think, as I've been saying on other fora and also in discussions with my own colleagues, never earlier in the history have we ever seen such a spotlight on science, technology, the whole area of vaccine development as we are seeing now. I mean, you literally have a day-to-day trial of the vaccine being monitored by the citizens, by the media, by the public. While it's very good, it is bringing in a level of understanding and information to everybody who's involved and engaged with it, and also those who are now going to be, part of, because it's obviously a vaccine that we're bringing out for the public. It also puts a lot of responsibility and accountability on the scientific, the technological, the clinical community. And I think for India, which has been recognized as a vaccine manufacturing hub, it's been recognized for its strengths in vaccine development for so many years. this is today our responsibility, as the Honorable Prime Minister has said on many fora, not just to have vaccines ready for our own country, but have vaccines ready for the globe. It's a global cause that we are all working for. And I think that's really what the effort has been over these last many months since this pandemic came into our lives. I think, first of all, it's very important to understand where are we in India positioned with our vaccine development. And as I said, India has this unique strength, which has been globally recognized for many years today, of being a vaccine manufacturing hub. More than 60% of the world's vaccines which go into immunization are manufactured within this country. We do have, in fact, a large number of vaccines which have been developed indigenously within the country, of course, with national and international collaborations, which today are in the immunization program. Our very recent rotavirus vaccine, which this department has been working with many other agencies, which is today in the immunization program, is again a recognition of the strength that we have. With this, when the pandemic came, it was definitely felt that yes, India will be able to take this challenge on. And I think I'm very pleased to say today, so many months down the line, that India has taken on this challenge. India is leading from the front, and India has put together all components that are required to go right from the research and development through the whole ecosystem that needs to be built to facilitate and accelerate vaccine development, to facilitate the manufacturing of the vaccines, and most importantly, the delivery of the vaccines. Again, in each one of them, as I said, we do have a lot of experience. We do have a lot of strength. We have strong foundations. And it was on these foundations that the government has very quickly built on newer policies, which we can then help to move ahead. I'm not going to go through where we currently are in the global status of the vaccine development, because today, as I said, this is the media news. You open up any news channel and they'll all give you a complete comparison of which vaccine, which global vaccine, which trial has it gone into, what is the efficacy data, what is the safety data. So we all know that. But I think what is important for us is to understand that never earlier has there been a situation where we are looking at a particular target, but we're looking at many platforms and we're looking at multiple vaccines which are going to be rolled out more or less together or straight one after the other, because the pipeline is so strong. We are very, very pleased that if today we talk about global phase 3 trials, if you're talking about 11, and that's my data for 2 days back, believe me, you really have to have a dynamic real-time dashboard now, because that's really how quickly numbers are changing on that dashboard. But out of those 11, we were very pleased that we had 2 Indian companies who were doing the phase 3 trials. India has partnered for the Russian trial, which is also now started on the Indian territory. So 3 which have gone into phase 3 trials. I think that's a huge number for a country to be able to be proud of, to take forward. It's then important to understand that how has this happened so very quickly. All of you are from the field, so you all know that vaccine development, a complex journey. 10 to 14 years is what we would always generally say. If you get onto a journey of vaccine development, it would take you 10 to 14 years before you do that. And here you're talking about less than 10 to 14 months. How did we do that? So while a lay person may ask, how did it change? This August gathering here knows exactly that each of the process of the discovery to the development, to the validation, to the clinical trials, all steps have been followed. Each part of the regulatory framework has been done, but then what is it that we did differently to be able to compress this timelines to 10 to 14 months? I think it's very important to understand that there are key components which help us to do this. And in this particular case, I would say, first of all, I think it was the commitment, because we all realized that this was a global challenge. And anybody who gets into taking this forward, whoever has the capacities and the competence to do that, were committed to do it. Since it was a collective ownership of the final goal that we were to achieve, it quickly brought us into the next very important step, and that is collaboration. Never before have we seen all stakeholders come together without an effort, come and collaborate to be able to deliver for a common goal. And this collaboration extended beyond the boundaries of countries, beyond the boundaries of public and private sector. We got everyone together. All the various departments and ministries within the government are today collectively on the vaccine group, which is trying to look at where are the issues, how would we do this, which are the bottlenecks which are going to come in our way, and not only approach it when it comes, but proactively try and recognize what is it that we are going to face, how do we address it in advance so that we are well prepared for it when it comes forward. Today, when you see vaccines which have been developed, and you'll see, in fact, all the players who are in this today, whether it's Serum or it's Bharat Biotech or it's Zydus Cadila, all of them, BioE, Dr. Reddy's, Genova, all of them who are in the advanced stages. I'm sure they're all part of your August gathering here. It's just that in this virtual circumstances, you can't see them. You just have to recognize names on the grid to be able to understand who's there. I'm sure they would all tell you that today, when they are in their vaccine development stage, what we see is the endpoint that the vaccine has come out, or the vaccine is at this stage of development. How many various groups are they collaborating with? The academic research centers, the groups nationally and internationally who are giving access to the resources that are required. I think that was the second most important component, which then brought in the, accelerated the development of the vaccine. And for both these that I have put in, whether it's the commitment or whether it's the collaboration, believe me, there was no new policy that the government had to put in place. These were policies which came in from organizations which were part of it. It was just to be taken forward. The third most important aspect is how do all the stakeholders partner? How does the government partner with the industry? How does the government partner with international groups to again give this commitment of saying we are developing vaccines not just for the country, but for the world? So we, in fact, over these last couple of months, India has been an active partner in all the international fora which have been created, whether it's the ACT Accelerator, whether it's the COVAX, all our discussions. Now here again, while specific policy decisions were taken by the government to become partners in this, this was greatly enhanced and accelerated by our existing collaborations and partnerships that we already had. And here India was already a partner with CEPI, India was already a partner with the Gates Foundation, with Gavi, with WHO, of course, our NIH partnership, all these, the Wellcome Trust partnerships, all these were very strong partnerships which helped us to bring in our presence. So again, no new policy decisions, but yes, building on policies which the government had created and taken over the last few years to be able to build this very strong collaboration to be able to move forward. Now, having said this, while we've got our entire act in place, we've sort of got a large number of candidates that we have been able to bring forward. We've been able to get these industry academia partnerships strongly supported. We've got all agencies within the government who've come together, as I said, in this vaccine group to be able to collectively take decisions as to how quickly. And this is all actually it's all a senior leadership which is itself engaged in this entire vaccine development program. And that gives us a lot of confidence to be able to move it forward. But having said this, it's now important to say, what is it that we are doing to further accelerate this development? So again, I would like to allude to certain decisions which were taken a few years back, which helped us to build on that to be able to move forward today. As you all know, the government set up the National Biopharma Mission, which is being implemented by BIRAC, which is our public sector. BIRAC, of course, is about 8 years in existence, but the Biopharma Mission is just a little less than 3 years into existence, where we connected with all organizations, the DBT, of course, the ICMR, the CSIR, the industry, very many institutes which were engaged in this sort of an activity of creating a biopharma ecosystem for translational research. So our whole effort was, how do we take discovery research to translational research, identify what are the gaps, and those gaps need to be then plugged by bringing in various enablers, whether they are policy enablers, whether there is investment that is required to create shared infrastructure, or whether there are policies that require to bring together the regulatory ecosystem and also connect it with other organizations. So the Biopharma Mission, and of course, most importantly, building capacities of human resource. Because today, if you need to expand, if you need to accelerate, and each of the industry who's engaged in this will say that you need trained, skilled human resource at every stage, whether it's the research and development stage, whether it's the validation stage, whether it's the clinical trials, either the preclinical or the phase 1, 2, 3, you need capacities. You need people to understand how to do that without compromising on the quality and the standards through which it is done. And I think that was the major focus that we had put on the Biopharma Mission. And that again came to our advantage now to be able to quickly ramp up what was already there. The collaborations of DBT and ICMR in terms of setting up clinical trial research networks, I think again is something which has really facilitated the speedy implementation of this whole vaccine development cycle. We have, in fact, while we spoke about these 5 or 6 vaccines which are now into advanced stages of trial, they are into human trials between phase 1 to phase 3 level. We are hoping to get data very soon from some of them so that they would be ready for, and already the stockpiling and manufacturing is happening so that we are ready for a rollout very soon. I think it was, again, there were 2 aspects that we focused on, and that is, one is partnering with them for investment purpose. So how do we facilitate and become part of the investment needs which are there for this development? And most importantly, as I said, how do we create a robust ecosystem? So we focused on supporting a large number of candidates, both financially, but more important technically as well. Financial supports to the industry are probably, right now the industry itself has come forward, so it's not really a financial support of the government that they're looking for, but I think it was the technical support and also the support that it's being backed up by the government to facilitate at each step in which it moves forward, because it's all being done for a national and a global cause. But yes, the public sector institutes are academic research institutes. Many of them have also identified a large number of candidates which are in different stages. And it's important for us to continue to support each one of them, because as this moves on, we really do not know which vaccine is going to be the correct vaccine, which is going to have a better efficacy and safety data. But it's important to have this large pipeline, because it's also very interesting to see that we have different platforms which are today being worked upon. As again said, never before have we seen this sort of a situation where you have multiple vaccines and multiple platforms. So what we did is, while we have nearly 30 candidates which are in different stages, some very early stages, some in preclinical, some reaching preclinical, which we hope will also be rolling out very soon. We also then realized that it was important to have within the country our own very strong ecosystem for the animal facilities, so that you have the animal challenge models available, and also the immunoassay labs. Because as you have very many candidates or very many trials which will get started, you will need access to these. Plus, of course, the clinical trial sites. So while we have a large number of clinical trial sites, I think between the ICMR and other hospitals had nearly about 60 different sites across the country. Through the biopharma mission, we supported another about, I think, 11 phase 3 sites, nearly about 30 hospital sites. So collectively, we do have nearly 60 to 65 sites across the country which have been engaged, not just today. I mean, they've been engaged for years in doing clinical trials, and they have a lot of competence. But it was important to bring in more competence into these, and that's really when we've now put in a lot of investment. Again, not just financial investment, but investment in terms of building their capacities, bringing in our partnerships with WHO, bringing in our partnership with CEPI, bringing in the right resource people to see that these sites become sites which are globally acceptable, so that when you have larger trials, when you have other vaccines coming in, these are trials which are accepted globally, because we do recognize that the vaccines which get developed within the country would go into WHO pre-qualification for being available globally. And that's really what our effort is, that we make this based on this. These sites should be, and these labs should be ready to be accepted by global standards. We are very pleased that one of our laboratories, the THSTI, has been recognized by the CEPI network of immunoassay labs. So that again gives us a lot of recognition. So that's one of the laboratories, but we are hoping that, in fact, our laboratory network of 6 laboratories would now facilitate it, and we'll expand it to about 10 or 12. You did hear, I'm sure many of you heard the finance minister's recent stimulus for which has been announced for Atmanirbhar Bharat, and the COVID Suraksha mission, which has been given the go-ahead, the green signal, which is really for the vaccine development. So it's for the R&D, which goes right up to supporting vaccine development up to the manufacturing stage. And here again, as I said, it's going to be investment, not just for the trials, for building a strong ecosystem. While we're investing in this, what is it that we're trying to see? It's not just the COVID vaccine today. There would be many other vaccines that India would roll out. So we are creating a very strong foundation of an Atmanirbhar Bharat, that India, which has always been looked at as a site for vaccine manufacturing and developing, is also now looked at as a site globally for other vaccines to come into the country. And that's really the effort that we've put in.
Sorry, madam, to interrupt. Time is running out. Kindly finish it.
I thought I had another 3 minutes, Dr. Damodar, and I would close it within those 3 minutes that you've given me to speak.
Okay, fine.
I can close it now. I'm done with my policies. If you want me to close it now, I can close it straight away.
No, please take your 3 minutes.
I thought I had till 10:40. It's 10:33 now. Okay. So I think what was important was to say that, how do we move forward? What is it that India is going to do to help and facilitate the development of this vaccine as we move ahead? One is, we've also started interacting with some of the international organizations, of course, but also some of the countries, to facilitate and help them to build their capacities. We have launched an India Pact program, which is a partnership for accelerating clinical trials, where we are working with our neighboring countries, with our friendly countries, to build their capacities in training, and also to facilitate if clinical trials have to be held. So that's our next step, with that we are working towards facilitating the trials and also facilitating capacities in the region for being able to help vaccine development even beyond COVID vaccine. The last point that I would like to mention is, of course, you did speak about the delivery ecosystem. The delivery ecosystem that you've spoken about, I think while I'm sure during this conference, you will have others who will come in from the health ministry to give you more information about it. It's important for me to say that the delivery ecosystem required a lot of planning, but again, our strength in the immunization program of our country, which we have been able to do a lot of immunization program, gave us that strength to say, how do we vaccinate a country as large as ours? I think the health ministry and all the players are already on it. A very good vaccine rollout delivery plan has already been put into place. We have an IT-based platform, which they will slowly roll out with the information. All the state governments have been brought on board. But I would just like to say that, as which I started with, that the government is now working proactively to ensure that all the steps that we need to take, whether it's from the regulatory viewpoint, whether it's from the procurement viewpoint, whether it's from the delivery viewpoint, those are done well in advance, that we are ready to roll out. A country, and I'm sure many of you heard Dr. Vinod Paul, who chairs this group, which all of us are part of the delivery ecosystem, he has said, and that's our Honorable Prime Minister's message, if we can do elections with a large country like ours, the same model is what's going to be used for the vaccination as well. And I think that's the strength that we're going to follow to take forward. So with this, I will conclude by just saying and reiterating to everybody here that the government is fully committed to ensure that we have a safe and efficacious vaccine for all our citizens, which is made available on time as soon as it's ready for delivery. The policies and enablers which can facilitate it are already in place. And the most important point is, with the Atmanirbhar Bharat call that has been put out, this ecosystem is not going to be limited only to COVID. It's going to be beyond COVID. And if we can all come together to respond to COVID, I'm sure we don't need another pandemic to continue this collaboration, to continue this commitment. We can continue to do that for everything else that we do. So with this, thank you very much for having me here. Thank you, Dr. Edna, and thank you, the entire team. I wish you good luck for your future discussions. Thank you so much.
Thank you, madam. Thank you, Dr. Renu Swarup, madam, for your excellent deliberation and explaining us the government policies, what you are doing in vaccine development as well as the vaccination, and in this process, you have really set the tone for the deliberation for rest of the sessions. We are really very, very thankful to you. And the fact that in spite of your busy schedule, you have been able to spend so much of time for us, this shows your commitment to the cause. Thank you very much, madam. May I now invite Dr. Srinath Reddy. Dr. Srinath Reddy is the actually President of Public Health Foundation of India. He heads the Department of Cardiology, New Delhi, some time back. He is an adjunct professor in epidemiology in Harvard School of Public Health. He is a prolific researcher, an orator, an author too. He has been instrumental in developing health-related policies for the Government of India and the states. Currently, he is actually advisor to the health department, advisor of health to the Government of Odisha, holding a cabinet rank. Today, Dr. Reddy is going to speak on the vaccine supply chain, which will be shaped by choice and capacity. This is a very important topic that he has selected. May I now request Dr. Reddy, please keep your deliberation.
Thank you very much, sir, for this opportunity. Well, this particular conference has the stellar participation of many people who are actively engaged in vaccine development, production, and distribution, and in policy making at various levels. So my role as a public health advocate is going to be to raise some questions rather than provide all the answers. as the wise person once said, it is the questions that are important, the answers are all out there. I think given the expertise that is there in this conference, the answers will flow. But let me mention as to why we have to really look at choices and capacity. Are our choices going to be constrained by our capacity, or will we make choices on other grounds? To multiple areas, vaccine that needs to be chosen, which vaccine, the population to be vaccinated, how many? Is it going to be 80% of the population? Is it going to be 100% of the population? Or as recently the director of the All India Institute of Medical Sciences said, we may not need to vaccinate so many because many people would have already acquired herd immunity by then, which I do not believe. But nevertheless, that's an argument that has been put forth. So next comes the question, who first and who next? Because the supply chain is not going to be in full flow immediately. And how do we actually prioritize and on what basis? Who will be distributing and who will be controlling the distribution policy between the center and the states? How many supply chains? Who will pay? Will it be universally free for everybody? Or will it be through a direct to beneficiary transfer for the poor and the vulnerable through the Pradhan Mantri Jan Arogya Yojana or through other government facilities? Is it going to be employer provided for those in the organized sector? Is it going to be personally purchased on priority by people who can afford it from private outlets? These are again some questions that will come up in terms of the choices that the government will have to really decide upon in terms of policy. Will there be a three-tier? We are likely to plump for an intramuscular vaccine. Are the personnel involved in the actual administration of the vaccine adequate in number and skills? Are they adequately distributed across the country if the responsibility is going to be left entirely to the state governments? Or will there also be a central team that will be moving from place to place to supplement the capacity that is there in weaker states? Those are some of the questions, again, that will have to be answered. And who will be monitoring all of this process? Now, coming to the question of which vaccine, obviously, we have to really look at multiple considerations, whether it is going to be a vaccine that is going to be produced in India after having been developed in India, or produced in India after having been developed elsewhere but licensed for manufacture here, or entirely procured from a foreign developed and produced vaccine. All of this, again, will have some impact on the supply chain in terms of the volume of supply that is available, apart from, of course, the production volume per day, even for the domestically manufactured vaccine. So what will be the flow as we move along and we ramp up our capacity? Will the flow actually keep in measure with the amount required as per our decisions? Or will we be constrained by some of the supply chain constraints? Of course, in terms of the mRNA vaccines, it does appear that those that require minus 70 degrees centigrade for preservation and transport, storage and transport are ruled out automatically. The minus 20, according to the Government of India authorities, is feasible according to our supply chain conditions, but nevertheless, cost may be a bit of a prohibitive factor. So are we going to be going in for other vaccines? Of course, in the hope that our domestically developed and domestically manufactured vaccines would be available soon to make it our first and perhaps our only choice? Or will we have a menu of vaccines to choose from and choose a combination thereof, principally depending upon our domestic vaccines, but supplementing it also from internationally procured vaccines if they're relatively inexpensive and easily available, either through the WHO procurement process or through a direct negotiated purchase. So these are going to be some of the important questions. But then the other big question is going to be, is it going to be a single dose vaccine or is it going to be a double dose vaccine? How many doses do we have to really then actually produce in order and distribute for that particular purpose? Perhaps at some point in time when we have multiple vaccines available, we may actually create a vaccine scoring system based on the cost, efficacy, safety, duration of protection, ease of administration, and so on. But that doesn't appear to be immediately in the offing. It may take it up to 2022 for multiplicity of vaccines to be available for that kind of a scoring process to be developed. Then comes the question of population. Which is the population that we choose to vaccinate, particularly when the supply chain is going to be relatively narrow in the beginning? How do we actually move along in terms of choosing? There is an essentiality model and a demography and disease model, a vulnerability model. Essentiality model really talks about people who are actually essential for maintaining our services in health, other essential services, and security. So we choose the health workers first, and then, of course, other essential workers who are also supporting the health services, but then also the security and transport services. All of them fit in with the essentiality model. In terms of demography, we look at age as the vulnerability area. We also look at crowd density, particularly in urban areas of large cities, and then look at whether that is going to be the determining factor. People with comorbidities and confer vulnerability, or where it is now spreading faster. If the cities are getting controlled and the small towns and villages are the hot zones of rapid spread, do we intervene there first in order to contain? So those are going to be some of the important questions and choices that the government will have to make, both the central and the state government. I believe there is now an emphasis on a mixed model where essentiality of health workers and other essential health services will be prioritized first, followed, of course, immediately by those who are likely to be at higher risk because of higher age, being the elderly, or with the diagnosed comorbidities. The problem about comorbidities is that in smaller towns and villages where the health services have not been very strong in the past and screening programs have not been very effective, many people with comorbidities may not be even aware that they have diabetes or hypertension or coronary artery disease. So we do have to look at people with diagnosed comorbidities, but also apply the age factor as a probability factor for saying that these are the people who are more likely to have comorbidities and include them as well. Then the question comes up is, do we also include people who have been previously infected? If they've already been infected, do they require a vaccine? We do not know the duration of protection and the nature of protection conferred by a previous infection. For example, people who are seriously hospitalized with a high viral load may have a stronger and a longer lasting immune response. Those who have been minimally affected or even asymptomatically diagnosed during a serosurveillance study of antibodies may not have had much of a viral load, and it may not last long. Since we are not studying the T cell immunity in all of these people, we do not know whether they have a lasting immunity or not. So I believe people who have had previous infections and we do not know the duration of immunity or the strength of the immunity, if they would also be candidates for immunization. So that will also mean that a very large proportion of our population would need to be immunized, even if there has been some level of exposure in the population. Then comes the question of distribution. Is the distribution going to be decentralized, and is it going to be dictated mostly by the center in terms of allocation to the states? The states have been told that they cannot procure directly, but it will be centrally determined. What will be the nature of flow from the various production points, whether it is Hyderabad or Pune or elsewhere? How are the distribution flows going? We should look for as much of a decentralized distribution process as possible, even if the policy and monitoring is done at the central level. Then comes the question of a digitized citizen journey for enrollment and then administration and monitoring. Previously, it used to be the paper-based methods. in the previous immunization programs. Now we have to move towards a digitized citizen journey. Unfortunately, the advent of the COVID program, which has been a platform that has been devised by the central government, is likely to be helpful in this area, but we need to plan it carefully. But we also have to make sure that technology should not disbar people from getting the vaccine if they are not technologically enabled to access that particular platform. So equity comes in, and we'll have to balance these in terms of efficiency and equity. Then comes the question of transport and cold chain. Clearly, minus 70 degrees is really out of reach, except for some specialized laboratories, and therefore it's not feasible for mass administration. Minus 20 is feasible, but may not necessarily be the best option. So we have to look for vaccines which are not so super freezer cold chain dependent, and those are some of the constraints that we have to really address with and live with the task of administering as fast as possible, as widely as possible, without being constrained by the cold chain barriers. Then comes the question of state organization and central teams, recognizing that who is going to administer the vaccine. Now, clearly, the people who have, it's very different from polio immunization, which was oral, or even measles, which are restricted to only children of a particular age group. So now you are going to be dealing with a huge volume. So how are we going to actually mobilize our available doctors, nurses, possibly medical students and nursing students, and our frontline health workers who are differentially enabled according to state regulations to give or not to give injections. So we have to try and overcome all the regulatory barriers to make sure that our frontline health workers are trained into vaccinators without any regulatory restrictions, but give injections without, with adequate skill and safety. And if we have to train other vaccinators as well, only for the purpose of vaccination, it should not be a very difficult task. It can be monitored training for safety purposes. We may have to recruit others as well into this task. But how do we actually build that kind of a task force in primary healthcare settings who can actually administer these vaccines with ease if an intramuscular injection is to be given, particularly 2 doses, and also monitor for the adverse effects in between. So all of these are going, and where for states we are very weak in terms of human resources in health, will there also be centrally monitored, centrally organized teams who will be also traveling across the country providing these vaccines. So all of these are going to be important decisions to be taken as to how best we can actually ensure universal access to vaccination. Then, of course, comes the big question of how do we incentivize and regulate the vaccine production and the supply chain, because there are going to be many issues related to how public-private partnerships need to be built in, how actually incentives need to be provided to the multiple players, whether it's the cold chain, the developers and the managers of the cold chain, or whether it is going to be the others who are involved actually in the distribution of the vaccine, or in the manufacture of the vaccine for that matter. All of those issues come in, but what are the appropriate regulatory restraints also that we need to apply alongside so that we do not see misuse or ill use of the vaccine? So those are some of the things that we need to really look at. And there, I believe, incentives and should be.
Sorry to interrupt. Please.
I'm concluding in a minute.
Okay.
There we have to really look at incentives as well as regulation. Regulation as a part of the same instrument. The carrots as well as the sticks will have to be combined into what I call a frozen carrot, which can act both as a carrot and as a stick. So what we need are redefined PPPs, not the classical public-private partnership, but a partnership of public purpose, which defines the public purpose and serves it well. So I believe that the people who are assembled here will adequately and efficiently discharge that public purpose. And thank you very much for this invitation to participate.
Thank you very much, Padma Bhushan Professor Srinath Reddy ji, for your excellent deliberation. And you have really set all the issues that has to be really tackled if this vaccination has to be really made very effective and given to the people who requires it. So it is indeed a sort of eye-opener, and you so nicely explained the issues. Thank you very much again for your sparing so much of time. In spite of all your busy schedule, we're really thankful to your deliberation. Thank you very much. Namaste.
Thank you, everyone. Next, we have panel discussion on manufacturing and sourcing of vaccines to keep 1.35 billion people safe and healthy. May I invite Mr. Narayanan Suresh, COO, Association of Biotechnology-Led Enterprises, to preside over this session. Over to you, Mr. Narayanan.
Good morning, everyone. This is Suresh. Thank you very much for joining the session. So our earlier speaker, Professor Srinath Reddy, has almost set out the context for the session. He has also asked almost all the questions that I will be, or our panel will be discussing in much more detail, which vaccine, multiple doses, where from where. And so I'm very fortunate to have almost the 80% of the India's vaccine industry present in my panel. Of course, the topic of the session is manufacturing, securing vaccine for the country. But being in the midst of a COVID pandemic, most of our discussion will center around COVID-19 and the corona vaccine as expected. So we have a set of three speakers, who are the who's who of vaccine industry. First, Dr. Vishwamohan Katoch, the former Director General of ICMR, followed by Dr. Varaprasad Reddy, the vaccine man of India, who introduced the recombinant hepatitis B vaccine and set up this whole industry, followed by Dr. Krishna Allah, who is the man everyone is looking up to these days for the vaccine. After that, followed by a panel discussion. There are four other panelists also from Serum Institute, Biologically, Aurobindo, and over to Dr. Vishwamohan Katoch. Meanwhile, unfortunately, as a panelist, there is a Bangalore Technology Summit going on parallelly. I'm speaking from the venue, and we have produced a report called Karnataka Bioeconomy Report, which the Deputy Chief Minister is releasing in a few minutes. I will be just stepping aside for a few minutes to the adjoining room. This was unexpected because the program was advanced thrice within the last 1 hour. So I requested my co-panelist, Dr. Lakshminarayan Reddy, to moderate in my absence for the next 15 or 20 minutes. Over to Dr. Katoch for your 8 to 10 minute talk, followed by Dr. Varaprasad Reddy and Dr. Krishna Ella. Over to Dr. Katoch.
Thank you, Suresh. Thank you very much. As you know,
my colleague, who was the former editor of Biospectrum, will be there sitting in my place meanwhile when I just step out to the next.
Most welcome. No problem. No problem. I think, this morning's tone is already set. What Dr. Renu Swarup alluded to, where we are in terms of the positive efforts going on. And Professor Reddy has told us, he has put the questions that what we really need to address today, actually, for future. See, the first point which I would like to highlight, there are a number of issues which are to be addressed, which I'll just concentrate on a few of them. Because I'm not a manufacturing person, I'm not a supply chain person, but a former techno bureaucrat. I just have a bit global outlook. So I'll comment from that perspective. See, the pandemic has brought a focus on COVID. We are thinking of the vaccines for COVID. But then it's not the totally COVID, actually. Whatever we are existing, it will be total. So the scenario of the manufacturing, scenario of the supply will not be COVID-centric. The country will be handling 100 of other problems also at the same time. So you will be manufacturing other vaccines, you will be supplying the other manufacturings, you will do the other things also. This will be one of them. So when we think of anything, it is a total picture. Then the second point arises, which the question again is by Professor Reddy. Then which vaccine? At the moment, the scene appears positive. There will be a number of candidates. And again, what he said, the one which will be easily available to us. But then available to us, and then another question which he said, which we must think about, is the landscape of the country. how it will fit in the ecosystem of the country. So I think those all issues, the planning committee, our Niti Aayog, the Ministry of Health, and the state governments, and the government as such will be discussing through their own mechanisms, through their own debates. But a conference like this, brings a focus on these key issues, that this is our opinion. So I think if you're looking at the landscape of the country, the extremes of temperatures, the difficulties in the periphery of storage, supply, you will have to build on what you have at the moment. India has a supply system at the moment, and fairly robust system, but it takes to the last, may not work actually done in a routine manner, because even the vaccines which work fairly good, and they are about 100 years actually, they're not really given to the people the way they should be given. Okay? So if until this is a campaign mode, if people don't access it actually, it doesn't reach the people. So what will happen now actually? Will we connect with the people there so nicely, so that they'll become very efficient the way have become efficient in the COVID pandemic as such? Will that efficiency at the periphery will work? Okay. So the people connect, everything in a landscape total will work actually. That will have to be considered. Then, the third point which I would like to again highlight actually, that is the selectivity of populations to whom. So I think again the priorities are being discussed, and I think there is a common sense, which are under attack in the beginning. You think of them first. That's absolutely fine actually. So those priorities in terms of the healthcare, the security services, but then the third part is, in the same subcomponent is the institutions, like the industry, like the colleges, like the other essential establishments, which you want to work for the purpose of your safety, where you want them to succeed for the purpose of the economic prosperity. That all we require actually. So I think those all priorities will have to be based on that system. But then who will pay for it actually? The next point arises. Okay, we expect the government to chip in the maximum, and that as a social responsibility, they will do some. But then the question of insurance, then the question of the institutions taking care of their responsibilities, the industry taking care of their own employees, government taking care of their own employees. So I think the payment, the contribution from towards the costs involved, I think again this will have to be thought of from the beginning itself, and then people will be ready for it. They will do their job. I don't think they will not do their job, but then these will have to be debated. Even in the development part also, if you really commit that to the industry, this much we are going to purchase, I'm going to fund this part itself. This is a co-funding from the beginning itself. That will make things much easier actually. So the institutions, the governments, I think they become they're placing advance order itself actually. They're doing that. But that all depend upon the possibility, which vaccine, for whom, where, and those choices which he said in the last, actually, because they will depend upon that. People will decide what's to be done actually. That will not be a very easy thing, but that will have to be decided very carefully. And then the last point I want to say, it will have to be choice and then a very, very closely monitored introduction. These are no unknown vaccines. We are thinking of positives at the moment to start with, but then the responsibility lies in terms of making a choice, making a decision. I think that becomes very, very critical, which we may not be thinking at the moment, but you'll have to decide that, because the decision of an unknown thing, the vaccine may have a lot of positive things to do, but it may have negative things to do also. So closely monitored exercise of its introduction into populations. So I think those magic bullets will have to be closely monitored. So I think this is the last point, which as a scientist, as a doctor, I would like to make there, which will be important. They will be considering it, but this is not done very well in this country. This is the truth actually we must face. We do very efficiently when we are in a campaign mode, but after the campaign mode, we leave it up. But in today's in the environment, it is possible actually, because we have a capacity, we have the network. It's all doable actually, nothing difficult. So very impartial choices, impartially judgments, thinking of generating data same time. The phase 4 of the introduction into the different subgroups will have to be very closely monitored, and then keep on making choices, because the COVID vaccines will be required for a long time to come. I tell you, this is not a story of containing now itself. This war will not be over a short time. This will be a long drawn battle. Okay? And we want to save people for all times. So I think that's really one of my messages for this initial part of this discussion, which we are beginning. Thank you very much, sir. Thank you very much.
Thank you, Dr. Kachor. It's been wonderful preface that you have set for this particular track of discussion, which theme is manufacturing and sourcing of vaccines to keep 1.35 billion people safe and healthy. And that's the theme of this particular track. And may I now invite Dr. Varaprasad to say a few words of his thoughts for this particular panel.
Namaste to everyone.
Morning, sir.
Good morning. I am not a scientist nor a life sciences student, but having associated with the healthcare industry for the last 30 years, I have some questions rather than solutions. Professor Srinath Reddy started the talking about the issues, logistics. In fact, what all I thought, he made a mention of that. There may not be much for me to talk about it, but I only endorse what he said. There are many unanswered questions. There are many gaps. Unless we fill the gaps with proper answers, the logistics cannot be planned or executed. He just broke the lock of Pandora's box. Now I've opened the lid of the Pandora's box. The world is currently on a pause waiting for COVID-19 vaccine. It may come, it will come, but not the time frame what our enthusiasts were mentioning. Even Government of India made a mention that by August 15th we'll have vaccine. It didn't happen. Not even by the end of this year. It may come probably first quarter of next year, 2021. It will come. Not one, maybe two. In India itself, there are two companies, good companies. They are in the race. Serum Institute of India and Bharat Biotech. Biological events may come little later. But point is, when these two companies are going to roll out vaccine, because now Government of India allowed pre-manufacturing before the license. That's good initiative to save the time. When they're ready with each one, say 50 million or 100 million doses, they're not enough. Not only that, there are many issues. First of all, on price, at what price? Whether it's going to be 2 doses or not, we do not know. And there are many other questions. What is its shelf life? Nobody knows. What is its immunogenicity period? We do not know. And whether, as Srinath Reddy suggested, whether already people who got COVID infection and whether they have antibodies or not, we have to test them and then give the vaccine. We do not know. So there are many issues which are to be thought about now. Unless we have those answers, the perfect plan will not come for 135 crore people. Now, as it is already, some priority was given by central government, saying that first one is for healthcare workers who are on the front end fighting with COVID. Fine, that is understandable. Then they said that people who are above 65, then after that, people who have some infections, and after that, below 50. But what is the system that is going to be adopted to segregate these kind of sections of priority? What is the methodology? Whether central government is going to do it or state government is going to do it, is there any system or organization or a structure to do this kind of separation and prioritize, make them stand in the queue and do it. And Serum Institute of India got almost 300 million, if I believe what I was told, $300 million to procure 200 million doses. So they were given instruction not to sell beyond $3 per dose. If they are going to do two doses, each one is going to cost around 500 rupees. But who will pay it? Government of India or state governments or people have to pay. If it is allowed openly, rich people will come first. They will, irrespective of sector, whatever you call it, this is a priority, healthcare workers first, and then say above 65 is the second priority. This prioritization will have no meaning when it is open for public. Whoever has money, deep pockets, they can go and buy it, depriving the essential people who have to get it. So it is very difficult to implement. People should think on this. The government, not people. Government should think about this and have a structure quite well defined and implement it appropriately. Then only equitability, the justification for prioritization, the needy people will get on priority. Then IP issues will come. Bharat Biotech didn't get any support, I think, from government, if I understand correctly. They are doing on their own money. But are they be allowed to sell at a cost which they can recover their R&D? No idea on that, no information on that. When one company got support from Gates Foundation, the other company is only working on its own funds. So they are at liberty to sell at any price to cover their costs. Will it be like that, or they have other ways of controlling? Price control will come into effect. If that comes in, the other people who are enthusiastic to spend money on R&D will be hesitant to do that. We have to have some clarity, and government should be transparent in making some statements. And they are comfortably saying only dates, that they are saying it will come in August, it will come by end of this month, end of the next year. These statements are okay. But basically, they should spell out the policy, whether it is going to be funded by the government. If the government, it is central government or state government, or some people, prioritization people will get free of cost. The others can buy it in the open market. If it is not defined well, what happened recently when Remdesivir was launched as a possible drug for combating COVID, it has gone into grey market. People sold it to 1.5 lakhs, 2 lakhs. Do we want that one to happen to vaccine industry? These are very peculiar times we are living in. Earlier, no vaccine had this kind of attention, this kind of advertisement by media, and political people are taking their own advantage. Companies also are taking their own advantage. The other day, Pfizer announces, the CEO, that their vaccine efficacy is 90%. And next day, he sells his stock after seeing the rise in the stock market. So these kind of unwarranted, unethical things can happen in our country also. There should be a public policy clearly defined who is going to get it first, at what price, who is going to fund it, etc. And other things, technical, of course, I'm not technical, but I'm concerned. And the all clinical data, earlier we used to publish them. And nowadays, only press release is the answer. They are giving to press that phase 1 completed, phase 2 completed. But there should be some data on that. Earlier, our vaccine trials were reviewed by peers when we published them in a reputable magazines or journals. That is not the order of the day today. We do not know what is happening. So one day we hear that AstraZeneca stopped their trials because of some serious adverse event. The next day they said that it can go ahead. But what is the reason? At least we know that some people were found allergic to this vaccine, or it is not the root cause for that. They established it and they allowed the trials to continue. But that's kind of data in India is not made available. Maybe they are reporting directly to regulatory people, but regulatory people in this kind of emergency mode, only limited people are reviewing and they are giving permissions or they are stopping it. But if it is allowed to be reviewed by other peers when they see it in the established journals, that will have more authenticity, that will be more safer for the human use. My request is that all companies who are in this business, they should publish their data as and when they are ready, when they have submitted to regulatory. Parallelly, they should do it to journals also, so that other people also can have a look at it. Then my other concern is, it will take minimum to cover all the people, at least in India, 135 crore people, take 2 to 3 years. In these 2 to 3 years, to maintain the serenity, the anxiousness of the people who have to get first, etc., they have to be told in this region where it is pandemic is more, then they have to be given permission to have the first. All this kind of segregation is very important, because if it is made available after 2 years, the state or the place which is getting the last will be in anxious moments. They should be properly educated. They should be properly given information that they are getting their priority in the due course. If it is not done, it is another pandemonium we are going to create. It is going to be pandemonium. Now we are in pandemic, and pandemic to pandemonium, we will slowly shift to that. Some anarchy, some hesitations, some street shows, all these things can happen, because this is a very peculiar situation as I see COVID situation. It is not like that for any other vaccine so far. So people, I think, if you remember, in the initial stage of COVID, the protocols were not properly defined, because they were also learning, medical doctors. So they made several trials and errors. Ultimately, they have frozen a particular protocol, which is 70% or 80% right. Similarly, for logistics also, we have to go through the same trial and error. We have to learn things as we move forward. Professor Vishwamohan, he was telling that we will learn on the way. Yes, definitely. It is going to be not easy. We don't have any ready-made solution. First of all, if we define our problems by way of questions through the seminar, then people will note down and start working on that, zooming their attention on the problems and questions raised by these people in the panel. And some people should work on that. Bill Gates Foundation and these Gavi people, all these people formed a consortium, COVAX. They are thinking on this, how to transport it, how to distribute it. There are several issues. At one go, we require so many vaccines, 2 billion vaccines. To make 2 billion vaccines, so many raw materials are required. Cartons are required, the rubber bands are required, the labels are required, vials are required, seals are required. Whether the other areas where we have to get inputs, did we prepare them? And did we make them alert that we require at one go so many vaccines? So are you ready to supply all these things, whatever is going into the vaccine? And there should be some uniformity around the globe. Ultimately, the UNICEF, WHO, COVAX system will finalize 2 or 3 efficient vaccines, and they will ask global leaders to produce across the globe at 4 corners. They should be transported effectively to all the places. And this is also a big exercise, and many more things have to be thought about, and then only our logistics will be nearly perfect. I cannot say perfect. So a lot of things are there to think on, and this is where I want to stop. I endorse what our Professor Srinath Reddy raised the issue. And these are main real concerns more than development of vaccine. These also are very important. If the vaccine is available and we are not able to deliver to the people, it doesn't serve the purpose. Thank you very much.
Many thanks for your deeply insightful initial commentary and this sets the tone for the panel discussion. May I now request Dr. Yella to say a few words for the panel and set the context for the conversation.
Thank you. Thank you, Lakshman. Can you hear me now? Can you hear me, Lakshman?
Absolutely.
Good. Thank you.
Absolutely.
And I want to thank Professor Damodar Acharya to be there as a chairman. And I think time is running out. I'll make it few bullet points. As a manufacturers, we don't just develop a vaccine. We also work on a last mile delivery, how to deliver this in the field situations. We have that experience. And my friend, Dr. Varaprasad Reddy, clearly briefed a lot of things. And I just want to brief some of the points that he brought it together on some of the issues. Peer-reviewed journal. Yes, Covaxin will come in 4 reviewed journals, articles will be coming. But it takes 2 to 3 months minimum for review of all the articles. So which are in the review process right now going on, and it will come, all the 4 articles on both monkey challenge study, hamster studies, phase 1 data, everything is coming out, all the things. So please be review clear that we are a scientific driven company. We want to have peer-reviewed, internationally peer-reviewed journal, and it is coming. So Okay, that's number one. And also, and whenever adverse reactions are, people are talking about, even some press people, somebody even raised in the chat box why we are not disclosing. There is a clinical protocol, international Helsinki protocol is there, that we need to follow in a clinical trial very strictly. We can't give every adverse reaction to the press. We need to give, first rule is, their ethical committee of the hospital should be informed. And ethical committee, first we have to inform the Drug Safety Monitoring Board, DSMB. DSMB and ethical committee will be informed, and our ICMR Director General, ex-Director General is right there. He knows the protocol of this sort of ethical guidelines. We have to follow that, and then we have to inform the DCGI and subject expert committee reviews, and then all the process followed. But I think, everybody's kind of suspicious about Indian vaccine manufacturer or something we're not following. But trust me, one thing I can tell you, we are following international guidelines, not less than that. So the trust is important in the vaccine, and we are creating the trust, but just give us time. Because as a manufacturer, I don't have a backup like AstraZeneca Serum Institute has got. We are fighting alone. And somebody raised issues in the chat box. We got a lot of money from somebody. And I'm telling honestly, this Covaxin project, we are doing, as my friend Dr. Varprasad Reddy said very clearly, we have not got money. And the question is, how do you realize that R&D cost? You raise a pertinent question. If we don't realize that R&D cost, we are not going to survive as a company. Nobody will take innovation. Nobody will take a risk in the vaccine field. And that's a key as a battle for us in the country like in India. And when we develop any vaccine, we always look at the public health system at a large, where there's three angles we look at it. Always, one is the vaccine storage cost. What will be cost matters. Cost is not just manufacturing cost alone. We also look at it, the packing cost, transportation cost, and delivery cost on the four. And that's the cost of the total vaccine, all put together, all the four. We look at the vaccine storage cost, in-country transportation, transport from Hyderabad to Calcutta, Calcutta to Guwahati, Guwahati to Manipur, all that we work out the costings, the parameters. And per kilometer, how much it costs, per dose, how much it costs. And then we also look at the biomedical waste, what should be done in the disposal of those plastic in the final stages. We look at all those angles, and we work at those sort of angle in the manufacturing. So I want to leave it because the time is running out. And so whatever the questions are there, but one thing somebody has got a negative thinking all the time, particularly some chat box people raised, we got a lot of money from there. And I want to say that we have not got any money from the Covaxin project. So that's number one. And we follow the international guidelines of the clinical trial. Be rest assured, we are not going to let down that standards in the India. Being an Indian company, we are much more cautious than a Pfizer or Moderna. We are much more scrutinized. So therefore, please be assured on that. Thank you very much.
Many thanks for the clarifications and the specific guidance for it. There's so much more that the public has got so much more interested in the vaccine development. And thanks for, the public scrutiny have also become so much more. And then it is in that context, you are cautioned in terms of there are protocols which are there. There is a DSMB board which will review, and then ethical committees, and they all will have the immediate opportunity to review. And then before we can raise an alarm to the millions of people all around the world, because in the information age today, it can raise unwarranted questions. So it's very well received. Thanks for that clarification, and then setting the tone for this track of the discussion. Just continuing with the subject, I have one, this is my personal feeling, and I would like Dr. Anand Fayal to react to this. In my understanding, for all the downsides that this COVID onset has actually given in this last 100 years, in this generation, we are experiencing it potentially, and I hope we won't have one in the rest of our lifetime. But the one thing that I feel there is a benefit that it has done is it has brought the discourse into the Indian vaccine industry and what it has actually been a contributor to the world in terms of the 60 or 70%. Silently, we have been serving the world children by about 60-70% of the world children by the Indian vaccine industry. But in my understanding, at least the stakeholders, governments knew it all the while. But the question is about the stakeholders, and then the average citizen at large have now got an appreciation of what the contribution of Indian vaccine industry. And in my understanding, that's one of the biggest plus for the industry. And the second is also in terms of vaccine as a public health intervention, it's a very cost-efficient public health intervention. And in my understanding, this general appreciation by the citizenry will essentially make more responsive governments and then making more vaccines into the EPI programs, potentially helping the disease burden to reduce over a long period of time at a very fraction of a cost. This is my understanding, and then I would like you to elaborate if you agree or disagree, or what are your thoughts, Dr. Anand?
Yeah, good morning, Lakshmi. Yeah, you have rightly pointed out the industry did do a lot of service in times of providing quality vaccines. And you may know that while there's a lot of companies around who have spent a lot of time developing focusing on COVID-19 vaccines, like at Indian Immunologicals, we want to make sure that there's no disruption in supply of already existing vaccines which the government wants, like say, whether it be a pentavalent vaccine or whether it be hepatitis B. Unfortunately, this year, I think the number of participants in tenders for the conventional vaccines has been much less. I think a lot of people are reserving their capacities for COVID-19 vaccines. But for Indian Immunologicals, we want to make sure that the existing supplies continue. And the fact is that, as you rightly said, that affordability, as you may know, this year, the pentavalent vaccine, we won the tender, and the price was as low as 17 rupees something. So to provide a vaccine for 17 rupees, which can offer protection against 5 diseases, I think in the history of medicine, I think this must be the most economical intervention that you can imagine. And so definitely, see, there's a lot of very good companies. We have a very good cluster in India. All our reputed manufacturers, as you rightly said, 60% of UNICEF supplies go from India. And we at Indian Immunologicals also supply to more than 40 countries, especially the rabies vaccine that we manufacture. And we are also in this COVID vaccine race. But the approach that we took is slightly different to what other companies have taken. One is we took the most technologically challenging approach, which is to develop a live attenuated vaccine. So the advantages of live attenuated vaccine are many compared to inactivated vaccine or other mRNA or DNA vaccines, in the sense that it induces both humoral and innate immunity, and also the cost of making a live attenuated vaccine is much more less than making other types of RNA or DNA vaccine. So we have a capacity for about 200 million. And our first choice again would be to supply within the country. And if there's anything spare, then we would look at other markets. In the meanwhile, we also have some additional filling capacity. And from day one, we have offered it to other companies who are running short of filling capacity, if they so desire, that they will be happy to spare it for them. So in terms of other things that we talked about related to supply chain, today, we are both a human health and animal vaccine manufacturer. Historically, we have established very good cold chain networks, especially when you supply animal vaccines. You have to reach very, very remote locations across India. So already a very good cold chain network has been established. And over a period of time, we have added a lot of other things like SAP, and also now with GPRS, like there's a lot of traceability about the trucks that move from places. We know exactly what location these are in. And anytime when all these, for example, if there are any deviations in temperature, it all gets reported instantaneously and corrective actions are taken immediately. So I think as a country, I mean, I can talk about on behalf of all other vaccine manufacturers that there's no desire to, it's more of a social good and being commercially viable than just for commercial purposes. And in terms of science that we adopt, all companies have DSIR approved R&D facilities, and majority of the vaccines that have been developed have all been developed internally by the companies themselves.
Wonderful to know, Dr. Anand. And with your most, I mean, like many other manufacturers who are dabbling at it, your pursuit in terms of getting a very cost-efficient, widely distributable vaccine is very well appreciated. And thanks for your thoughts on it. And taking a cue from what you said in terms of, so far as what all that we know from the media, and then there's a lot of expectation within India. that this the earliest the vaccine, when should we have it? I think all of us are more attuned to the media reports. So I would now want to ask from Serum Institute, which seems to be holding the race ahead. And Dr. Rajiv, if you would like to let the forum know as to when do you think that the vaccines would be available? Because of course we have lots of media reports, but I think it's no better than knowing it from the company.
Okay. Thanks to all my panelist colleagues and thanks to you, Lakshmi. It is privilege. So thank you very much. The question that you are asking is not a million, but maybe a few billion-dollar question. Having said, not only the public around, my family is also asking me the same question, whether it is tomorrow or day after tomorrow.
Right.
I mean, yes, the trials are getting over, but you know, we have to wait for the safety data.
Dr. Rajiv, please turn on your video.
I'm getting a message, you cannot start your video because the host has stopped it. So if you can start
Maybe
it.
they will have a host to sort it out. I do not know.
Sir, I've just given you the rights. Please let me know if it is working.
Yeah, now it is working, it seems.
Okay, yes.
Yes, the big efficacy trial data for the Astra product is running in UK, Brazil and Africa, and plus in India. So as far as India is concerned, yes, we completed the recruitment. The second dose is also getting over by month end. And so we expect that the efficacy data plus the Indian data accumulated and the DSMB report should be available maybe by last week of December. And that should pave the way for the availability of vaccine in the early part of 2021. I'm sure everybody is anxious, like me as well. But those are the practical things which we need to take into account. And then obviously the review by the drug controller and subsequent licensing, maybe audit and all those things. So we expect that early part of 2021, the vaccine should be available.
Oh, that's wonderful to know. And I mean, as an add-on question, do you expect any distribution challenges when your product is expected to be in the market in terms of, will it be any different? Because in terms of the programmatic suitability or large-scale intervention, like the initial comments said that this is going to be a vaccine for every person, not necessarily for other products which are only for certain age groups. So just wanted a little more elucidation on that.
I think all the trials that so far have been conducted, even in India, is 18 onwards. So anybody who is beyond 18 would be getting that vaccine by scientific means also, because that is why the age stratification for all clinical trials would be available. But in the Indian trial, yes, it was over 18, any age, and that would be the thing that would be available for practically everybody, but nothing below 18 so far.
Correct. And this is not necessarily only for you, but maybe other colleague manufacturers as well. But there is one general concern which keeps coming up from the policy makers is about how are these manufacturers how are they really able to prioritize COVID vaccine? And does this necessarily mean that will it deprioritize any other vaccines, and then will it deprive the program of any other vaccines? This has been one of the questions that keeps happening. So I just wanted any one of you can pick this up and then try.
I will take that question, which is very often asked question, and is quite right to ask this question. So as far as we are concerned, nothing has stopped for routine. All those contracts which we have with Government of India as well as with UNICEF, they will go through. And maybe I have some other side to tell that whatever has been accepted as a contract, but there are countries are not lifting the required vaccine, and that is why there could be, I mean, no vaccination in some countries, not because we don't have vaccine, not because they are not taking. Maybe the prioritization for purchase would go for COVID, but from our side there is absolutely nothing that would be short for routine. I mean, we should take it really with pinch of salt, that you just can't say I will stop COVID death, but I will allow measles death. I mean, that cannot be the bargain that we are supposed to do.
Absolutely. That's reassuring to hear that. Anand, would you have anything to add?
No.
All right. Okay. There's another participant, Dr. Sivakumaran from Aurobindo. So good morning. And I just wanted to ask you this as a question, but obviously you can elaborate on it. I didn't mean to pick on you, but how is the companies are expected to finance? I mean, I did hear Dr. Varaprasad and also Dr. Yella speaking about this, touching this subject. But if you can elaborate in terms of how are the companies which are entering the vaccine field, how are they, especially in the specific COVID times, how are they expected to make the initial investments and get these vaccines? I mean, by the very nature, vaccine industry is investment intensive, gestation periods are long, and there are also allusions that are done in terms of there are some companies get the push funding and some won't, and then how is it, how this conundrum is best managed?
No, as far as the funding is concerned, Mr. Lakshmi, we ourselves is organizing fully ourselves, yes, presently. Yes, 100%. And the whole question is that the whole project is a very, very unusual project, unusual process and other thing. And we were also in a very peculiar situation in the sense we were attacking three fronts we were attacking. One is our own research center at US. They are working on some molecules that we know up to what level it is going to come. Yes, it is some promising candidates have come. Yes, it will take some time. So we didn't want to go at that stage. And again, we have got a collaboration with CSR laboratory to help them out in scaling up and production. Yes, that is going to be another question mark because we have to take some time. And third is our own, we have got some discussion with already the innovators who are in the final stages who are about to launch and other things. So there also we are going to work together in launching the product and simultaneously do some phase 3. All these things, we wanted to take it up our own funding and other things. Perhaps now more clarity has come. Now we may have to approach the various funding agencies. I think now we will start it out.
Very nice.
Am I clear? Have I cleared your point or?
Absolutely, absolutely. This my question is to Dr. Varaprasad, and I just wanted to know your vision in terms of now there are different types of technologies and platforms, and there's so much of innovation that every company is trying to add a little value and then try and work on. Dr. Anand said he's working on a live attenuated vaccine, and someone else is working on some RNA vaccines, and then Dr. Yella is at the forefront of different kinds of vaccines. So how do you see, I mean, where convergence will happen maybe a year later when many different candidates will all start to arrive? How the vaccine space, rather the COVID vaccine, will settle down, and then how do you see that the equilibrium will start to set in at what point in time?
Yes, sir. In your question, you used the word convergence.
Yes,
that is very essential in future.
Yes.
For example, most what you call, I don't call them rivals, but they are two leaders in their own way in vaccine field. GSK, GlaxoSmithKline and Sanofi. They had their own markets, their own technologies. They're competing with each other. Such kind of people, normally they don't see eye to eye. Now they have taken shake hand. Rather in COVID times, no shake hand, only wish. They joined together to develop COVID vaccine. Sanofi is using its recombinant DNA platform. They are very good at that. And GSK also has rDNA platform, but they are very good in adjuvant technology. Both of them came together, most unprecedented times, an unprecedented thing happened. Now they are jointly working on COVID vaccine. They are adding their adjuvant platform to this recombinant DNA platform of Sanofi. and they are coming out with a very effective vaccine. They don't speak much. They don't give any press statements. Probably by June, July of next year, they will have authorization to sell it in the market. So in future, I think convergence of technologies is very important, and there is no need of 100 varieties of vaccines to come. We can standardize them, and people will come together, complement each other, come out with more effective vaccine, reducing the confusion in the market. If there are 20 vaccines, people have big question, which one to use? Then it will become another pandemic. So the best way is to converge and form an effective 2 or 3 vaccines, not more than that. That will happen. It will settle down. Thank you.
Thank you. Thank you, sir. And then my next question, this leads me to Dr. Yella. And this is largely about, this is a question that I want you to peep into the future and then help us a little more vision into it. I mean, Indian vaccine industry silently has built a leadership. And this I'm also trying to contrast with the pharmaceutical journey that it has happened from early 90s onwards. I think pharma has built up the leadership in terms of US generics in the synthetic and small molecule chemistry, and they continued with it. But at the same time, by the time the fermentation APIs have come, literally we have lost the competition to China. So much to the fact that we nearly started to restart the entire thing as if we are learning chemistry now. The point what I'm trying to make a simile on this, and then wanted your vision of the future, is about how does the Indian vaccine manufacturing industry and the innovation industry, two parts to this question. One, how can we lead keep the leadership for the future, maybe next many decades, so far as the global supplier of vaccines. Second, this is by volume, which is what we have, and then how do we maintain it? Second is about how do we also move up the value chain, and not just by the volumes and then the peanuts of a revenues, how do we move up the value chain and also make innovation as front and center, and then move up from where we are right now. So I know it's a broad question, but whichever the way that you see it in the future, it will greatly help all of our understanding.
Thank you, Lakshmana. I think it's a wonderful question. I think, my friend Varprasad Reddy said very important thing is the how Sanofi and GSK, two leaders of the world, are cooperating. It's a fact, actually. It's a very good partnership. And I think the vaccine industry needs a partnership. Let us look at it, Indian manufacturers. Before that, I'll back up one thing. Why we lost a fermentation of IPA? Because of competition, IDPL, Reddy Lab, everybody started fermentation based, killing each other, and Chinese came and they brought down the price. Naturally, we all destroyed. All our industries are destroyed. Okay. And the same thing, what I'm worried about vaccine industry is today, the two things, the price erosion is happening. And my friend Anand Kumar is saying he's happy that he's selling at 70 rupees a dose vaccine. But will it survive the future of this country? I'm really concerned about it. And today, so unless we have a partnership, we will not survive. Why to make so many manufacturers? Like, let us ask a simple question in another way. Suppose if the COVID disappears by 2021 or 22, all the people who are invested in the vaccine industry, what will happen to them? Everybody will collapse.
Correct.
Just ask a simple question. And then by next year end, we'll have excess supplies of production and everybody will be having vaccines. Then if the market doesn't take up, what will happen? These two scenarios dictate terms on the vaccine industry in a different way. I think I fully agree what Varprasad Reddy said, is the partnership is very critical. Somewhere Indian vaccine industry are shying away from the partnership. We are insecure of each other, and that should get away and partner. Okay, let us share one technology if I develop. Let's share with the BE or Sharta, whatever it is. We share both together. Okay, I'll do the up to manufacturing. You take the clinical development. You will have a dossier with you, partner with it, and make it. But again, I'm telling honestly, 17 rupees, less than a water bottle cost of this country. And I'm telling honestly, it will be in trouble. The vaccine industry will be in trouble in the future. Thank you.
Absolutely, sir. And I mean, either you or Dr. Varaprasad, any one of you can take But I still want to persist with the question. It's not just the volumes that, 60 or 70% of the volumes of the vaccines and children who globally they take it, but how as an industry we will move up the value chain in terms of getting innovation. Because all put together, we may have about 20, 25 vaccines per vaccine preventable diseases in the current context. But one good thing that has happened is about this COVID has brought in the discourse, and then people now have a better appreciation of vaccine as an intervention for them, because they were all happy paying post an event. For life also, people keep taking medicines, and then millions of rupees they are happy spending. Rather, if somebody has to give $1 for a, like you were alluded to, 17 rupees for a 5 antigen vaccine, and 20 rupees is a Kinley water bottle. It's silly to say the least. And this is what is the downside of this. And I really want to understand from both of you, because you have really built this industry, like what has been Dr. Reddy's and then Ranbaxy for pharmaceuticals, and you guys have that kind of a leadership in this. I want to hear more from you in terms of how do we get up the value chain, be it the innovation or how the industry academia partnerships will help, or how the startup ecosystem will really make an intervention in terms of moving up the value chain.
I will take first 2 minutes, then my friend Krishna can answer.
Sure, sir.
Sir, sustainability is very important.
Correct.
Though we all originally with emotion started working on affordable vaccines. Yes, at the time it is affordable. Today, a movie ticket costs 500 rupees. It is a 2 hours entertainment.
Correct.
And vaccine is a lifesaver. Why if you go at 70 rupees, people cannot afford more than 70 rupees, they can afford. But the same slogan, 1 rupee kg rice, is no more valid for this changing times. If sustainability is not there, innovation will not take place here. Innovation is from the other frontiers. We ever depend on other countries, no self-reliance, nothing. Government should step forward. Here the problem is with government, not with people or industry. I am openly telling government is shying away from R&D and innovation. They were earlier giving weightage in IT. They were giving some concessions if you spend money on R&D. 200% they used to give. They reduced to 150, 100, now 0. What is the signal they are giving to innovators? We don't care about R&D, isn't it?
Absolutely.
Make in India, what a kind of slogan it is. Made in India should be, not make in India. Everything is completed outside 95%. They come in the last stage of the product finishing, either to put a screw on it or to connect a cable on it. That is called Make in India. The entire innovation is done elsewhere, and only cheap labor for that they come here. They enjoy all the construct of the government, land, and free water, free electricity, everything. And what is the valuation they are giving? 5%. All cell phones, what we are now doing in India, their valuation in this country is only 5%. This should not be the criteria. Other countries, they spend a lot of money on R&D. They liberally give to industry. Not only that, they fund universities very well. And universities will evolve the innovation. They give the proof of concept to the industry, and the industry further researches on that and complete the project. Our universities are weak. We don't have university. The vice chancellors are not there. How innovation can come there? And industry is not getting adequate funds. In America, National Science Foundation annual budget is $28 billion. Do we have that kind of funding here? Without investing on innovation, how do you expect any innovation here, sir?
Absolutely.
We have no labs for brain. We are very methodical, intellectuals, excellent people, but where are the resources? Government should come forward. They should invest more into science, more into education. They spend all the money on the defense with the fear of one Pakistan or one China. The future wars are not going to be missiles or the anti-aircraft, whatever it is. They are going to be biological wars like this only. COVID may be a war, biological war, we don't know. Spend money on education, universities, and science. Liberally fund all the industries. See, Moderna got $500 million from US government. What is that our government has given to any own industry here? No, they have not given any money.
Absolutely.
Gates Foundation came forward and given to Serum Institute.
Correct.
But where is our funding? Where is our thinking?
Absolutely.
Krishna, you can add.
Lead me to ask the question back to Professor Vishwamohan Katoch. Are there any policy interventions that you think you see from looking from the governmental angles in terms of how do we make this industry a bit more healthy? Because from looking at the global practice, be it Gavi or UNICEF or others, at least in terms of their larger vision, the healthy markets framework, where all the stakeholders, there is at least an allusion and a stated effort towards making stakeholders a little more healthy in the long term. But I'm not very sure with whether the enablement in India, what all are the thoughts in government policy making. If you could just interject, it might be value adding for the conversation.
Lakshmi, actually, see, I've spent more than 10 years, in creating the policy documents so that, the industry becomes healthier. Correct. Because industry has to be strong. Correct. The industry has to be vibrant. Its returns should come out of it. So a industry which has to feed itself cannot survive. That's what the example of the APIs came, the fermentation came, because all my reports, they dealt with this issue only. So the self-reliance of the industry, the support from the government in all ways, whether taxation, the support to the R&D, the incentives, it's a huge list actually, which the industry initially gave, then we also collected and we also came as a policy documents, which the government accepted actually. Right. But then the question arises, how much is it should be put into the practice as early as possible. Now, COVID crisis, everything has come together to streamline the systems, for the trials, for the giving approvals. But the point what Dr. Reddy is pointing out, that the support in terms of the money again has to be there. Actually, you have to find the mechanisms for not for the COVID alone, for the all times to come. Because if you see, India has moved from a nation of traders to manufacturers to innovators. Now innovators back to traders. Now that process has to be nurtured by government. There's no question, nobody else can do it, I tell you. Okay? Whether the governments from where it collects the money, whether it makes the policy, so it invests into them the production also. It makes advanced purchase actually. See, okay, this is done ready. We are going to purchase. We are going to invest into it. Right. So that health of the industry has to be made healthy actually. And the same way what Dr. Reddy's point is, they support the innovation chain, from the universities, medical colleges to the industry together. So you fund a groups actually. So these are all it's a consortium of three stakeholders, like the industry, the medical college, the state system, university. So you fund coalition, okay? So that means it's for a product, it's for an output. All those things have been captured in the various documents. I think the Niti Aayog is also seized with many of them. But the time is, that we should use this opportunity of today to put them into a action actually. So tomorrow it does, see, because ultimately what he's saying, that you cannot live in uncertain times. You have invested, you have shown that you can innovate. For example, they said Dr. Ella, I know him for so many ages. I know all the people who are there talking today. The question is, you invest into the ideas, you invest into a process, you and do it. The Serum Institute has done many examples. So that all of the people sitting today in the panel they have created there something, So then it's to be nurtured in a chain, and that commitment has not to be it has to be a very formal commitment. Okay, well, this is this is what the state system will do. This is what you will do, and this we will get actually. So I think that's for the COVID also. There's no choice on that. But then, this dream should not fade away, I tell you. But the point, I think, is a lurking fear in the mind of the people. As the euphoria goes, where we will be. Okay, that is a realism, actually. So either the people will perish or they'll survive. But then you say, oh, we don't need it. But that, it can't happen that way, actually. Right. Ultimately, you purchase the guns. They may not be a war, actually. Okay. But you purchase them. You invest into that. So this same things to be done for the health actually. Healthy nation is a must actually. So right from my years as a secretary to the later years, I've been part of 3 documents at least led by me. So my thinking is very clear. And when before I departed, the last report has been accepted by government. But then the question is coming of is implementations, how fast, how benefits they reach, how it becomes a part of the system. But today's questions are all centric on a vaccine and the current vaccines, there, which one to choose, how to roll them out. But the generic issues cannot be sidelines, I tell you. Because if the generic issues which are required for the health of the industry, a healthy, vibrant industry, which is honestly, you nurture it actually. You cannot survive, the nation cannot survive without it, I tell you. This is something, it is not a today's phenomenon of selling something or a maybe 60%, 70% that tomorrow you may be 6% on low. Okay? What do you do then? Okay. So you will never remain 60% all the time. This is the advantage for a time. Okay. But you may become 100% also. You may become 90% also. So even to sustain at 60% has to be driven by investment into policy, environment number one, which is happening today. Then money, then commitment to purchase and keep the nurturing the industry healthy. That's all. That's I'm very clear on that. No second line. Yes.
Absolutely, I can't agree with you more. It's just that, like, government is such a complex machinery. Many times, lots of good work, people like you put it across. In terms of reaching the industry, sometimes there are operational hassles. Just to allude to the specific context that I was referring to, if pharma industry is about 24 billion or 25 billion, vaccine will be a low single digit out of that in Indian market. I'm talking about Indian market. And out of which the retail will be a fraction of a digit. Yes. Now, if this is the kind of a scale at which we are operating, now, if this is what is it, with people wanting to, I mean, if 17 rupees, 5 diseases can be prevented for whole of a life, if that is what is the scale at which the benefit, the cost versus benefit equation looks like, there is going to be some amount of appreciation for it. But how the policy enablement can happen today, many of the vaccines for a retail, if they are in price control, it just doesn't cut the ice. Vaccines are being given free of charge by government to every last citizen. And however, transportation cost could be 100 times, but then if whatever is the vaccine, it's being given free of charge. But when it comes to the question of less than 1% of the volume to be spent to disposable income people who are willing to pay, it needs to be under price control. This we need to contrast with our atta, which is going to be essential, and salt. These two are so basic to human life. Those are free priced. An Annapurna atta, Tata salt can sell at 25 rupees, but 5 antigen vaccine, like Anand Kumar mentioned, should sell at 17 rupees because that is the way the prices are being controlled. It looks a bit somewhere policy articulation is fine, but how do we get this to be, obviously this is a COVID track.
Lakshman Energy, I think this question I'll answer in a very different way.
Right.
See, I cannot say how that 70 rupees bid that has been evaluated or assessed actually. But
right.
To be truthfully, there is a problem. There is a problem. No, this kind of price fixation, if it's done by the government or by anybody who has calculated it, there is a problem. And what is that problem? I really don't know because I have not assessed that actually.
Sure.
But the same way the price war in the industry, airlines, how they one after another they collapsed.
Correct.
A price war has not to kill each other actually. It has to be something which is sustainable actually. So the same way for the vaccines, for the drugs, I'm telling you very clearly, the gold line is that people don't exploit anyone. So the price control is to say that industry, if somebody in the industry wants to exploit, they don't do that, but they survive, they grow. So that those are to be realistically assessed. I'm not supporter of the choking the industry. That choking the industry is suicidal. I tell you, it is not acceptable position actually. Which now, as an Indian, as a scientist, as a doctor, I will never accept that actually. It has to be realistic. But I'm not passing any judgment on any particular figure. But it has to be realistic. We have to see a growth of the industry. We don't have to see that. Let them go to hell. We don't care. No, you can't be that way. Yes.
Absolutely. I can't agree with you more, sir. I think we are coming close to the session coming to, but I really must thank for all the participants, panelists and the seniors in the industry. Speaking of their thoughts and peeping into future and giving us a perspective. And I'm sure I am enlightened on many of the subjects as much as all the viewers here. And I really must thank everybody to have such a wonderful participation. And as and when we are all eagerly waiting, as and when the first vaccine will be in the market, and we are all eagerly waiting, and our program machine, because in our internal consultations, one of the things which came up was also that in the last 1 or 2 years, the amount of large scale campaign programs that have got delivered, a testament of our, as a country, our ability to deliver vaccines to large scale people. But again, this COVID being for every individual, about 135 crore people, its challenge is one notch above, but I'm fairly sure our program machinery is all well geared up, and then we look forward to, and then not just we, the 135 crore people, or even 700 odd crore people across the globe are eagerly waiting for all of us to contribute. And I must really thank you on this note for your excellent participation. Thanks for the opportunity.
Thank you.
Thank you all. May I also bring to the panelists notice that a couple of questions have been put in Q&A box. Kindly feel free to answer them at your convenience as they're open to everyone. The upcoming panel discussion is on preparedness for the distribution of emerging COVID-19 vaccines. And it is my pleasure to invite Devendra Mishra, Executive Director and Co-founder BSMA, to introduce the panelists and moderate the session. Over to you, Devendra.
Thank you, Nidhi. We are indeed privileged to have a panel with extraordinary eminence, knowledge, experience, and diversity to address the most formidable challenge that our country faces of distributing the vaccines to the 1.35 billion citizens. To set the foundation for our discussion, I'm going to request a friend and a great executive to share with us his point of view, and he is none other than Dr. Harish Iyer, the Senior Scientific Advisor and the country head of India for the Melinda and Bill Gates Foundation. Dr. Harish Iyer, would you be kind enough to get the ball rolling? And then I will request Dr. Anjan Ray to follow him right after that. I can see Professor Anjan Ray. Dr. Ray is right there on the screen. As you all know, he is the director of the Council of Scientific and Industrial Research, and he brings to us the glimpses of that great institution that has served India for more than 80 years. So Harish, please take it away.
Thank you, Devendra. Hopefully you can see my slides and hear my voice.
We can see the slide, we can hear your voice, and we can see you too.
Okay, thank you so much. It's so wonderful to be here. You have such a stellar panel before. I don't know whether we will be able to match it in terms of the deep experience and capacity they have. I want to start very much, in some sense, continuing the previous conversation, to place on record my appreciation for what the Indian companies have brought into their pipeline. They're truly heroes in my mind, for not just for India, but also for many of the lower income countries and the lower and middle income countries. They've always been heroes. And many of the people on the panel are my personal heroes. So it's really I'm a little bit awestruck following them on this panel. I will talk a little bit about our preparedness for supply, talk a little bit about the global situation where we are. I have only 5 slides, so hopefully I will get to finish in the 10 minutes allotted to me. I want to start off by saying, where are we today? Right? We've had these fascinating new results this week and last week. Yesterday, we heard that Pfizer has a vaccine with an interim 1 week post second dose efficacy of 95%. Right? This is really the number on that slide is wrong. It's 90% was what was before. Yesterday, it became 95%. But there is a challenge. It's stored at -80 degrees Celsius. Right? So that's clearly a challenge for us. It has only 5 days data so far at 2 to 8 Celsius. And of course, here the doses are 2 doses, 21 days apart. Let's look at the Moderna vaccine, which has also been in the news. That has an interim efficacy data of 94.5. You could say both vaccines are at 95%. But that's stored at -20 Celsius. It's got 1 month stability at 2 to 8, which is what we normally use these vaccines and they are stored at. And here it's a slightly different schedule. It's 2 doses, 28 days apart. You can already start thinking about why there are issues with this if you want to use it in a country like India. The US has, the US, of course, has a lot of money. They've got a very powerful setup. They've established what it takes to put this all together. I have shown you a couple of pictures at the bottom. You're talking about ultra cold freezers, very expensive capital equipment. These need to go on planes. They're most likely, these vaccines will be single dose vaccines. It's hard to imagine that you will have a multi-dose vaccine. It'll probably be PFS, single dose. So that's my expectation. So obviously for any country, a country such as India, these companies may not have sufficient capacity upfront to supply. We know Pfizer has talked about more than 1 billion doses coming in next year, but it's hard to understand how exactly the presentation will look for countries like India. And again, the -80 degrees Celsius clearly is a big problem. So there's a manufacturing capacity limitation. Who will they supply first? And then there's, of course, a storage capacity limitation. How can we store this in India? And I think the government at this point is looking at storage capacities as -20 and -80, but I'm not sure they're very serious about the -80 certainly. Then let's not forget the Russia vaccine, the Gamaleya vaccine, which also actually showed up with the interim efficacy greater than 90%. I believe it is stored at 2 to 8 from my understanding, but this 90% data is on much fewer subjects. I think what they announced was about 20 subjects turned positive. It's a very, very small number of people turning positive in such a large study. The other studies have had numbers like 90 people turning positive, 150, 180 people turning positive Pfizer in their final data. So still kind of small numbers when you talk about tens of thousands. But here again, what is the complexity with this Russian vaccine? It's a 2-dose schedule with 2 different vaccines, which means basically you have to have 2 different vials. One is the AD26 vector and another one is the AD5 vector. So we need to understand how will they do this 2 different products in a cold chain, complexity of that. It's not clear what the long-term visibility on supply is from everything I've tried to understand from industry. But the one advantage over the previous 2 vaccines we saw was 2 to 8 Celsius. So when you come to the Indian manufacturers, there are 2 leading phase 3 contenders. The Serum's first vaccine is the Chadox vaccine. It's undergoing a phase 3 trial, probably with the idea of bridging to global data. So that's a new approach. We're trying to do a fast track approach. The Bharat Biotech's phase 3 trial is going on with the inactivated whole virion approach. And also, it's a large number of subjects. It's an expensive trial. I think they're getting support from the Indian Council for Medical Research and DBT on some of this. What are the reasons I'm excited about both these companies and many of the other companies that are also on the call? They both have a lot of experience supplying vaccines to LMICs and LICs, which is of deep interest to the Gates Foundation. Also, they're likely to know that it makes sense to make multi-dose vials and which can be stored at 2 to 8 Celsius. I want to also add that where the global data has been helpful is that it tells you now finally, hey, you can have a vaccine that works. Until now, nobody actually knew if a vaccine would work, right? We all assumed, in fact, many of the early conversations were people saying there's a 25% probability it might work, 15%. This is completely new technology. mRNA completely new, both completely new. The adenoviral vector completely new. I know there's people who've done other phase 3s and so on and so forth, but it's really actually quite a new technology. It's nothing like the pentavalent, for example. The inactivated virion approach, something similar has been done for polio, but again, it's a exciting. They have a new exciting adjuvant which they're using in the approach that Bharat Biotech is using. And yesterday night, actually, there was a very interesting talk on what are the correlates of protection. We suspect right now It'll probably be neutralizing antibody level, but there may be other things. So now the question is, will they both, first question everybody's looking to see, will they both these companies get emergency use authorization by both DCGI and WHO? DCGI very important for India, but WHO very important for other parts of the world, which will depend undoubtedly on many of the Indian manufacturers. And of course, others are following behind quickly. There is Genova, Zydus Cadila, Aurobindo, Indian Immunologicals, BioE, which are in earlier stage trials. What are the challenges? Everybody's heard the word unprecedented many times this year. It's a very difficult situation for regulators and vaccine program officials. Many of the questions were asked already this morning in the earlier sessions. So I think it will be science and data-based trade-offs on immediate protection so that we can get people confident in the economy versus long-term protection. None of these have long-term protection data. By definition, long-term protection will take time. One of the challenges of long-term protection also is that you need placebo arms, right, to continue on to get the understanding of what's the long-term efficacy. But if the vaccine is approved, do those people on placebo arms have to be given those vaccines? Does that ruin, in quotes, the biomedical research requirement of getting, how do you get two-year data? You can only get 2-year data if people have continued on the non-vaccine arm for that equivalent period of time and accrue cases. Very complex question for regulators, ethics committees. How long will the protection? What about the new technology? The adenoviral vector, the mRNA certainly is new technology. In Bharat's case, the inactivated vaccine is somewhat understood, but what's the kind of long-term experience? What's the stability data? I know that many of the companies are keeping stability doses on trial, continue to keep stability, but we won't know till we are very end, close to the end of the game, whether you will have 2-year stability or not, whether you will have 3-year stability for such a vaccine. At this point, it has to be by definition a limited amount of stability. And how will the cold chain handle it? One of the things in the supply chain that was a great innovation was the use of VVMs, vaccine vial monitors, which would change color if the vaccine went to an unacceptable level outside cold chain. It seems unlikely to me that these vaccines will have a VVM on them because we don't have enough stability data to say what VVM they will fit. So that's something that important to understand. And then we also went back to the question earlier about who will get which vaccine, right? So suppose there are 3 vaccines approved, who will get which vaccine is a key question. New technology could help to supply, strengthen some of these issues. We are talking about EVIN, which the government of India is looking at as a digital solution, and which we know already has reduced stockout significantly for the existing UIP vaccines. It will also be used to enumerate and map residents who need to get enumerated and immunized. My last slide. Of course, the public is keenly awaiting a safe and efficacious vaccine. When there is a EUA, it's important to have transparent sharing of safety and efficacy data. I'm seeing a lot on social media about distrust in other countries. I think India has one of the highest levels of trust in vaccines, but these things can spread globally, this distrust question. Are there simple operational guidelines to use? Will it be a simple operation to execute? It has to be something that's simple. Training of the cadre to make sure that they are available and they can handle the supply of the vaccines at the appropriate time. Cold chain I talked about. Communication, important question. Will prominent public faces be immunized along with people at the bottom of the pyramid like healthcare workers, right? So you build confidence that people do trust it. This is the opposite of rich people who can pay lots of money getting the vaccine first. Can also prominent people get vaccine, show that they are also confident on it? And then a couple of more questions, points to consider. Ability and mechanism. I think the government is putting in place an ability to quickly investigate AEFIs that are serious in nature beyond sort of injection site pain or soreness or mild fevers. And all along, I think while we're thinking about the supply chain, we need to stay with a science-based approach while keeping the needs of the population in mind. So maybe I will stop there and over to you, back to you, Mr. Devendra.
Thank you so much, Harish. Anjan is ready to go. So Anjan, will you please take it from there? Dr. Ray?
Yes, thank you. I hope all of you can see me. I will just put my slides on share. If you'll give me a moment. This is not doing what it should.
While he's sharing the slide, I just want to share a point of view that CSIR is focusing on 6 different verticals, all the way from surveillance to PPEs to monitoring. It's rather comprehensive. Maybe Anjan will give us some insights into what's being done at CSIR.
Yeah. I have sent a copy of my slides over to, let me see if I can do it from here, just a moment.
Yeah, Nidhi has a,
yeah, can I request you? Because I seem to have a little bit of difficulty here.
Nidhi, can you please help our...
Sure, sir. If I would, yeah, sure. Dr. Ray, could you please tell me where did you send your slides so that we can put on them for you?
I sent it in response to your mail this morning. Should be in your mailbox right in response to that mail. Because for some reason, this, I mean, I can see the slides, but they're not coming up on the share.
When you went to the share, did you go to your desktop or to your computer file?
Yes.
And it still doesn't show up?
It is, oh, I see. Okay, just a moment.
Got it?
Yeah, I think
this must be the coronavirus in your computer.
Right. Well, it does say that, you know, it is human to make mistakes, but to really mess up, it needs IT. So there's something. Could you get it, ma'am?
Sir, I have not received any email from you. If you could just quickly send it to me at nidhifaba@gmail.com. NIDHIFABA.
That is where I believe I sent it this morning, but I will just.
Yeah, I am unable to
find at 9:27 a.m.
And then can you see the file on your system?
I can see it on my system. Madam Nidhi sent you at 9:27. Could you check your spam inbox? From
Here's what you will do. While you look for your presentation.
Oh, there it is. Yes, it is there in the spam. It's there in the spam.
Okay.
Okay.
Sorry about that.
I'll put it on.
While we go to the presentation, she puts it up. Since I know what's on there, let me get started so as to not lose more time on the program.
Thank you.
Let me start by thanking Dr. Mishra and Dr. Iyer for already setting context with the 2 key phrases that I thought are very important to this. The first one was the phrase science-based or evidence-based distribution, and the entire vaccine program logic, which is driven on 3 fundamental issues. 1, which vaccines? 2, where must they go? And 3, how do we know that the person getting it is getting what we intended? So I like the very fact that Dr. Iyer raised the point of VVMs, because it does seem that the more stringent the storage criteria get, more important it is that there is a VVM identification for supply chain outage. Otherwise, you would have a false sense of security. And we have already seen social behavior that people today are out there without masks, without social distancing. Tomorrow, once you give them a vaccine, we can expect the behavior to amplify. Maybe you go to the next slide. Yes. So these have almost all been discussed today in the previous discussions, except for 2 items here that I see were not picked upon, so I may spend more time there. One is the supply capacity of ancillary items, and the second is a proper disposal plan for not only the ancillary items that have been used, but also the compromised stocks and post-vaccination residues. These have not been touched upon at all, so I will address them a little bit. As far as the basic ecosystem for immunization is concerned, the Indian immunization program has already demonstrated that it can be done. The scale up and ramp up of this, however, is significantly more than we have seen for any other immunization program before. And therefore, the issues will be similar to scaling up anything else. So for the moment, I'm going to give the analogy of gearing up for a Mahakumbh when one is used to just a Tirupati. That is kind of what we're trying to do. And that's why, again, even was mentioned. There is an even purposed version called CoVIN that I understand is in the works. This was presented just a couple of days ago by Dr. Vinod Paul of Niti Aayog. But let us go on to the next slide. So we don't know at this point where exactly they will fall, but we know they will fall at multiple points on this sensitivity chart. We also know, or we also believe, that the sensitivity to heat is the major concern. We don't at the moment believe the sensitivity to cold will be a problem. So if you overfreeze something, it may not be a problem except for some vaccines. Therefore, there are other things that we can do today in that -20 to +8 space that could help build capacity. So I will talk about institutional approaches to temperature management. We can do that on the next slide. Let us move on. Yeah. So here are the basic possibilities. We already see that there are no major issues in normal refrigerators, but the moment I go into the remote parts of the country, and this will interest Dr. Iyer, the reliable power supply question becomes important. So how do I produce cooling reliably when I'm down at a regional health center? So there are things we've considered as solar fridges, biofuel-driven cooling. These are options that can actually be scaled. There are a number of energy programs coming up around the country which can be dovetailed. And the issue is we get the problem out there first, we get the solution out there later. At least let us get started so that the problems are surfaced. And then wherever solutions are required, I believe we are now geared to respond to them. For instance, today, we can put up in less than a week or 10 days, a solar wind biofuel hybrid. We can put up a biogas unit. We can put up a number of things that are off grid that do not require a reliable grid power supply if it comes to push comes to shove. But as we get to much lower temperatures, the second issue comes in, what about maintenance and spares? We have talked about the supply network, but what about the supply network for keeping our deep freezers running? Now, a lot of these are today being made in India, but a lot are still imported. We have to actually put together, and we will be happy to support this from CSIR, the entire component ecosystem, a predictive component ecosystem to ensure that when something breaks down, the supply chain for that is also ready, not just the supply chain for the vaccine itself. On the transportation side, the major shortage, we already see it because we do extensive testing today, the major shortage issue is dry ice. While we will hear in the last session of the day today, I can see people like Plus Polymers already in the game, ready to present, who can do temperature stabilized transport. We must ramp up right now for all our constant temperature transport solutions. And where if ultra-low transport is required, and we know we will need every solution. So if ultra-low transport is required, we have to build and put in much more liquid nitrogen plants, at least centrally at the hospitals that are of importance. These are actually not as difficult as it sounds, but it does have to be planned ahead and some capital investment goes into every liquid nitrogen plant. Funnily, there is or not funnily, but by a fortuitous coincidence, there is an increasing demand right now for medical oxygen. And we have looked at the design of medical oxygen plants. There are more and more creative ones coming in the next few months. I know of a few in pipeline. And in any hospital, an AIIMS or a district hospital of sufficient capacity, you can put in a medical oxygen plant, take the reject air, which will now be rich in nitrogen, and the liquid nitrogen plant will then come in at much lower cost. So dovetailing medical oxygen and liquid nitrogen plants becomes a practical reality. You could put in the capital and then decide not to run it if push came to shove. So this also addresses this question that was asked, what happens if industry puts in a lot of capacity and then there is no demand? My recommendation is put in capacity at the point of use side, put in that capacity on capital, where the capital is relatively one time and the revenue cost is modest. And then if you don't have to run it, you just save that much recurring cost. That's a better design than a very large number of disposable units that you then have to collect, dispose, manage. But of course, there will be a minimum number of disposable units required for transportation, and the truth will lie somewhere in between or in a combination of these. Also, all the domestic components that need requirement, not just maintenance and spares, but actually big pieces like compressors, will also need more capacities in the country. And that's probably worth it, not just for the COVID situation, but for the long-term healthcare ecosystem, because whatever we put in for COVID will last us in good stead for many other pandemics and even for business as usual healthcare to come. We can go to the next slide. This is my, my Six Sigma engineer's line of thought. What can go wrong? We call it failure modes, and one can actually teach a one semester course in failure modes. But very quickly, if we look at the big ones, I'm not going to go through the ones that have been obviously talked about. The very big ones are on the right-hand side, the point of use. Typically, the production site and distribution network are largely institutionalized and will be managed. But once it gets to point of use, monitoring and control goes down. So quality of training, quality of remote monitoring, quality of reporting all become very important. And we call this the 6M thing, where we must obsessively check your manpower issues, your machine issues, methods, measurement, material, and all the uncertainties like Mother Nature, which include power outage and a cyclone and the pandemic itself, that your entire vaccination team goes down with COVID, then who gives the vaccines? So how do we build that capacity? How do we do that planning? How do we preempt the fact that somebody who could be a healthcare worker on the front line has to administer the vaccine, and therefore we must know 3 or 4 days behind what their exposures are. So do we use Arogya Setu to know that they haven't been exposed or are at some even moderate risk of exposure to somebody else? Can we also look at the training of the people who are administering the vaccine to make sure that they know when vaccine A suddenly has run out and they have to go to vaccine B, that there is a change in SOP? How does all that happen? This needs to be built into our thinking. We go to the next slide. This is one of my absolute favorite papers on things that can go wrong. A very recent paper in the International Journal of Medical Science Public Health, an Ishikawa diagram showing what causes delays and dropouts in immunization. This has not been discussed, and I want to spend a minute or two on the slides. So when I go into villages, and during the WHO smallpox eradication campaign, my father was heading the campaign in Bihar, and I was a 12-year-old who went down there to help him because he didn't have enough people. So I cycled down from Gaya to Jahanabad, 40 kilometers, and I was in the grassroots. And what it told me is this, that you can overcome everything technically, you can't overcome beliefs and social issues technically. There were people who would say, मुझे खून देने में डर लगता है, मैं बकरे का खून लाके देता हूं. So we have to overcome that line of thinking. We have to overcome disinformation that spreads via social media, where somebody will start spreading for whatever reason, whether in belief or whether in disbelief or whether for any other reason, something that says, when they inject you, you don't know what else could you be getting infected with. Okay, that is why the OPV was so successful. It was oral. It did not require intervention. So we have to overcome all of this. Now also booster doses, so lack of reminders. Migration. So you give a person a dose, but he's a migrant worker and he suddenly finds a job in the next city. He goes off. So what happens to him? All of these issues have to be considered. And because we talked about the different income strata, those who can afford it, upper class, upper middle income categories, will pay for it if they require, just as they pay for testing today if it's required. But once we get to the LMICs and LICs, we have an issue, particularly at the social and individual family level, that the supply chain needs to consider. And the supply chain needs to encourage through staffing of local people. I would strongly encourage a model where we staff with local people so they can talk in local language, allay local fears, establish local concerns, and do an enormous amount of internet-based connective training in a multi-tiered manner. This is the non-technical factors that I believe will ultimately determine whether we succeed or fail as a country. We can go to the next slide, which I believe is my close to no. Yeah, these are my last slide. And apart from the integration with different initiatives, making sure that we are screening out those who don't need a vaccine and we know how to screen them out, making sure we're establishing the infrastructure, developing essential IT systems. For example, we have a small IT platform called Arogyapath, where you can actually just go in and see what medical supplies are available where. I would encourage all medical players to register on this. And it gives you a PIN code delivery system, which we eventually plan to make a GPS distance-based delivery, maybe linked with players like Google, so that you can tell where the nearest vaccine is. Or the nearest vaccine point knows where the needy populations are. How do we match that? I also think that we mustn't forget that the country has got used, particularly in the smaller towns, to scooty-based last mile deliveries for food. We must link up to scooty-based deliveries and expand that to drone-based deliveries. The faster we can get vaccine from point A to point B by methods like these, the less time the vaccine spends in transit, in uncertain transit, the better it is for all of us. The last point, which I already heard this big debate on government investments in the vaccine value, I would say it is investments for everybody. India is also painfully low on percentage investment of industry in R&D. We do see that increasing from the Department of Scientific and Industrial Research, where CSIR sits. We see the number of in-house R&D units increasing progressively, so we see that number is improving. But the average in-house R&D unit outlay is still well under 1%. So there needs to be more plowback as well of mature businesses. And we can see some very clear new trends emerging. One is immunomodulators and indigenous vaccines. We've talked about the indigenous vaccines, but immunomodulators are now getting tested. PGI is testing Sepsibac, a mycobacterium species, now, even as we speak. We have to build more cohorts. CSIR will be very interested to participate in more cohorts, both from an individual sampling standpoint of view and from air and sewage sampling standpoints, where we are making considerable progress. And maybe in a future discussion, we can report these. And finally, some off-the-box thinking. I see my colleague, Dr. Chandrasekhar from Sister Institute, IICT Hyderabad, is on the attendees. And he pointed out to me that in the area of therapeutics, deuterated drugs actually have some very interesting benefits. Similarly, vaccines in D2O, which require ultra-cold storage, don't require ultra-cold storage in D2O. So maybe in this country, we could invest in deuterated drug and deuterated water vaccine reconstitutions so that the cold chain can be ameliorated or mitigated. With that, I thank you for your time and listening.
Thank you, Anjan. May I request Frank Toussaint to jump in, Rajiv Nath to jump in, and Deepak Sapra to join us as well. Now I can see them all. Let's see, I can see Rajiv Nath, the Managing Director of Hindustan Syringes and Medical Devices. I can see my good friend Frank Toussaint, the Managing Director of Biolog US Europe. And where is Deepak? Deepak Sapra, the CEO of API and other devices at Dr. Reddy's lab.
I'm here.
Yeah, wonderful.
Wonderful.
All the long vaccines, and we have not talked about the ancillaries, the other components that are vitally necessary for immunization. So may I call upon Rajiv, who is probably India's #1 provider of syringes and other supplies, to enlighten us as to what some of these challenges are. Rajiv, please.
Thank you, Mr. Mishra. It's nice catching up with you after a couple of years. We met earlier at Hyderabad.
Yes, sir.
Thank you for this opportunity. It's a very interesting conference. I've been listening in since the morning. I wear multiple hats, so I'll be speaking as the MD of Hindustan Syringes and Medical Devices, the maker of the syringes, which is part of the campaign. I will also be speaking on behalf of Association of Indian Medical Device Industry as the forum coordinator, and I'm also the president of the Syringes and Needle Manufacturers Association of India. So multiple hats, and then I will just take you along as to what are the challenges we've noticed in the last few months, what we've tried to communicate to the government, and how we are trying to address them in partnership with the government and internationally also outside the government. So first and foremost, in April beginning, I reached out to Dr. Ella in Hyderabad, Bharat Biotech, Mr. Pankaj Patel in Cadilla, and Mr. Rajiv Dere in Serum Institute to ask about their plans for the COVID vaccine and how they plan to package it, how they plan to deliver it. And they were very key questions for us that we had in our mind, that which of their COVID vaccinations candidates they're working upon would be intramuscular, which would be intradermal, which would be subcutaneous, which would be intranasal, and which would be oral. Because each delivery would require a different kind of syringe and maybe even a different kind of needle mechanism. So I was quite encouraged when they all told me that their primary focus currently, top of the shelf, is on intramuscular, which is the most common way of delivery of using a 0.5 ml AD syringe. Having known that encouragement, I reached out to WHO, to UNICEF, and the Government of India right in the end of April, and submitted to them that the world has about 8.5 billion people. India has 1.35 billion people. Even if 2/3 are going to be injected with the vaccination, and that time we were talking about single dose. So we quantified that we've been getting at least 900 billion syringes for India alone. And at that period of time, as HMD, we were having a capacity to produce 44 million syringes per month. That means 525 billion pieces per year, for which we were already a major supplier to UNICEF worldwide for the immunization plans. Now, immunization had become completely stuck in India and partially worldwide. Not so much in Africa, but more so in India for 3 months. So on one hand, the government was not buying, or what they were buying or they had bought from us, they were not picking up. So we had a very peculiar position that we had more than 120 million syringes lying in stock with us, which were not being picked up by UNICEF and not being picked up by Government of India. And the big question for me was, shall we keep on producing and where do we store that? And the country and the world is not thinking about stockpiling, and tomorrow there will be vaccines available, then how will we go around doing the injections? Now, as the largest supplier worldwide, the onus was on us, like it's been on Serum Institute, that they took the big gamble, we also had to take the big gamble, and I was inspired by their initiatives. So, while, of course, I communicated to the Health Secretary, to Pharma Secretary, everybody about our concerns, and our plans that we could ramp it up from 525 billion to 800 billion by the first quarter of 2021, and then 1 billion by middle of next year. There was a limited capital available with us and a limited space available with us, whereby we could ramp up this capacity. So the challenge was that post-COVID, suddenly the tap would be off. And once the tap would be off, we'd be left with a huge surplus capacity, which UNICEF, WHO, and Government of India may not be buying. So who will take care of that capacity? And if they will not be taking care of the capacity, there are no commitments, then who's going to help us with the capex? Now, that's one question which has never been answered, and that's been our biggest challenge. So even though we can do it quite cost effectively, and that we wanted only about 80-90 crore rupees investments, and we were asking nothing more than a contractual supply chain commitment of 3 years' time, either from the international bodies like PATH, or from UNICEF, or from Gavi, or from Ministry of Health in India, that answer has not been given to us to date. So we could only go forward with our limited capacity risk as what we could take on as a corporate company on our own heads, and then leave it for the wise policymakers and the public healthcare experts in the various government and WHO that when the crisis will really build up, they may come back to us. The first to come back to us was UNICEF and WHO.
Right.
And in July, August, they started talking to us. And by August, they realized the need for the stockpiling. And they released an order to us in addition to our existing order of 160 million pieces per annum. We have a 2-year LTA with them. So in addition to 160 million pieces we had to supply to them this year, they gave us an additional order of 140 million to be delivered by December. Now, we already had, I told you, 120 million in stock. On top, we had to make another 140 million.
I'd love for you to wrap up as quickly as you can. We have very limited time. We really get the picture very, very well.
Okay.
I mean, what you're doing is absolutely extraordinary.
Sure.
We understand, and we understand the capacity issues. What I'd like to do is, all day long, we've talked about vaccines coming from overseas, while 3 or 4 or 5 Indian vaccine companies are working very hard. I'd like to approach my friend Frank Toussaint in Brussels, Belgium, where in his neighborhood there is AstraZeneca, there is Oxford, there is Novavax, there is BioNTech. So Frank, how are you going to help us with this pandemic that we face in India?
Yes, thank you very much, Devendra. Actually, that's interesting to compare where I'm located, Belgium and India, because nothing is comparable in terms of size, except I would say the vaccine industry, with the presence of GSK, Pfizer, Janssen's, Novacep manufacturing for AstraZeneca and some others. So actually, we're close in terms of challenges. And what we can learn is that we have to build more bridges, not only in the air freight industry, which is a huge challenge, maybe the challenge of a lifetime, by building capacity at airport. And I heard that Mumbai is prepared for that, but we have to really get ready in a very short time in terms of capabilities of cold chain facilities, working with government in qualification, validation for the pharma industry. What we can really do is also doing more tech transfer in terms of cold chain management. Really the capacities that's now, it is increasing. Let's take as an example vitrification, which is an opportunity for ultra frozen vaccine. And also in the capacity to getting prepared in a very short time. I remember in March, April, we developed a WFP, WHO hub in 3 days in the worst period of the pandemic. So that's also the capacity to react very shortly. But what we need is that we need also more cooperation between authorities, between all stakeholders, from the packaging, the manufacturing, the governmental, the politics, because that's a global challenge and where we have to build more bridges with all the stakeholders. So that's maybe something we can learn from each other, put every stakeholder around the industry to make it happen. And we see now that the supply chain can be a very also differentiating element. We don't talk that much about the vaccine. In the presentation of Dr. Iyer, we mentioned about the stability of the product, the capacity to store at ambient temperature during 5 days or more at 2 to 8. So on that matter, I think that these topics will continue to evolve, and we need to address the challenges, by learning and doing all together. That's really one of the solutions on the short term, because that's a new situation for all of us. So we will need to be agile by changing more altogether.
Really appreciate your viewpoint, Frank. And this conference has given us a platform where we can really cross-pollinate ideas and we can connect with each other. And I'm really hoping and praying that collaboration is going to begin from this platform that we have created today. I want to go to someone who brings a very interesting proposition, and that one is no one other than Deepak Sapra, who, as you know, is the CEO of API and Services at the Dr. Reddy's Lab. If I'm not wrong, Sputnik V is a vaccine being developed by Russia, and Reddy's lab is very integrally involved. Deepak, would you be kind enough to shed whatever light you can on that vaccine and how
Sure.
it is being planned? Thank
Sure.
you, Deepak.
Thank you, Devendra. Am I audible?
You are.
Thank
and I
you.
can see you too.
Thank you. And first of all, very grateful for inviting me to this extremely illuminating discussion. What I would like to share with the group is that we are currently working on Sputnik V. This is a collaboration between Dr. Reddy's and the Gamaleya Institute in Russia through the Russian Direct Investment Fund. Now, Sputnik V, as many of you are aware, is a vaccine based on the human adenoviral vector-based platform. There are 2 doses given 3 weeks apart. And broadly, I think the idea is to use 2 different types of adenovirus vectors. We're using the ADVAC26 and the ADVAC5 for the first and the second vaccination so that it boosts the effect of the vaccine. The other thing which is important for everyone to know is that the use of human adenoviruses as vectors is fairly safe because these viruses are the ones which cause common cold, are not novel, and have been around in the human population for thousands of years. The other thing I want to talk about the vaccine is the status currently. This is amongst the few vaccines being spoken about, the ones approaching the end of clinical trials and the start of mass production, also not just in Russia, but also on WHO's list. Hello?
Yes, we can hear you.
Yeah, okay. Okay. The ongoing post-registration trial is on. The trial is on in Russia, the phase 3. This is about 40,000 volunteers. The trials are also on in the UAE and in Belarus. The trials in India are starting very soon. This is a phase 2/3 adaptive design trial, and we expect the entire set of trials to be completed in the next few months. Now, coming to manufacturing and supplies, the manufacturing will be a combination of a product which is made in Russia and made in India. We are working out the details, but I anticipate that initially we might get a certain number of doses from Russia, while at the same time we are transferring the technology into manufacturing sites in India and ramping up our production capacities in India. The process of technology transfer is currently underway. And as we do that, we are also engaging very closely with the regulator in India and also with the manufacturing sites to accelerate the process of tech transfer. One site is currently in the middle of the tech transfer, and another site is likely to start by the end of November. The storage of this vaccine is currently at -18 degrees. That is how we have the stability. We are working on the cold chain in collaboration with key partners. And we are also working on a 2 to 8 degree version of this product, which we expect should be ready in the next couple of months. As of now, we are making sure that we are fully prepared for the -18. And from that standpoint, we are configuring the supply chain, and there's a lot of preparatory work that is underway. The process flow that we have envisaged is likely to be from the manufacturing location to our global distribution center, packing the product in insulation boxes. These insulation boxes go to reefer trucks. Secondary warehousing might be required in certain cases, depending on the distance and the logistics. And based on that, we will deliver the product to the last mile. Now, a lot of people have spoken about the logistical challenge. I just want to share a light trivia. Recently, I was reading an IATA report that to vaccinate everybody in the world for coronavirus with just 1 dose would require 8 million cargo aircraft or their equivalents in trucks and reefer containers. So this is certainly not a trivial issue, but this is an issue which we will all have to work on and which we are all working on. Before I close, there are just 2 other points I want to bring to the attention of the group. These 2 points we're working on. One of them is on manpower and training. This is something which is unique for us as an organization. So we are working on upskilling our manpower, especially those who are handling the supply chain. There are guidelines that we are creating for people to work with with products at these kind of temperatures. And the other thing which we are trying to do is that we're trying to work with some companies to handle counterfeit and vaccine packaging and bring in certain measures like serialization, geofencing of transportation. We're also talking to some people on the blockchain platform. So that's a brief about what we are doing, and I hope it gives a perspective. I'll pause here, Devendra. Happy to take any questions or clarifications. Thank you.
I think we are just running out of time, and I know Nidhi is going to shut me down. So I just want to say thank you all. We could have gone on for the rest of the day, because the question I really wanted to ask each one of you is, what is one thing that keeps you awake at night about the COVID distribution challenge? Maybe there are many things. I just want you to think about that. And maybe after this conference, we will have that discussion. Let today's event be just the beginning of a long journey and a long discussion as we deal with this great challenge that our country faces. So thank you, all of you, the panelists. Hats off to you. Mighty grateful. Nidhi and Vishal, take it away, my friend.
Thank you.
Thank you.
Thank you.
Thank you, everyone. Next, we have panel discussion on cold chain shipping, storage, and last mile delivery. May I invite Mr. Vishal Gandhi, founder and CEO, BioRx Venture Advisors Private Limited, to moderate the session. Over to you, Vishal.
Thank you, Nidhi, for the introduction and the opportunity. Good afternoon, good evening, and good morning to all the participants across the world attending this virtual conference. It's my deep honor and a deep privilege to moderate a session on most impactful theme, and which is known as cold chain shipping, storage, and last mile delivery for the COVID vaccine. I must say that we couldn't have had better panel than this. Today, the panelists will share their insights on various nuances of cold chain shipping, storage, and last mile delivery. I would now request each one of the panelists to introduce themselves briefly. So over to Rahul. You have to unmute, Rahul.
Thank you, Vishal. Good morning, everybody. Of course, good afternoon, good evening for those at different time zones. I am Rahul Agarwal from Coolex Cold Chain Limited. We work extensively with the pharma companies in India for distribution of their temperature control products, and happy to be part of this panel. Thank you, Vishal.
Sure. Thank you, Rahul. Over to Masanari.
Hi, this is Masanari Arai, CEO of Keep Corporation. Key is providing Internet of Things based platform, and our focus right now is cold chain monitoring in India. We have a customer in India like Guba is using our technology for all of their facility, and so that's Key Corporation focus. And at the end of the day, we really want to reduce waste and destroy of the products, in this case, vaccine.
Thank you, Masanari. Over to Mahesh.
Yeah, greetings, everyone. Delighted to be part of this panel. I'm Mahesh Balgat. I am the Chief Operating Officer for Syngene. We are a CRO and a CDMO focused to work on many different areas in terms of technologies and sectors, but primarily, of course, in the biotech and the pharmaceuticals area, with facilities to deal with both biomanufacturing as well as small molecule manufacturing. I come from an industry background of being in the vaccine industry for 10 years and biotech industry overall for about 20 years.
Thank you. Manish, please take away.
Thanks, Vishal. First of all, pleasure to be on this panel. I'm Manish Sanghai. I am a Senior Director for the Laboratory Solutions Division at Thermo Fisher Scientific, and we as a company focus on providing laboratory solution services to the entire pharma, academia, and industrial segment. Today, we'll be focusing on what we can and how we can contribute in the fight against pandemic with our cold storage solutions. So happy to be part of the panel, Vishal.
Thank you. Last not the least, we have Dr. Ravedkar from Serum Institute. Over to you, Dr. Ravedkar. Dr. Ravedkar, can you hear us? Seems some technical. Okay, yeah. Over to you, Dr. Ravedkar. Please go ahead. You need to unmute. Dr. Ravedkar, you need to unmute. We can't hear you. Yes.
Can you hear me now?
Yes, good to go.
Yeah. Good afternoon, everybody. See, I'm Dr. Ravedkar from Serum Institute of India. I work in Serum Institute for a very small period of 48 years. And I've been the student of, vaccinology right from beginning, and even today also. I look forward to a lot of learning from this August gathering today we have in this beautiful webinar. And, I had a pleasure right from working from the launching of the first vaccine in Serum Institute till today, till the COVID vaccine going on now.
Incredible.
Yeah. So I will start speaking on the cold chain shipping, storage, and last mile delivery. Of course, this is not really my forte, but I will, being in the line for so many years, I will try to share my experiences and views on this. And, this is a last stage because I've been mainly associated in manufacturing and testing of vaccine. But nevertheless, I have worked in, thanks to our chairman, Dr. Poonawalla, and our CEO, Mr. Adar Poonawalla. I worked in almost all the areas, so I can speak on this. I think this cold chain shipping, storage, and last mile delivery is more talked about. But luckily, as Dr. Renu Swarup explained in the morning, this is very well established in our country because I think India is not only hub for manufacturing, but also the vaccination program in India is also implemented by Government of India efficiently. The latest example was that MR vaccine, which was done last year. It was a beautiful campaign done by Government of India, covering children up to certain age with the MR vaccine. Can I have next slide? Yeah. Now, regarding the vaccine quality and the cold chain, the cold chain is, as you know, is a last in the process, as we said just now. But it is very important process because ultimately the cold chain is the one which is delivering the vaccine in a assigned storage temperature, which of course depends on the stability studies and also the storage temperature of the vaccine. And so it depends on, in case of Corona, as you know, there are various technologies. I'm very happy that a lot of technologies, even the old till latest technologies, which are not having any vaccine in the market, like RNA vaccine, are also being tried. So I think there are advantages and disadvantages like any other thing, of course, in all the technologies, but nevertheless, we'll have some solution. It is not a which solution, and it is not a which company which comes out first or rather second. I think it is I look at a long term, in a broader view of serving the human mankind. That has been always my view. And, this is a what I call as a philanthropic business. So vaccine is we are all in a philanthropic business. So we should be all proud of this business. And to assure the product quality of the vaccine, cold chain is a complex biological process, and ensuring consistent safety and efficacy of a vaccine has long recognized as an essential element in successful program, disease control program. And, efficacy of the vaccine, mainly efficacy, depends on the storage temperature. And we have seen now, as we are discussing, this webinar is more focused on corona. So we are speaking about corona. So if we see, there are various vaccines coming which are requiring storage at 2 to 8. And also there are some vaccines which are requiring -20, as our friend explained just now about Sputnik. Then there are some vaccine like RNA vaccine which are more unstable but very fast in development, requiring -70. So all that makes this little complex. But I think can I have next slide?
Dr. Gravitker, you have about 3 minutes to go with your presentation.
Yeah, I know. Good, you reminded, of course, because I got a habit of speaking. So
you have 50 minutes to complete our task.
Yeah, and second most important thing in this is cold chain is a complex process, and we'll have to have more training of the people. And I think, as I said, the cold chain in India is very well established, and because of the vaccination program, and Government of India is also, we get feelers from the market. In fact, we are also talking to government to if there are any help required from our side. And we are in constant touch with the EPA officers in Maharashtra, in other parts of the country also. And what I found, there are about 41 centers of main depots, which are regional or state-wise, which are having enough cold rooms. And Government of India has also issued a notification to them to gear up for the, more cold rooms for storage of vaccine. Next slide.
I think you have already shared the nuances of this
Yeah.
slide.
Yeah.
The next one.
And an effective cold chain relies on three main, that is storage of vaccine, then also the accurate vaccine inventory, and also the break in the cold chain. We can't afford at this stage. I was just talking to Vishal other day, because of course, any stage, any vaccine, any stage, but more so in this case of COVID vaccine, because if every day and every drop is important. So I think break in a cold chain we cannot afford. But I think what we can do is, government is definitely geared up, because that's, as I said, that's the feelers we are getting. And also we have been talking to the people, but they should also have some mock trials done, so that, either of the vaccines, whichever comes, should have more efficiency in distribution. And I think what I personally feel with so many years experience, initially when we launched vaccine about 50 years back, see, that time there was no uh, talk studies or phase 1, phase 2, phase 3, until nobody has died. So I think we are making more issue. That's my personal opinion, which I can be wrong also. I'm telling you very candidly, but I think the vaccine always has got benefits, more benefits than the disease itself. And in case of COVID, the deaths that are happening, if you see the Delhi's case yesterday, I think we should launch vaccine yesterday. And I don't see any problem of any company's vaccine because it has gone through the tox studies, it has gone to the ferret trials, it has gone to the phase 1 and phase 2. I think we are personally, as I'm again repeating, I may be wrong, but I think we are making more issue and more fuss about phase 3 and all these trials. All vaccines are efficacious and they will definitely control the disease. Only question is the day we launch, and it is a requirement of yesterday. Thank you.
Thank you, Dr. Ravitker, for setting the tone for the panel discussion of challenges from manufacturing to cold chain shipping to storage to last mile delivery. Thank you so much for sharing your insights. Let me start the panel discussion by stating few facts in front of each one of us to understand this unprecedented challenge in India's preparedness for a policy framework to immunize 1.3 billion people. And I think all the challenges have already been spoken in before panels. I can just reiterate: vaccine production, pricing, distribution, cold chain infrastructure, human resource. I think this all can be addressed by the active participation of all the stakeholders through the public and partnership consortium. Now, may I invite each of my panelists to share their views on how to mitigate challenges of vaccine supply chain disruption in pandemic times, as it is well known that the 30% of the vaccines in the normal times are destroyed due to the disruptions. So what can we do to avoid such disruptions which used to happen pre-pandemic? So I invite Rahul to set the stage.
Thank you, Vishal. See, the most important factor here is that there needs to be a proper planning of the networks. So while you have, and as mentioned in some of the earlier panel discussions, they spoke about how the distribution channel in India works. You would have the primary storage point, and then then on the secondary point, and then the last point where the immunization would actually take place. And it's very important for the government to sort of engage the existing stakeholders, the pharma companies, as well as the logistics service providers in sort of correctly mapping the requirement in terms of the type of warehouses required, the storage sizes, the temperatures, because we are seeing products with multiple temperature ranges, the sizes of the reefer vehicles required, the capacity in the air which is required for air shipments, what kind of passive coolants are required, what kind of tertiary storage facilities are required, and then of course the most important leg, which is the actual immunization and the collection of data post immunization in terms of the the after behavioral effects of the patients once the immunization takes place. So it's a question of mapping the process right. We in India already have some bit of facility and some bit of infrastructure available out there. Immunization programs have been going on for years, so it's not that this is happening for the first time. So this is a global level pandemic, and there is a time to for the product to reach the market, which is what is creating more panic because of so much of media attention. But just to mention a quick point, when we had the the AIDS program going on, and the product took a much larger longer time to sort of come on road, unlike the corona vaccine, which we are hopeful to see coming on road by in less than a year's time. At that time, I think the product took almost a decade to come on road. So we are much better off than what we were in the earlier times. And we are seeing a lot of companies, a lot of people, putting in all their muscle and might to sort of bring this product quickly on road. And I think the right kind of planning will help us create the best of infrastructure and the timely and sort of efficient rollout, which would help sort of reduce the losses in transit, with the handling losses, the temperature excursion losses, and the related factors. Thanks.
So Manish, would you like to add on the dimensions that Rahul shared, considering that you have storage solutions?
Sure, Vishal. I think continuing to what Rahul said, the WHO and CDC have come up with very clear guidelines on the usage of purpose-built cold storage equipment to minimize wastage. And to that point, over the past 60 years, Thermo Fisher has provided hospitals, clinics, and pharmacies with the tools they need to deliver every vaccine at the full strength and efficacy. And that obviously starts with the right cold storage. We have purpose-built refrigerators from 2 to 8, 20 to 40, or minus 86 that are designed in compliance with CDC, WHO, and NSF guidelines, especially for vaccine storage. And Thermo Fisher has been a front runner in adopting cleaner technologies such as CFC and HCFC-free refrigerants, complying with the SNAP guidelines. I think other than the right cold storage equipment usage, what also is important is monitoring the real-time temperature, enabling vaccine stability up to last delivery. And I think Masanari's son will speak more to it. But I would just like to end by saying that in terms of mRNA vaccines, my personal opinion is that the infrastructure of the minus 70 cold storage equipment is relatively low in India. And we need to start building that capacity now in order to be ready once the vaccines are out in the market.
I couldn't agree more with you. I think the time to take action is now. And minus 70 is going to be, I think it's going to be unprecedented challenge. Yeah. So let me move to the other question for other panelists now. So we know that there are multiple vaccines which are coming with different temperature requirements. So how does one prepare in such an ever-changing environment? So over to Mahesh.
Yeah, hi. So I think you've caught on a very important topic. Let's just look at the complexities that come in from this dimension of the number of vaccines that are there and the differences that they have, and how it boils down to challenges in supply chain, and how it boils down to challenges in administration, and really the last mile work, right? Even if you just take the three that are most talked about, the Moderna, the Gamaleya, and the Pfizer vaccine. And then, of course, we know we have the Indian vaccines that are also following very closely behind. They all have different storage conditions. They all have different schedules of administration potentially. They even have complexities of a different vial that needs to be administered for the first dose versus the second dose. So all of these are really strong logistical challenges that we need to prepare for, and therefore need to have really strong distribution systems, strong monitoring channels, strong data collection channels. And at the end of the day, all of this needs to be administered in the background of what we are talking about for something that would be suitable at the scale of India, which is a 1.3 billion population. So, we obviously need the infrastructure to make all of this happen, and we have experts who have just talked about some of the logistical components and the solutions that can be brought into consideration for that. We then have the data collection components of it, for which again we have folks working on providing those channels of collecting data, monitoring it. What we additionally need, and this is what we need to think about in terms of specifically the COVID challenges, we need to think about supply chain, not just ending with. Sorry, okay, let's see. Maybe it's better. Okay, good. So, we need to consider that our supply chain challenges don't simply end with giving the vaccination shot to the person. We need to consider it as it doesn't even end after giving the second shot in case of a 2-dose vaccine. It actually is then also looking at the effectiveness of that vaccine, the vaccine performance assessment, as we would call it, because that is something that we still are working with minimum amount of data in terms of protection, in terms of longevity of protection, plus any degradation or any changes or any effectiveness issues that may have happened due to the vaccine during transit, which is not something that we understood because of our own supply chain. So what that translates into is the need to have good testing potentials, good testing facilities, good awareness of how the vaccine needs to be treated at the last mile. And for the testing components, there are two components that I want to talk about more from a technical perspective. One is to assess the vaccine itself, whether or not it was still safe, and what are the tests that can be performed for those right just before administration, if any, to be able to make sure that the dose that is being provided is the right and the efficacious dose. Then the second is with regards to the performance assessment after to check for immunity buildup. And that's where, again, the capabilities and the scientific horsepower needs to put in, so that we start to utilize the assays that are there, not just for antibody measurements, but also then for T-cell response measurements, because we know this, it's a combination of both of these that need to be brought in, after which we can say, yes, we know that we delivered the vaccine safely, we know that the vaccine was effective and then and gave and led to the protection.
Great, Mahesh. I think you brought a very important point of testing. And I think because testing will happen, and that's where we will be able to maximize on the impact that actually immunization program would like to do. So I think this is a very important dimension that you brought. Thank you so much for bringing that. Now over to, let me turn to Masanari. Masanari is a CEO of a tech company based, backed by Cisco Ventures. So how do you plan, Masanari, to actually integrate this challenge that we've been talking about, that India has in front of us? And there's a clear need to provide scalable, reliable, real-time monitoring solution, which can track the temperature till last mile delivery, including managing unforeseen circumstances, which we know will happen, And so I would really request you to share your views on this unique challenge and the opportunity that you're working on.
Yes, thank you for great introduction for my conversation. And as Manish and also Dr. Swart mentioned in keynote, digitalization is really, really key for monitoring. And I want to mention a couple of things to enable those digitalization. First of all, right now the monitoring is implemented very, very isolated way, and so you cannot really do end to end. That means manufacturing to actual hospital and those kind of endpoint. Monitoring is not really happening. It is really, really important to onboard all of those implementation, sensor implementation for the monitoring into one platform. Those are really important, so you can see entire cold chain. That's number one. Number two is, as you mentioned, real time is really important. And why it's real time is important is when something happened, temperature excursion happened, you want to take immediate action. So when something happened, then it's received real time, and then you take a real time action so you can fix it. So that's another important thing. And then because of this is massive scalability, we are talking enabling cold chain asset facility is really, really challenging, because number of the facility you have to monitor is really huge. And so if you talk about a very expensive platform to enable those kind of each asset, it's not gonna happen. So I believe to make this scalability happen, the cost of each monitoring is really, really important. And then those kind of sensor device, it's really becoming really cheap right now. And also connectivity is becoming cheap. So connecting those kind of a cheap sensor into one single platform, then you can see entire view.
I can imagine the disruption that you're trying to bring. This is really, really encouraging. So I think it's time to move to Rahul. Rahul, being a managing director of one of the leading cold chain logistics company in India. And I think they've been doing this for 30 years, and they have, you name a company, customer in the pharma industry, especially on the cold chain side. they have it. And Rahul, how do you plan to address this challenge, which we could never imagine, to provide a scalable, reliable cold chain logistics and associated infrastructure, keeping last mile delivery challenges in your view, considering the COVID-19 vaccines? I think it's difficult to imagine, but we still need to prepare. So over to you, Rahul.
Thanks, Vishal. So, see, we've been doing vaccine transportation or handling for a long time now. So, when you look at products in the +228 temperature or -20 degrees, that's something we've been doing for quite a while. And we have the right tech available, in terms of, like, as Masanari-san was mentioning about the, end-to-end connectivity of these sensors, on a common platform. So we've been doing that already, since the last 8-9 years. We have that software available, which integrates the data points into one platform and can give you a complete journey report, irrespective of the interim changes that take place in the distribution of a vaccine or any biological products which require the temperature control. So this is being done. Yes, there's definitely a question mark or a challenge in terms of India's capabilities on the -70 products, which is the Pfizer vaccines that have been spoken about. But as the world evolves, if we can come out with the COVID vaccine in such a short period, as I mentioned earlier, and I'm sure we can also come out with the solution to handle those products.
This is your optimism.
It's a matter of again, I think it's collective coordination where you use the best technologies from the world and bring it onto a common platform, because this is a global problem, right? It's not just about India or about any other country. Everyone needs to solve this sort of puzzle, that how would we handle the
One has to be selfish at this point.
Yeah, but you see, even Pfizer has got a plan, I'm sure, in terms of how they would sort of distribute this across the various countries. And if there was a question mark in the capability of doing it, they wouldn't have really sort of gone ahead and come out with this product at this range. So yes, 228 and -20 is a doable option. It exists in India also. The government has been doing it. The private sector has been doing it. We see a lot of food logistic companies who are now volunteering to sort of come into this whole pharma game and try and handle the COVID vaccine. And yes, while there may be some compliance challenges that they may have, but today I think India needs all the infrastructure that is available to be pulled into one common platform. And I think it should be the prerogative of the government to drive this platform, because that's how sort of you would have a smoother transition into this model, and you would have a more visible and compliant sort of rollout, rather than doing it company wise individually. And
Sure. So Rahul, there's an add-on which is what worked and what hasn't worked in your opinion, very crisply, if you can share.
No, I think, I mean, if you look at the India immunization program, what hasn't worked has started working now, because the government has learned over the years, so I won't say what, so there are learnings from what hasn't worked. Now the government is talking of IVANs, and, so they're talking about serialization in the pharma industry in terms of, probably using technologies like blockchain for monitoring.
Track and trace.
They are concerned about the counterfeiting, where the serialization also takes place, care of the counterfeiting, which is alarmingly, I think more than 10% of the total medicines sold in most countries, including the US. You have counterfeiting even in other highly developed countries. It's a challenge. Yes. And that's why these technologies and that's why these common infrastructures will help sort of mitigate those challenges. And I think India is very well equipped to handle that. People are willing to build the infrastructure. A little bit of push and drive is needed from the government side, and that would probably sort of nail the problem at hand.
Great. So I'll come back to you again. So Manish, Thermo Fisher, as your organization, is one of the largest biosupplier in the world. How would your organization contribute to solve the problem of cold storage in India and associated supplies in hand?
So, Vishal, very relevant question for the current times. And if I start with the Pfizer vaccine, which needs -70 degrees cold storage, we have extensive range of freezers and ultra low temperature equipments which can help the team store. And these are very high technology driven products which have variable speed compressors and compressor free refrigerator systems, which should provide very low vibration and very high temperature stability. And they also follow the green technology guidelines from SNAP and have got CFC free refrigerants. In terms of the 228 and -20, also we have a very, very extensive range of equipments which can help. And I think what I have seen at times is the hospitals and the clinics resort to the general purpose refrigerators, which leads to an unnecessary wastage of vaccines because the efficacy of the vaccine can be lost in a very short span of time if not stored at the right designated temperature. And then it's very, very important that the entire value chain from the manufacturing location to the last mile administrative site follows the right type of cold storage equipment. And that also complements what Rahul was suggesting, that having that knowledge across the value chain is very, very important.
Absolutely. So let me turn to Mahesh. Mahesh, you being the Chief Operating Officer of a largest CDMO and CRO for biologics. And I'm sure you have some recommendations, some solutions, some suggestions to make to address this challenge, So over to you, Mahesh.
Yeah, and I think I think we should look at this overall supply chain challenge both from a logistical and a technical issue. And we've talked about some of the logistical things. On the technical side, what we also need to look at is in India, we have large manufacturing capabilities and capacities. And one of the things that Rahul mentioned is, let's look at industries that have been looking at repurposing and offering solutions for this challenge, such as the food industry. Similarly, we need to look at all of our biomanufacturing capacities and capabilities within the country, and especially with CMOs like us, to see what can be used for manufacturing those same vaccines in India by partnering with the innovators, so that we significantly, one, increase the availability of those vaccines here. Second, bring down the high cost of shipping vaccines at -20 or -70 degrees, because we know that not only is supply going to be a challenge from a capacity perspective, but it's also going to be a challenge from the transport perspective. We just heard earlier, some on the order of some 800,000 crates vaccines that will need to be shipped. And these are astounding numbers, which we need to break down the problem into saying, what can we do even on use of local manufacturing capacity? And that's where I think one of the places where the local CMOs and local manufacturing needs to be brought in, and I think companies are doing and working through.
Couldn't agree more, Mahesh. So it's time for me to turn to Dr. Ravedkar. He's been patient. Thank you, Dr. Ravedkar, for being so patient with us. So, you are one of the top techno-commercial professors that I've known in last 10 years with my experience with you. And I think, as you said, that you're a student of vaccinology for about 48 years. So that's a very humble statement coming from you, sir. I'm very, very encouraged, to know you as a person. And, but I do feel that, with your background, definitely there is some suggestions that you can make to ensure that the last mile delivery at scale, which is never imagined. And I think all of us spoke about the scale, which actually nobody imagined before. So are there any practical suggestions that you think will need to be implemented? And the time to take those actions and make recommendations is now. And I think I would like your words, to be really, really very effective. And we will do our best to see how it could be, channelized to the relevant stakeholders. You have to unmute, sir.
Can you hear me?
Yes, sir. Loud and clear.
So, thanks for the kind words you said about me. But nevertheless, this problem, India, as I said, is well advanced in this, in technology also. I have seen we have got a cold refrigerated valves which deliver in India, which have got a GPS and cloud computing and AI. So we are already that in place. We are also working on a traditional packaging as well as isothermal packaging. And as Serum Institute, is exporting to more than 160 countries. We are well versed with all CDC norms and all international norms of delivery. And I personally feel, after reviewing, India is in a good position to deliver the vaccine. The system is well established. Only thing, as I said during my speech, they should do some mock trials as if vaccine they are going to distribute today. then that mock always surfaces a lot of problems in the issue. Like cold storage is not there, or it is short. Because this time it is going to be a little different situation, because all vaccine will come from various companies at same time, and we have to immunize so many people at the unimaginable speed. Every time it is a different, it is spread over so many months, or things like that, whereas this time it is going to be short time. So the program efficiency, efficacy of the program is very important. The vaccine shouldn't stay in a cold storage for a long. It should be implemented. It should come and move. So all that logistics.
I think you said the relevant point, and it's time for me to move to Masanari, because you mentioned about solutions based on IoT. And so Masanari, if you could just let us give crisp feedback about what can be the learnings from your experience working with other countries, how India could win from there. How can India leverage from the solutions that you are actually working upon and you have worked upon?
Yeah, again, this again, I'm always talking about the platform, but for having like a lots of experience from India, for example, and because India rolled out massively at the beginning, and then it is very, very important to collecting the data from those kind of experience. And sometimes like some problems happen, and if you have data, you understand, you predict before it's happened. So those kind of data should shared by worldwide. So not only like Japan has unique experience, US have a unique experience, India has unique experience. At the end of the day, all of experience is asset for the human being. So from that viewpoint, data play, again, collecting everything into a single platform and playing that data plus AI is going to be like a key to expedite this entire thing.
Thank you so much for those insights. And before I end the panel discussion and invite the questions from audience, we've received lots of questions from chat in the chat box as advised by my colleague. But would like each one of you to make a single liner suggestion or a recommendation to the government towards preparedness of the robust framework of last mile delivery. And as I said, the time is now. So just one liner in conclusion from each one of you. So I can see Dr. Ravedkar in my frame first. So over to you, Dr. Ravedkar.
Yeah, thanks. As I said, do the mock as if we are going to distribute vaccine today.
Wonderful, wonderful. Audit is important. Internal audit, great. Rahul, last line.
No, I think it's just the proper planning that is needed, and to utilize the right infrastructure to pick and choose the right players to sort of run this whole show, and we should be on track.
Yeah, and time is now. Masanari, final words from you.
Yeah, I'm keep repeating. So having a single platform, digital platform, and also collecting data is really, really important. And
just can't manage without technology. I think that's what you said, and it's so well captured. Great, Mahesh. Final points from you.
I would build on all of this, which is to say that let's have the platform to make sure that we know where the vaccine came from, where it went, and that it was finally effective. So to cover everything from manufacturing, batch numbers, patient information, to finally that yes, actually there was a response that was generated so that people know they're actually safe.
Wonderful. That's very holistic. Thank you. Last not the least, Manish.
Vishal, I would just say that my suggestion would be that government should come out with a very clear guidelines on purpose-built cold storage. So to your point, Pfizer had to procure 300 plus freezers in UK and US for the -70 vaccine, and it will not be easy to procure them in short term. So again, to your point, time is now. We need to have these guidelines and procurement plans initiated right away.
Thank you so much, my wonderful panelists, for sharing your wonderful insights. I learned a lot, and I'm sure my audience would have also. And now it's time to segue to the Q&A from the audience. And we have received two questions in advance. And the first question is, are there any cold chain logistic providers building the capacity of freezers to meet the demand for vaccination of the entire population? I think this can be addressed by Rahul and Manish. Rahul, over to you quickly.
Sure. So I think portable storage solutions is the key for this sort of program, because as of now the geographies have not yet been finalized. Where the tertiary storage would take place, and we have developed not only just the portable cold rooms which are at -20, but also the packing solutions which we are expected to launch in the next 2 to 3 days. Surprisingly, we have been able to achieve a 96-hour shelf life with these passive coolants.
Okay.
At -20.
And at what temperature?
-20.
Oh, that's brilliant.
We've crossed about 90 hours as we speak. The validations are going on, and I think this product should be available for demo on Monday or Tuesday. And I think this would bring a lot of change about in the whole availability process.
Do you think this could actually be extended to -80 with a little bit of incremental innovation?
Well, there are some trials and R&Ds going on, but at this stage it looks a little difficult. But then, as I said, nothing is impossible. You can always.
I'm sure our friend from Thermo Fisher can collaborate with you to expedite this. What do you say, Mahesh?
Absolutely, would love to do that.
Great. So that's wonderful. So we have a second question, which says that what is the government plan for vaccine delivery logistics so that private players can look for most efficient way of transportation, building prototype, and get the same certified? I think it's a kind of the same question which was earlier addressed. Maybe if any one of you wants to add to supplement views what Rahul shared beautifully, please feel free to pick up.
I'll take that, Vishal. I think in terms of infrastructure, we have around 27,000 cold chain points in India, which effectively serve 390 million doses and 60 million people. So in my opinion, the infrastructure we need is much more than what we have now. And across the entire logistic team, we'll have to start planning for it now. So the question is very pertinent, and I think there's need for faster action than what we're taking today.
Wonderful. I think it's time to pause, and I thank each of my fellow panelists for their wonderful insights and audience for patient hearing. And it's time to say bye, and I hand over stage back to my host, that's Dr. Nidhi. Thank you, Dr. Nidhi, for the opportunity. Over to you.
Thank you, panelists. Coming up next is the panel on building digital infrastructure to ensure supply of vaccines and timely vaccination. May I please invite Dr. P. Ratnakar, Global Practice Head Life Sciences, Tech Mahindra, to moderate the session. Over to you, Dr. Ratnakar.
Thank you, Dr. Nidhi. Dr. Nidhi, you may have to actually enable the video, please.
Absolutely, sir.
So once again, warm welcome to all the viewers of this particular webinar, and warm welcome to all my panelists. So as Nidhi mentioned to you, today's discussion is around building digital infrastructure to ensure supply of vaccines and timely vaccination. Today, we have along with us the speaker, Professor Dr. Soundar Kumara. He's actually a professor of industrial engineering from the Penn State University's Park campus, and an esteemed scientist with research focus on sensor-based process monitoring, chaos theory, digital threats in manufacturing, AI and ML in manufacturing, healthcare analytics, and graph analytics. So I would like to introduce him with his photograph so that you'll be able to see him live and hear from him what he has for us. He's actually worked extensively on military and industrial supply chain logistics, infrastructure problems. He's also armed with fellow of Institute of Industrial and Systems Engineering, International Academy of Production Engineering. He's also a member of American Society of Mechanical Engineers and American Society of Advanced of Sciences. So take us through for the next 10 minutes. I would request Professor Soundar Kumara to address us. Over to you, Professor.
Yeah, thank you very much, Ratnakar. I'm going to share my screen. Nidhi, you may have to enable me.
Yes, sir. Actually, you're enabled. I just had to stop sharing Dr. Ratnakar's screen.
Okay. Can you see my screen?
Yes.
Yes. Excuse me. So this is like my real sleeping time, 3 o'clock in the morning. So I may be a little rusty when talking. When Dr. Damodar Acharya sent me an email and asking me to talk in this conference, my initial reaction was, I don't do anything with vaccine, so I may not be the right person. But I'm very encouraged from the last panel, especially when Masanari Arais and talked about real-time monitoring, and also Dr. Mahesh, he also talked about having the visibility of the supply chain end to end. And I'd been working in sensing and trying to figure out the situation awareness for a long time in my career. And therefore, I feel what I'm proposing is the right segues into the previous panel's discussion. So what are the key takeaways I would like after this 10 minutes from my conversation is the smart vaccination supply chain is a technology which is cross-cutting and research, technology, and development for IT, information technology, and OT, the operations technology. That is one takeaway. The second takeaway requires this SVSC requires the development of operating system for cyber physical vaccination ecosystem. These are the two takeaways from my talk. So about this, a lot of people talked about even network. Essentially here, I'm trying to show this slide that to state that India has the infrastructure in terms of distributing the vaccines. And then how far it can go is a question which everybody has been asking today. So all this are known points, therefore I'm not spending time. So everybody talked about platform. So what is a platform? Platform, the way it is defined by McKinsey, is a business model that creates value by bringing together consumers and producers. So there are three kinds of platforms. One is a transitional, where you have the individuals and organizations are interacting, like Uber or Airbnb, eBay, Amazon, etc. So they kind of work in a marketplace. Then you have what you call the innovation platform, where you have a hardware that is defined and you have an operating system that is defined. And if it is open, it's much more, much better. And then you can hang on any application. Therefore, this leads to tremendous amount of innovation. You are crowdsourcing innovation to people. So this is a second kind of platform. The third kind of platform is an integrated platform, wherein we have both the transactional as well as innovation together. These are like the Microsoft Azure or the Amazon Web Services, etc. So here you are looking at the users and the producers coming together, and you have technologies like AI or cloud computing, and then your sensing and also your data. All these things in terms of the operations and also IT. So this is the structure I envisage for the smart vaccination supply chain platform of the future for India in the global context. This is, everybody knows about how COVID, the vaccine comes from a factory to the end point. Here, the doctor is shown as the person who is delivering the end product to the patient, vaccinating the patient or the individual. And people talked about the cold chain and then how you can, what the need to track everything. All these things were mentioned fairly well right from the morning till now. So if you're going to create, or if you're going to work with this kind of a supply chain, we need a reference architecture. So for a platform, you would definitely need a reference architecture. This reference architecture here, you look at collaboration as one vertical, business models as another vertical, and operations as another vertical. And then each one of them, I go through in a little bit more detail. They're held together, these 4 pillars of the reference architecture. So in the collaboration, you have the different players, right from healthcare professionals or the frontline workers, NGOs, or the old people homes, or the 3PL and then 4PL logistic big providers, the manufacturers, physical cold chain equipment, and also the regulatory bodies. All these are the players who are going to be at the almost the physical level. They form these networks, and then you have the data that models that are being built on this data that is generated, and the processes that happen at the physical system level, or the distribution, storage, or the time series services which you have to give, when and where things were, and then the cloud and edge computation, and then pilferage or counterfeiting detection services. All these are necessary at the collaboration level. At the business model levels, we are looking into how do we optimize the system. Therefore, transit analysis becomes an important point. Storage becomes another important consideration. IoT, cloud, and edge, another one. And here the analysis is a little bit quasi-real time. We really may not need the real-time analysis. Whereas if you take at the operations level, that is where the sensors and the devices, if you are looking at the bottom level. And the last mile delivery, this is where we are going to be looking at all the sensing and the data loggers that come out of it. And the sensing data is stored onto the either IoT, whether to do it on the edge or whether to do it on the cloud. All these questions are going to come in. And therefore here, control needs to be exercised, how well you're going to use it in the last mile. And then here, again, you need to worry about in real time, pilferage or counterfeit detection. So the most important point here is in terms of the real-time analysis. So the 4 pillars of this reference architecture are, one is the interoperability, and then standards and the protocols. And the other one is security and the cyber security, safety, and resiliency. The third pillar is going to be human systems interface, because people are going to be interacting with these systems or with this platform, and data services. So if you put all these things together, we need to design this system. We need to measure how the system is going to be working. We need to predict in terms of when you're actually picking up real-time signals from the sensors, and then you want to do the control. So the founding technologies, if you go to what we need a platform communication language and operating system for this smart vaccination supply chain reference architecture. You need communication. Locally, you could do edge, maybe a local network, and then globally or at a higher level, you are looking at mobile or cloud computing. And then for analytics, we will be using AI and machine learning. Both, they can be at the edge or they can be at the cloud. For example, when I take machine level data, I can do it on the edge. Raspberry Pi maybe does to some level, but if I go to Jetson Nano, I can do it much faster and much more efficiently. So then the question here in real time when you are dealing with the vaccine supply chain is what analytics, and then when you are going, how you're going to use it and where you're going to use it. And tracking at every level. We need a data structure for tracking at the vaccine level, and perhaps that needs to be enabled by a blockchain. So the inferencing from the data that you're collecting, that is going to be AI based. So what services are needed to do this, and what data is needed for a particular inference you want to make. What I mean by this is, did I really conform to the temperature specification? Suppose you ask that question, then I should be able to come up with that inference. Then my system should be able to know what data would be needed and what kind of a service should I call, whether at the edge or at the cloud. So the major challenge, like Masanari-san was talking about, real-time monitoring and control. I spent 30 years in that particular field, dealing with manufacturing. And then the real-time distributed management, though you have the central operational control, the vaccine distribution is going to be in a distributed manner. Whether here, again, to edge or not to edge is the important question. Integration between Aadhaar, even, and the vaccination health record or EMR. Maybe we need a vaccination health record. So why is that important in the digital platform? At the transaction level, if you look at, I built this diagram specifically for our purposes. I used McKinsey's IoT stack configuration. You have the platform layer, all the business applications, development environment, analytics services, what you need, visualization, e-commerce, or security services, regulatory services and data wrangling service, and device management. If you look at, we need three things at the last mile when you actually are dealing with the individual. Pre-vaccination, what do we have to do? What data we need to collect? Right from provisioning for this data to authenticating the person, to geo-mapping to visualize where the person is and what is being done, where are the collection of people. And then while you're vaccinating, we need to worry about cross-contamination. Somebody who already has COVID maybe is standing in the line, who knows? So even if you prevent it, even before, one does not know. So we need to worry about all those. And then post-vaccination is very important because we do not know the efficacy of all these vaccines over a longer longitudinal time period. So if you really want to follow this, obviously we need to have an efficient tracking system and also an efficient data collection and storage that is a part of this platform, which I propose need to be open source. So in terms of analytics, what kind of analytics we are talking about? This is some work we did on the COVID data. This paper came about in about, I think, September or August. Myself, my colleague, and my students, we looked into the county level data in the US, 3,200 counties roughly. And then we used comorbidities as well as the age and both the demographic and some clinical parameters in terms of comorbidities, and try to figure out the vulnerability of each county. So perhaps the vulnerability here, both from the point of view of what do you call, there was a reference to two things here, the frontline workers who need to be vaccinated. The second one is the vulnerable population. In order to enforce equity in distribution, some kind of a model like this. Here we use like gradient boosting method in the from machine learning and some AI inferencing to develop this whole county map. This is even before the data was freely available. So public-private partnership, obviously, even Aadhaar and the voting systems, I don't know too much about the voting part of it. Voting is a little bit one-sided. People go vote. We don't track them afterwards. Therefore, tracking here is going to be much more complicated. Though having said that, but still, it might be a good idea to use our learning from that in order to build. All these things are in the public sector. And you have a lot of companies coming up with blockchain platforms for tracking food or tracking vaccine and also tracking counterfeit drugs. So this is the other point. So the blockchains for information visibility, and then also blockchains for tracking as well as analytics to be able to identify anomalies to figure out what is happening in the system. So these are the few points I wanted to make. And finally, as a concluding statement, we need a reference architecture if you are going to, we need a platform. Platform need to be open source. And if we want to build a platform, we need to have a reference architecture. A reference architecture gives the stacks and what needs to be done and what kind of a data that needs to be collected and how, and all the services that are going to be put on top of each one of these layers in the platform are going to be almost open source. Anybody can build a service like apps people are building for iPhone or Android. So that is, I believe, could be a bright future in terms of building a platform for. Then I had to give a name because it is going to combine all that is existing as a smart vaccination supply chain platform. Thank you very much for giving me this opportunity. And the last 2 months, I learned a whole lot about vaccines and vaccine supply chains because of this call for today. Thank you.
Thank you, Professor Sounder. It is wonderful listening to you. We appreciate you staying back a little late and then enlightening us about various aspects. What was very, very interesting is you mentioned about a couple of areas, which is your last mile, the point you mentioned about lab to doctor's office. I think it's a fantastic in a problem area where everyone is looking at how do we solve that. You also touched upon the smart vaccination architecture in terms of what services to be used, what data to be needed, what are the challenges in terms of real-time monitoring, geo-mapping, coverage visualization. So I'm sure all these things are actually points to ponder for in the next 30 minutes in our panel discussion. Thank you so much for setting the stage for us to have a deliberation on these specific areas and maybe understand a little more from our esteemed panelists. Today, in our panel discussion, we are very, very fortunate to have two important, very, very esteemed professors with high academic credentials with us as a part of the panel. And we also have two important individuals who actually are steering the startups in this particular space. So we have a very, very good mix of professionals helping us to navigate through in the next 30 minutes, answering to us how digital can address some of the areas what Professor Soundara has actually enlightened us. So before I go further, I would like to introduce our panelists and give you a quick glimpse in terms of their credentials. Of course, we all the professionals, all the panelists here are of esteemed, have esteemed credentials, so I need not spend much time, but it's important for us to understand the kind of legacy they carry with. So Professor Viswanathan is actually INSA Senior Scientist in the Computer Science and Automation at the Indian Institute of Science. He's a Professor and Executive Director for the Center of Excellence, Global Logistics and Manufacturing. He was also a faculty member for the Indian Institute of Science for almost close to about 25 years. He was the Chairman, Department of Computer Science and Automation from 1990 to 1996. And he's a recipient of 1996 IASC Alumni Award, and a number of such awards are bestowed onto him. He's a fellow of IEEE, a fellow of Indian National Science Academy, Indian Academy of Sciences, Indian National Academy, and the World Academy of Sciences. So Professor Viswanathan, warm welcome to the panel, and we're fortunate to have you and would like to listen to you. Before we come to you for your questions, I would like to introduce my rest of the other panelists. We heard about Professor Soundara, again an esteemed professor from United States. Once again, thank you so much on behalf of all the panelists and the participants, Professor, for staying back late in your night and again enlightening us. We would like to spend more time with you in the next half an hour. Ajit Kumar is actually the CEO and the founder of RealMeds. It's a modern track and trace and anti-counterfeit solution. I'm sure all of us actually are trying to address this particular menace. And today, Ajit would actually like to give us in terms of what are the emerging techniques or technologies addressing these challenges. He's a serial entrepreneur, and RealMeds is his third venture. He's an expert in building scalable business models based on niche technologies from ideation to execution. He has over 2 decades of experience in employing these technologies to solving the problems. He is an open source evangelist and is also author for a number of such areas. Last but not the least, let me take the privilege of introducing Ajit Pai. Ajit Pai is the COO of Delivery. He is responsible for ensuring the smooth delivery of the products and services, especially from the supply chain perspective. We all understand and appreciate that. He manages the efficient functioning of Delivery's network, ground operations engineering. He is the CFO of Delivery and is also handled multiple roles in the Lodha Group. So without taking much time, I would like to now point this question over to Ajit Pai. Ajit, can you please enlighten us in terms of, you heard about number of nuances as far as the supply chain is concerned. Can you address us a couple of the areas which are actually very, very important, relevant as far as the digital technologies are concerned, and what kind of nuances do you see in the vaccine supply chain?
Sure. Thanks for the opportunity. It's been very enlightening to hear the views of the panelists so far. And Professor Soundarajan actually just laid out a whole bunch of things that are very, very critical as a theoretical framework and as a practical sort of next step to how this can be implemented. I think there are 2 key nuances to the vaccine supply chain. And one part of it is completely on the physical infrastructure side, which is with regard to basically the availability of refrigerated equipment, so to say. Now, whether that is fixed equipment or it is movable equipment, both of those are equally critical, right? But the topic of this discussion is more about. So I think there is a need to understand what the gaps are on the physical infrastructure side, right? But equally, okay, the physical infrastructure without the digital tracking of it will not give us the results that we need, right? What I think Professor laid out, I think is the most important thing, which is if you boil down everything to what is required, what we need is basically leg level traceability of every single transaction that happens in the supply chain, right? Why is this very important? While it is sort of, while it is a fairly easy concept to understand, to actually practice it, right, is where all of the difficulties lie, so to say, right? And more so, especially in India, where historically the supply chain has been very, very fragmented for any sector, right? Delivery itself started out 10 years back with exactly this problem, saying that digitally one has to understand what is happening in the supply chain. There's a very famous saying by Fred Smith, the CEO and founder of Federal Express, which is that the information on the parcel is more important than the parcel itself, right? Frequently, I think that comes to the root of what the nuances in the vaccine supply chain are, which is that every dosage of vaccine has to be tracked along with possibly about 40-50 different sets of information about that dosage, all the way from the time of its manufacturing to the admission to its movement to the last mile and across a vast landscape, right? And then what I would call as, let's say, for example, in a consumer durable world, what is called as a post-sale service, right? Where effectively you not only need to track what you've delivered, but you also need to track what's happened to it after you have delivered it, which becomes critical information. Now, what are all the nuances that come in? I think some nuances are very India specific, like for example, the fact that addresses in India are not easily understandable, right? Are not in a very structured format. I think those are nuances that are important for any supply chain. They become important in the vaccine supply chain as well. And then there are the whole set of nuances which lie around the digital traceability, right? The answer, I think, lies in the platform approach. I think that's been fairly clearly laid out by Professor. And I think in practice, it is true that the platform approach is the only one which will resolve it, because no one agency or company or provider will actually be able to have the end-to-end infrastructure on this digitally or physically, right? So having a platform which is open source where anybody can rig into in some sense, right? And the platform defines what has to be tracked and how it is to be tracked. I think that is the real nuance of this, and that will lie across multiple points. So you have the warehousing side, you have the cargo side, which is bulk movement, then you have the bulk break, and then you have the last mile, right? I think that's where all of this lies. So I think from a nuance perspective, we are talking exactly about the problem that Professor has laid out.
Thanks, Ajay. I think you've very nicely alluded in terms of challenges from an infrastructure, both physical as well as digital. So with the kind of problems what you have actually now alluded in terms of these challenges, I would now turn towards Professor Viswanathan to help us understand from his perspective what kind of infrastructure availability is there from a supply chain perspective. How can we actually circumvent these challenges? What Professor Sounder has actually alluded a couple of minutes back, and what you just actually also spoken about the challenges from an infrastructure standpoint of view. Professor Viswanathan, can you please help us understand more from your perspectives? You are on mute, Professor.
Now, can you hear me?
Yeah, you're audible.
Okay. So, yeah, I'm sort of working on this COVID-19 effect on supply chains, as well as their effect and how to design ecosystems and platforms. So as far as our discussion is concerned today, there are two kinds of infrastructures. One is hard infrastructure, which everybody is talking about. And the second one is the soft infrastructure, which is the software platforms and so on, which Sounder has talked about. And what are the important things for a supply chain like the vaccine? First one is the traceability. You want to know where it came from and how it has traveled all over, and whether anybody has contaminated it and so on. So that traceability becomes an important issue. So, and then there are a lot of innovations that are coming up as far as supply chain and things are concerned. Like, for example, people collect the big data. From the data, is it possible to say when somebody comes for vaccination, he has already had a COVID? Is it possible to say whether he had high blood pressure, high this one from this one? So if you have digital records of these people who are coming for this one, I think it is an opportunity for India to create digital records in the name of COVID, digital medical records. And once you have this data, then you can use the platforms like AI and ML algorithms, the machine learning algorithms to do this. Now, the point here is that it should be an open innovation. In other words, just because the governments are involved, it cannot be done by the governments and the cold chain logistics people and so on. Then the vaccination centers, where are the vaccination centers? Is it in high schools? And the people are talking about like, we are doing like the voting, like central voting systems, which are held in high schools, which are held in various places. So what are the kinds of facilities that are needed, the doctors, the cold storage, and so on? Is it possible to have vaccine trucks where they can go to the villages and the vaccine truck can have some refrigerators? And it all depends on what is the kind of vaccine you're using, what are the temperatures and so on and all that. So it's basically taking into account that we are in India and most of the people stay in 60% of the people stay in the villages. And if you want to do the village vaccinations, etc., then you have to, how do you convert both hard and soft infrastructure into the villages and so on. So, and another thing is what in terms of public-private partnership, you should have all the hospitals, the startups, and all the logistics, 3PLs, 4PLs, all the logistics companies into this one and form a sort of an ecosystem. And the ecosystem can be a platform and so on. So what becomes important here is governance. In other words, if you are talking in terms of in terms of a management literature, it is what is called governance. How do you govern, tell people what to do, what they're doing, when they should do, when they should come, and so on. So that governance comes in from what is called, it is called in the logistic literature control tower. In other words, is there some control tower which collects all the information about the patients, about the vaccination centers, about the vaccines, where they are going and so on, how many people have vaccinated, what is the data they have, and all this, if it is controlled, then you can have you can develop from those things. And also these vaccination centers can be designed using what is called the scenario planning. No, we don't have like vaccines there. Everybody is talking only about vaccines, how they are prepared and how they are delivered and so on. But when you are talking of 1.4 billion people and 680,000 villages, and where these things are to be done, nobody has planned, and scenario planning, and as well as the simulations and the governance mechanisms need to be developed. And the control tower concept will help on top of what Sounder has presented in terms of the platform to do this and so on. So, but there are a lot of startups which are working on, I advise a lot of startups which are working on the supply chain logistics and so on, and they're using all kinds of technologies, APIs, application programming interfaces, which basically help to connect various people, various parties who are involved and so on. So I think the digital infrastructure to be developed for this COVID vaccination is a very important question. Yeah. And developing this, it can be useful for other purposes also, for your health, for your voting, for your Aadhaar, for your and so on and all that. So basically, one thing that should not happen is COVID should not be transmitted when you go for vaccination, right? So yes. How can you ensure that the people who are going there, you team up, and then it should not be transmission. So if you take the digital or any other what are the so-called performance measures that you say? How many people are vaccinated? How many people are immune? How many people are transmitted?
Sure. So thank you so much, Professor. I think it was wonderful. You brought in the two important elements. One is open innovation, and second is scenario planning. I think they're actually very, very important and significant from the current standpoint of view. So to further understand in terms of what can India learn from the developed markets, I think we could see some amount of traction already built in the Western world. Professor Sounder, we will request him to actually enlighten us in terms of what India can actually look towards some of these learnings from the developed markets. And Professor Sounder, so look forward to your views, please.
Like Mr. Pai talked about a little bit before, in the sense of the theoretical notion of the reference architecture and the practicality of implementing some of these things in the last mile or even in the whole system These two are very, very important components. The reason why I even talked about this reference architecture is from my experience working with the DARPA on military logistics, number one. Number two, recently, last 2 years, I've been working with Clean Energy Smart Manufacturing Institute, which is DOE's effort to revolutionize manufacturing in the US. One of the calls there is how do we take the legacy systems which are there and then make them fit into this so-called digital smart framework. So this is one of the practical examples I can talk about and deal with, or the two examples I can talk about are things I worked with some of these industries. So I think in order for us to go into the future, 10 years from now, look back and say, what did these vaccines do to the people? And then what was their efficacy? In order to do that, even though it is very difficult, I fully understand how can you go to a remote village and then from there you collect the sensor data, etc. But whatever you can collect, at least to the level you can. Suppose we come up with the vision of proposing this as a mechanism into the future, and then combine it with the practicality of actually making these things happen from people like the delivery company or with Ajit Kumar here, then I think we are into this for a long haul. And then the problems which are not solved today perhaps would be solved. Because the work, that is what I would say we can pick up from the, if you want to call American experience. There are a lot of things which are done maybe 20 years from now, things will happen. That's how some of the DARPA projects are. And when you're doing it, you know that there's no way this is going to happen. But then you realize when you look back 20 years back, oh, we worked on this, that has become a part of this particular system. That is my, what do you call, 2 cents. And also I fully understand how are you going to track an individual when the individual's address is not there? Or in the same address, 10 people are living. So I worked with the other group long time back before they actually started doing things. And I was called to look at how do you eliminate fraud. Then I was looking at individuals and their locations and then addresses. I could not disambiguate them because 2 people had the same name living in the same address. Who am I tracking? So, but however, the tools and then the reference architecture or the models developed or we are proposing or this panel is looking at perhaps will become reality 10 years from now. So that is the experience from the Western.
Yeah, thank you so much.
Thank you.
You did actually mention in your talk also about the geo mapping and coverage visualization. So I think some of these elements can try and address some of the areas what we are today grappling with in terms of challenges. So we will turn towards Ajit Kumar. Ajit himself was leading number of startups in this particular space. And Ajit, can you actually help us understand what kind of problems were faced earlier from a technology perspective in terms of these such kind of mass programs? And how do you foresee the situation now? And how can this be actually be learned from the lessons? We just heard from Professor Sounder about some of the learnings from the Western world. And can you enlighten us from an Indian context?
You are muted, Ajit.
You are on mute. Yeah.
So, am I audible now?
Yes.
Yes.
Okay. So, first of all, thank you so much, everyone in this panel and the audience for this opportunity. And Professor Sundar for putting together that nice architecture. I can totally relate to that because that's what I've been trying to put in practice as part of RealMeds day in, day out. So coming back to the question, Mr. Ratnakar. So in my experience, when we have a problem at this scale, there are certain things which become very important. And one thing is compliance and standard is something that I would really like to highlight, which was again the first pillar of Mr. Sundar's architecture. So why it is important is because now the the vaccines would be coming from various manufacturers, right? And they would be crossing borders, right? It would not be like Indian vaccines will only be distributed within India, or they would be going everywhere. So having a compliance in sense that it can actually comply with the global supply chain, right? And following some protocols or standards like GS1 would be very critical, so that whoever is doing serialization for these kind of medicines, as long as they comply with that, those medicines can actually flow effortlessly with no friction within the global supply chain, and they can be distributed and tracked very easily. So that's one thing which is very important for a problem of this scale. Second is, we all know that whenever there is a big problem, there is a big opportunity for the fake market as well, right? That's how the fake market sees that as an opportunity. So then this very next thing which becomes important is how do we protect each of these brands and also the consumers or patients from this counterfeit or the fake products. So having a very elaborate system in place which can actually do multi-point checks in order to protect. So whenever a caregiver is giving a vaccine, if they can quickly make sure that they run through the counterfeit check to figure out whether this is okay to give or not, right? So if they get a very quick answer in terms of yes or no, that would be very useful in this scenario. The next would be is the monitoring. I think in the previous session, and I think that's a common point, is that for vaccines is the overall temperature and the condition monitoring of the vaccine. So I think it is a two, I would say, the problem is like two-facet. So on one side, the cold storage is saying that, okay, we can do this, we can do this. However, in spite of all that promises, we still have manufacturers who have no clue. This is based on my practical experience. They have no clue whether their vaccine is really kept under that temperature from the source till the destination, right? So certainly, so we basically, for example, we provide a mechanism for manufacturers to actually understand this, where we provide them a device that they can actually put it inside their package. Now, how that package is going, whether through road or by air or by ship, doesn't matter. They get the complete visibility data about what had happened to the package actually. And that enables them to actually sit across the table and have a better conversation with all their logistic providers to ensure that why this is happening or how we can actually put this in place. So I think while we take care of the one part of the problem where storage companies are saying that they are doing it, but I think at the same time, we also need to enable the manufacturers to make sure that they trust that statement and they also have a visibility into that, because at the end of the day, if something goes wrong, they are legally liable to explain why this medicine gave any kind of reaction, right? So they are responsible. So they need to have the data visibility so that they can respond to those legal notices in a better way. And finally is the ease of onboarding the different participants, right? So that there is a common platform or there is a common data exchange mechanism in place where everybody is looking at one data at any given point of time. So it is not like the data is flowing from one system to another, rather than it's like everybody having a common view to the same data so that it's real time, it's accurate, and everybody has the same understanding of the data basically. And finally, one thing that I would like to add is in these kind of programs, it is also, in my personal opinion, it might help to have an incentive model built into the digital platform. So that way we can encourage people or the participants of this whole program, we can incentivize them differently, right? So that they're encouraged to either participate in this program, get their vaccination done on schedule, right? Get the repeat vaccination done on schedule. So having an incentive program would also enable us to actually run a program of this scale. So those are the key points that, in my experience, for a program like this would be really useful from a digital platform perspective.
So very thought-provoking point you brought in, Ajit, in incentivizing the population to ensure that they are actually being vaccinated and they comply to it. Thank you so much. It's wonderful to have the perspectives from all the four panelists, very esteemed panelists, and I think we got lots of information in terms of what could be the digital interventions. So I have a couple of questions from the participants. I thought we can actually spend a minute each in terms of addressing each of these questions. Professor Viswanathan was actually talking about role of public-private partnership, and the question is around where do you think and what do you think is the role of public-private partnership? Professor Viswanathan, can you please highlight us what, according to you, is the need today in terms of this public-private partnership?
I mean, there are a lot of private things. I mean, public partnership with the government and so on. But from vaccine makers to hospitals to startups to IT companies to various logistics providers, they are all private people. So, but what happens is, there is certainly, while people talk about how to design a vaccine, people are not talking about how do I deliver it from here, what are the steps that are involved, what is the scenario planning, if a thunderstorm comes, what will happen, if the truck fails, what will happen, and so on. So basically, there is a tremendous need for open innovation and data sharing, and having a big data platform and sharing all this data in a collaborative way. That's what I mean.
Thank you, sir.
And also there is another point where startups, there are platforms which are needed. There are platform at the vaccination center, because vaccination center also has all the players that Sounder has this one. Also at the government level, there are several platforms. So it is a hierarchical model where you have a big platform and a small platform. And all this government public people cannot do. It has to be done with cooperation with the partnership of the private companies. And also there is, as everybody has pointed out, from vaccines to data, everybody steals. So how do you secure the data? How do you secure the vaccine? These are all the issues. So, and I would also suggest to the government that they are supporting a lot of vaccine developments, but they are not supporting, I mean, today or tomorrow or day after, the vaccine has to be delivered, and all the people in in entire India has to be vaccinated. So how do you do it? What is the logistics? Do they have any research projects on this? No. No funding on the research projects. So it has to be done.
So thank you so much, Professor Viswanathan. And turning towards Ajit, the question to you is, digital interventions, number of digital interventions are tried. And can you highlight one or two things, what did work and what didn't work? Ajit, yeah.
Yeah. Sorry, I was on mute. So I think a couple of things that has worked for us in our journey, right? And I'll make this a little more generic because, it's not like we have distributed vaccines or anybody else has distributed vaccines at the last mile at the same level that is being spoken about now, right? A couple of things that have worked for us, and one of those issues, for example, is what Professor raised also, which is about the addresses itself, who stays where, etc. Right? Like in our case, for example, we have been able to build a system where today, if we have delivered to any address or any person, and when I say a person, it is defined by a location, right? Once, right, we are actually able to create through our own data, we are able to create a unique ID, okay, by disambiguating the address of that person. So effectively, let's say the person stays next to the Shiva temple, which exists on the main road of some village. I think the what I would call as the middle mile of it is very easy, which is that you have to get to that village, right? And then there is the last mile, and then there is the location itself, right? Because India does not have roads, road names, blocks, sectors in whatever 95% of the case, we've actually been able to use a combination of geolocation, the person's phone number, the disambiguation of that address, and training our systems to actually read that address, right? Which basically means that if there are 10 different words in that address, our systems can read those addresses and piece together with a 95% probability who the person is and where does he live, right? That's worked well for us on the e-commerce side, for example, because we are now in our history of about 9 years now, we've delivered close to about 750 million parcels across the country to possibly about 100 million unique people across the country. And when I say people, it could also be multiple people living in the same address, right? So the data systems that we have built we've been able to actually understand how to deliver. So, for example, today when a new parcel comes into our network for the same person, our systems, even if, let's say, for example, the address is written slightly differently, where, for example, instead of writing near Shiva temple, somebody writes it as near temple, and after that the locality name, and the locality name is spelled wrongly, right? Our systems using probabilities are able to actually zero in and say that, look, this is the same person we delivered to 1 year back on this date. And hence, if the delivery boy says that this address is wrong, please go back and tell the delivery boy that you delivered to this address earlier, right? I think those kind of systems that have worked for us over the last 7-8 years, and I'm not sort of saying that that's the only thing, but these are the kind of things which will have to come into play here, right? So I think to that question, I think this is one example of what is important, and there are certainly many more that are important.
Thank you, Ajit. We have, again, number of questions lined up. Unfortunately, we have limited time. So thank you once again. I think it's a wonderful observations and deliberations by each one of you. Some of the key points which Professor Sounder has actually brought out in terms of collaborative ecosystem with smart vaccination architecture, which he brought in. And similarly, what Professor Viswanathan was talking about areas like open innovation, and Ajit Pai and Ajit Kumar talking about the various needs of these technologies all put together, embedded to create a system wherein we have a seamless distribution for what we foresee as an integrated view for our vaccine supply chain. Thank you so much for all of you for your time and enlightening us with all your perspectives. And thank you once again for your time, Professor Sounder. Once again, on behalf of everyone, thanks a lot to you. I'm sure we are holding you late in the night. Thank you so much for your time.
Yeah, no problem. Dr. Ratnakar, thank you. And Ajit Pai, Ajit Kumar, Dr. Viswanathan, thank you so much. And nice to work with you again, Dr. Viswanathan.
Thank you.
Thank you, sir.
Thank you, Dr. Ratnakar.
Thank you so much.
Thank you.
Thank you.
Thank you all. The next panel discussion is on government regulations to ensure safe immunization with reliability and quality assurance. May I please invite Dr. Y. Madhvi, Senior Principal Scientist and Professor ACSIR at CSIR NIS TATS, to introduce the panelists and moderate the session.
Hello.
Yes, ma'am.
Am I audible? Yeah. Good afternoon to everyone. This is a very important session. Good afternoon. I can't. This session is on government regulation to ensure safe immunization with reliability and quality assurance. Success of any immunization program will depend on a vaccine which elicits good immune response with minimum side effects in a population. So the ideal vaccine is actually an outcome of the regulatory machinery which actually ensures a safe and efficacious vaccine is licensed for public use. So this session is very important, not even otherwise also for all vaccines, but particularly now in this midst of COVID pandemic. To control this COVID pandemic, there are a lot of vaccine candidates and have been lined up for approvals and for public use. What is critical here is the timelines which have reduced from 10 years to 1 to 2.5 years is the critical point, which is a challenge for regulatory authorities also, how to actually ensure safety and efficacy of a vaccine, especially the COVID vaccines in the current context. So in this panel, I mean, this session is basically looking at the regulatory approvals and quality assurances. We have in our panel 4 eminent speakers. I can't see other speakers. I hope everyone is there. Hello?
Hello.
Yeah. Yes. Yeah. In this panel, actually, we have Dr. Ishwar Reddy from Joint Drugs Controller from CITSCO, and Professor Gagandeep Kong from CMC Vellore, and Dr. Ashok Mahapatra from SVA University, Vice Chancellor. Namaste, sir. And Dr. Nitin Jain from DBT, Department of Biotechnology. I don't know, Dr. Ishwar Reddy, I don't know whether he's there. This is, he is the key person in this session who can actually enlighten us.
Good afternoon. I am there, madam.
Okay, now I can see you, sir. Yes, sir. I think that means we are 4 speakers in this session. We have each speaker will get 10 minutes each for the presentation, followed by a panel discussion. And I'll invite Dr. Ishwar Reddy to make his presentation. He is the youngest, I must tell you, that youngest Drug Controller General of India. He has headed various internal divisions also, like on medical devices, biological new drugs, import and registration, and others. He is an expert in this area, and he has also published various papers on this subject. So it's really our privilege to have you here, sir. Please make your presentation. Thank you, sir.
Thank you, madam. I hope I am audible to all of you, madam. My voice is clear?
Yes. Yeah.
Okay.
Yes, it is.
So very good afternoon to all the panelists and all the participants in this today's session on government regulations to ensure safe immunization with reliability and quality assurance. I don't have any PowerPoint presentation because of it is a 10 minutes time. So I decided to just make a oral presentation. Madam, I think as you just requested us to first talk about what are the regulatory changes we brought for approval of new drugs and also in the clinical trial thing. I think as all of you know, the government of India has come up with the new regulations for clinical trials and approval of new drugs in the year 2019 with the major objective that to streamline our regulations with the contemporary regulatory practices globally followed. The another major objective of bringing these new regulations is to ensure timely accessibility of new drugs in the country, and also to make time-bound clinical trial and new drug approvals, and mainly to bring the transparency in our approval process, and also to provide the ease of doing business. And another major objective to bring this new regulations is to promote ethical and scientific clinical research in India, and not less than any other objective. Mainly, it is to safeguard trial subject rights during the clinical trials. So we have brought many changes in the clinical trial regulations. The major, just salient features, I will give major important amendments what we brought into the regulation. The first and most important regulatory change what we have brought is about the timelines. The first time in the regulation itself, we have defined the timelines for various approvals, and also we have first time brought the concept of deemed approval. I think many applicants earlier they are worried about the uh, transparency and reliability of the regulatory system, and another most important, predictability. To ensure the predictability, we brought the concept of deemed approval. If, if the applicant is not able to get any response from the regulators within specified time, then that applicant can consider their protocol has been deemed approved by the regulator. And we also first time brought the new regulations for the academic clinical trials. Earlier, even academic clinical trial permissions are required from the regulators that have been waived off. And we also brought first time the medical management system for the clinical trial subjects, and the medical management will be provided as long as required to the trial subjects. And another very important thing we brought in the new regulation is the compensation provision. Earlier, the compensation formula was in the form of a guidelines, but we brought the formula and all the regulatory requirements in the new drugs and clinical trial rules itself. And we also included the concept of post-trial access of new drug to clinical trial subjects, and the registration of BABE centers, and also the applicability of medical research guidelines to the academic clinical trials. And to also ensure the accessibility of new drugs, there is also a provision for waiver of clinical trials. In case if the drug is already approved in the specified countries, or in case of any emergency use, or in case of any unmet condition, there is a provision we can do waive of the clinical trial. And another very important concept we brought is the constitution of the expert committees or the groups to review the clinical trial protocols and also clinical trial data and the reports submitted by the sponsor. Earlier we have these committees, but these committees have been constituted through official order. But this time, in the rules itself, the constitution of the subject expert committees provision has been included. Above all that, there is a concept of debarment of applicant if they will submit any fake documents at the time of submission. And another interesting thing what we have included in the new regulations is the pre and post submission meetings. Now, under the law, the applicant, before submission of application, he can ask for the pre-submission meeting to understand the regulatory requirements for submission of the application for conduct of clinical trial or other things. So coming to the main today's topic, the government regulations to ensure the safe immunization. So as on date, I think we have received the various types of various vaccine candidates for the conduct of clinical trials. Mainly the technology based is one is the DNA technology based vaccine candidate, another is the messenger mRNA based vaccine candidates, and third technology is the recombinant DNA technology based product, and fourth one is the inactivated whole virion vaccine candidates for this COVID vaccine. To ensure the safety of this vaccine, we have a very clearly defined regulatory requirements. The applicant has to submit the detailed animal safety data, and they also have to submit the proof of concept for, and finally the animal challenge test reports. So the animal safety toxicity data, they have to submit the single dose and repeated dose toxicity. If the vaccine candidate is based on rDNA technology, then they have to also submit the NOC from the RCGM, and all the entire animal study data should be generated under the PLP facility. I think many vaccine candidates allow reliable safety data and also the proof of concept. It is satisfactory to the regulators, and based upon the satisfactory, we have granted the clinical trial permissions to the various companies. And some vaccine candidates are in phase 1 by 2 stage, and some vaccine candidates are phase 2 by 3 stage, and some vaccine candidates are under the phase 3. After completion of this, the sponsor has to conduct a detailed clinical trial as per the protocols and approved by the regulator. I think I'm happy to share you CDSCO, under the head of our dynamic DCJ, Dr. VG Somani. The lot of ease of doing business activities, fast track review of applications are taking place. And you may be knowing the subject expert committee meetings are happening twice in a week. And there is a fast track mechanism has been in place in CDSCO. And I'm happy to share you, even during the lockdown, the entire CDSCO office was functional, and even officers are operating from home, because to ensure that no single application will be pending not more than 3 days. And we are also thankful to the experts for their active participation in the expert committee for reviewing the clinical trial protocol and dossiers for the approval of permissions. And we are really facing some major regulatory challenges at the time of approval of clinical trial protocols, and hope tomorrow also for grant of marketing authorization or emergency use authorization. We have great challenges, mainly at the time of protocol approval. The subset groups like trial on pregnant women or comorbid conditions or children or old people, because we don't have so much of time to the sponsor to conduct the detailed studies. And the second major challenge is the duration of the immune response. It is not clear. It is the only time will decide, and also the risk of disease enhancement as antibody titers are wane. The third major challenge is the transmission of even virus from the vaccinated population. The another great challenge what we are expecting is the follow-up study to evaluate the long-term safety. This is another great challenge to the regulators. And the most of the clinical trial protocols what we have approved, all are based upon the adaptive design. So it is going to changes the design based upon that need, whether the dosage regime or the strength of the vaccine. And another great important challenge is the percentage of efficacy. WHO says it should be around not at least 70% efficacy is advisable, otherwise 50 to minimum 50%. And the another great challenge, because of the adequately powered of these trial subjects to estimate the vaccine efficacy. And most of the trial protocols says that interim analysis to assess the risk, they will break this randomization of the trial and come up with analytical report. And another great challenge, today's the entire discussion on this seminar is the supply chain challenge, the storage conditions and storage facilities is another great challenge. And also challenge to the manufacturers is the lead time for packaging of these vaccines, because we had to maintain the cold chain, and availability of the power at all the storage facilities. And other major issues relating to the availability of container closure system, because we need a huge number of empty glass vials, and we also need a huge number of empty syringes to administer this vaccine. There are so many challenges, for both industry and the regulators to ensure the safe immunization and also the efficacy of the vaccine. But before I conclude, I think as a regulator, we are really proud and thankful to the vaccine industry. They are working day and night. In fact, last 6 months, I have seen many manufacturers, the amount of time they are spending, the entire their man force, the technical people there, and also their complete back support system is working day and night to bring the vaccine at the earliest without compromising the quality safety. But I am sure in the coming months we will hear the good news, and this vaccine may be available to all the needy population. Thank you, Madhavi. Thank you very much for the opportunity.
Thank you, Dr. Reddy. Right now, I'll invite our second discussant, Dr. Gagandeep Kang. I hope she is available. She is there, I hope. Dr. Kang?
Yes, Madhavi, I am here.
Yeah. Thank you for joining. Anyway, I need no introduction to audience. We all get to see her on televisions. We get to hear her views on safety and efficacy of vaccines. Rotavirus vaccine also, we have heard so much about her. Now COVID-19 vaccines. All of you know that she has served also earlier with as an executive director of Translational Health Sciences and Technology Institute. She's the first Indian woman to be elected as a fellow of Royal Society. Thank you, Dr. Kang. Please go ahead with your presentation. Dr. Kang? Dr. Kang, can you hear us?
I guess let's wait for just a minute. I think she lost her connectivity.
Yeah. Yes.
Yeah, she's rejoined.
Sorry about that. My internet cut out for a minute. Thank you, Madhavi, very much for the introduction, and many thanks to Dr. Ishwar Reddy for the first presentation on everything that the Drug Controller's Office and all of the CDSCO staff have been doing to facilitate the rapid development of vaccines that can be used by our populations. It is a challenge, but I have no doubt that the Indian ecosystem is ready to meet that challenge. Now, the topic of this particular panel and webinar is safety. So I think it might be interesting for the audience to see how regulators look at safety. Dr. Ishwar Reddy pointed out that when vaccine companies come to the regulator, they come with preclinical information and they ask to be given permission to conduct their clinical studies. Now, if we look at clinical studies, in the phase 1 study, what we are looking for is essentially safety. So the vaccine which is to be given to humans is tested in a small number of people. And the challenges here are sometimes when you have an absolutely new product on a new platform, you have no idea what the kind of safety events you might see might be. So if it is a new platform, the way safety is evaluated is to start with a very small number of people. When we look at phase 1 studies are usually done in tens of participants, 20, 30 people, not very large numbers. But even there, if you have doubts about what the platform might potentially induce, when you start clinical testing, you'll start with 1 or 2 participants every day and then increase the number after you have watched them for a day or 2 and see whether they are doing all right. What kinds of things might happen? We could have common safety events, and those happen with injection. This is usually called the reactogenicity of a vaccine, when you have pain, redness, swelling, and fever, where you have been given the vaccine more recently. But you can also have rare side effects, and many of these rare side effects can take some time for us to pick up. Examples of those include something like Guillain-Barré syndrome, which results in paralysis but happens in 1 in a million vaccinees. It includes paralytic poliomyelitis that can be associated with the use of oral polio vaccine, but again, a very rare side effect. What you're looking for in a phase 1 study is, can this vaccine actually go forward? And you evaluate it in tens of participants. In phase 2, again, we look at safety, but now we look at safety in hundreds of participants. So here the goal is to define the dose. What dose are we ultimately going to be using to get to the target population? So if the study is ultimately to develop a vaccine that will go into children, you can start with adults, but ultimately you have to get to children. So in phase 2, you can do a series of studies, but in each of these studies, in addition to studying immunogenicity, we also look at safety events. Now, this is done in hundreds of participants, and when you move to phase 3, then we are looking at thousands of participants. And the idea here is to get safety events that might be less common than the reactogenicity that we can pick up in phase 1 and 2. If you have a study size which consists of tens of thousands of participants, at least half or of them receiving vaccines, sometimes with the randomization, it may be more than half, then you can start to look at rates of safety events that are much rarer than you've seen in phase 1 and 2. So there in phase 3, if you have tens of thousands of participants, you can look at safety events that might occur in 1 in 1,000 participants. So once we have this, you've got phase 1, 2, and 3 data available. The vaccine is shown to be safe. It's shown to be immunogenic. It's shown to be efficacious. It prevents the disease that it's supposed to prevent. Then you can apply for licensure of the vaccine. But the safety monitoring by the regulator does not stop with the licensure of the vaccine. The manufacturer is expected to provide periodic safety update reports to the regulator, and this continues for a variable period, at least 3 years for new products, but can be continued for longer. In addition to that, when we think about vaccines, when vaccines are used, there is an additional safety requirement because vaccines are given to healthy people. So what WHO advises is for every country to have a system that is called the National Adverse Events Following Immunization Surveillance System, National AEFI Surveillance System. And in this system, there is a structure for when vaccines are used in programs. And the structure is a tiered structure. There is a national AEFI committee, which is the top tier. At every state, there is a state AEFI committee. And in every district, there is a structure for recording and making sure that every adverse event that might potentially be related to immunization is appropriately investigated. When we give vaccines, the kinds of side effects that we see might be due to the vaccine itself, or they might be related to the process of vaccination, because people who give vaccines can make mistakes. So for example, if we take a child who goes to an immunization facility, is given a vaccine and suddenly has seizures, how will we figure out what is going on with this child? The process is that a first information report has to be filed from the immunization facility. This report goes to the district immunization officer. The district immunization officer arranges for an investigation to try and figure out why this child has seizures, makes sure that the child is looked after, and then looks at the vaccine that that child was given, looks to see whether there were other children who were vaccinated at the same time and they had similar events or not, and then sends that report to the state. It goes from the state to the center Follow-up reports are required and are filed. And ultimately, it will be the National AEFI Committee that will make a determination of the relationship between the vaccine and the safety event that will be done once all of the information is available. So when we look at regulatory systems for vaccination safety, there is a structure that exists pre-licensure, but there is also a structure for post-licensure. I'd just like to take 1 minute to talk about emergency use authorization, which Dr. Ishwar Reddy had brought up. When we are in a hurry to get a vaccine, the question always is, are we compromising safety to get this vaccine as quickly as possible? And I think a lot of people don't have clarity on what an emergency use authorization is in the rest of the world and with the WHO. So I think it's very important to understand that an EUL or an EUA or a conditional market approval is not permission to use the vaccine when you want, where you want, as soon as this approval is available. It continues to be a very highly monitored process. It is temporary, and the requirements for safety monitoring do not go away. So in fact, it's been shown that in some situations with the EMA, if you have an emergency use authorization, it actually prolongs the path for that product to full licensure. So it's very important to ensure that we have a clear understanding of what steps are taken at what stage and the safety of participants in trials and the safety of those who receive the vaccine once it is licensed continue to be front and center of our regulatory systems and our immunization programs. So thank you very much for giving me this opportunity, Madhavi, and back to you.
Thank you, Dr. Kang, for your informative presentation on especially safety issue with respect to clinical trials and also from the regulatory perspective. Now I invite Professor Ashok Mahapatra. He is the Vice Chancellor of SOA from Bhubaneswar. He was the head of the Neurosciences Center at AIIMS earlier in New Delhi. And he also served as AIIMS Director in Bhubaneswar from 2012 to 2016. Currently, he is VC of the SOA University in Bhubaneswar. And he will be, he is associated with COVID-19 vaccine trials in hospitals now. He will tell us about the clinical perspective of the COVID-19 vaccine trials.
Good afternoon.
Thank you.
I think, namaskar, all the panelists and the participant. From very beginning, I send my condolences for 1.3 lakh people in India, those who have succumbed, and about 9 million people, those who have suffered, and over 1.4 million people, those who have died in the world because of this pandemic. We ourselves had 2,200 COVID hospitals spread over 5 hospitals, and in Bhubaneswar, we had 850 bedded hospital with 150 ICU beds. So we know how the people of COVID are demoralized. Now there are several questions as a clinician, as an administrator. We will be dealing with procurement vaccine, storage of the vaccine, and distribution. So out of 4 chain, production, storage, transmission, distribution, and the priority, we will be dealing with 4 parts. And if you do first thing, safety of a vaccine, our drug controller, Mr. Reddy and Mr. Kang has already told safety. But as a clinician, first time I heard that the Oxford vaccine started the phase 1 is 10th of April. In month of July, when the WHO reviewed the vaccine, That time it was told the clinician would be able to get it by the third quarter of 2021 or maybe by June 2021. That time we thought the vaccine which takes about 10 to 15 years can be compressed to 2 years. Now when as a clinician we see the vaccine manufacture and research, that whatever may the speed of translational science, it compressed to 10 to 12 months. Then the question arises, what is the safety? What is the efficacy? The efficacy is that when I see a patient or I see a person whom I advise, I say take a vaccine. Then the question, when is the antibody going to form? How long it's going to pick up the antibody? How long the antibody going to stay? Do I require second dose or third dose? Because people know polio. When we are children, for cholera, every year we are taking 2 vaccines because the cholera vaccine efficacy stayed for 6 months. And when you look at the world literature, the WHO said that if the vaccine comes by October, November, its efficacy and safety will be severely compromised and it will work between 2 and 20%. If it comes through April 2021, the success rate will be 50%. That means if the vaccine is taken 1 year study period, there will be enough time to see the safety, complication, and rectify the mistakes. If the vaccine comes by December 2021, the success rate will be 85 to 90%. Now the question arises, what vaccine? Next question, what vaccine? It is live attenuated vaccine, it is killed vaccine, it is spike protein, it is a messenger RNA, or it is DNA. We know that there is confusion in the mind of the doctors, researcher, administrator. What is the vaccine they are going to procure? Which patient will be getting what vaccine with what efficacy? So we are giving vaccine as a phase 2, phase 3. We decided the first 18 years to 55 years. Then we thought dose 1 on day 1, dose 14, day 28. Then we follow for 2 to 4 weeks to find out the immunogenicity by using IgG, IgM, CD4, and also CD14 and CD16. The question then arises, all these studies done in thousands of patients, can it be compiled and composed so short a time that we will be able to data? Because data which was taking 10 to 15 years, now is compressed to 1 year to 10 months. So there is a very, very question of safety. Next question arises, who will get the vaccine? When you say ethics in medicine, the first point of Hippocratic Oath say there should be no discrimination in the patients. The patients are equal, whether child or adult, rich or poor, influential or non-influential. When a vaccine comes to a clinician, can he prevent that ministers don't ask for it? Minister will not take for his grandchildren and grandchildren. How do you prevent? Where is the Lakshman Rekha to say this is only for corona warrior, the hospital worker, the first line corona warrior, police people, those are involved in the emergency services. The question then arises, will we be able to regulate this vaccine to the phase 1 or first phase of giving to the people those who need it? The need is the people, those who deal with serious patients in the hospital, COVID doctors or COVID staffs, and people, those who are high risk. Then the question arises, do the high risk need the vaccine, or if the patient need the vaccine, then how many doses? Because they are immunocompromised, they may have protein deficiency, they may not be able to generate as much of immune status as a normal healthy individual. A study said from the WHO published in New England Journal of Medicine, a study done at Arizona say that 30,000 patients who studied, their antibody disappear in 3 months' time. Patients, those who suffered from COVID, their antibody disappear in 3 months' time. A study done from Iceland say in 1,038 patients that they studied 3 months and 6 months and the antibody is still persisting. So we do not know how frequently you will require vaccination for a clinician. We do not know if after vaccination 1 or 2 doses, how long a optimal level of antibody will be persisting so that we confidently tell our people that you have taken the vaccine and for 1 year you are not going to suffer from COVID. These are not a question which is answered by the basic scientist or the administrator. Because when I give a vaccine to my patient, he asks, doctor, you have given me vaccine, do I need a second dose? How long I will be protected? Do I have to have a booster? This question has to be answered, and there is no answer for all these questions. Now it comes about immunogenicity. We are not doing study in every individual immunogenicity. Immunogenicity depends on the host, the type of the vaccine, the nutrition of the host, age of the patient, and immunocompromised state. The people with low hypoproteinemia, people with immunosuppression, they will not be generating or forming same amount of antibody as a healthy individual. The question then arises, is the immunogenicity of each individual, as you are presuming, are equal? Now, another ethical issue arises. We have not tested in the children below 18 years. And children in India, if you take below 15 years, they constitute 25% of the population. If I extend to 20 years, they're 30% of the population. We are so scared that we have closed down the schools and schools are not functioning. On the other hand, we think children are very least susceptible and they don't require vaccination. So when you think an ethical angle, scientific angle, if we are so confident that children do not suffer, they have a 1.10% risk and 0.1% mortality, why do we have closed the school for these children? These are very, very diagonically opposite question. We are not scared for the children. We do not want them to be vaccinated, yet we don't want to give vaccine for them. So there are ethical issues, there are moral issues, there are scientific issues, and more importantly, nobody discuss about, we discover syringe. How many syringe will be required? 8 billion syringe required. But what about transmission and distribution loss? A sister is giving a vaccine, the vaccine falls from his hand, is destroyed. The destruction of vaccine during transport. We know even blood bank, 20% blood bottles are destroyed while they're waiting for the transfusion. We know pharmacy, you go to any pharmacy across India, any medical college, 20% drugs are outdated because they are not being distributed. So when you talk about India has 1.3 billion people and you say you require 1.5 billion vaccine, don't understand there will be transmission damage, there is a distribution problem, and we may have to ask for 30 to 50% extra. That is my concern. How to store it, how to distribute, what is the ethical angle? Can I refuse a child? Can I refuse a politician, mantri? Can I refuse mantri? No, you are not in the first phase. You are second phase, you are for 2 years, because total vaccination will take 3 years. So in a family, 5 out of 5 people, you give vaccine to 2, tell 3 not to take. How ethical is this? How it is possible in a village, you go to a village, to a house and tell in your house only 2 will be given vaccine, 3 will not be given. So these are the very, very important issues for which we do not have no answer. So I think I have only told my problems when I have to give in a vaccine to a villager or a hospital or a COVID warrior. We don't know many answers. Thank you very much.
Thank you, sir. Thank you for raising all the ethical, moral, and scientific issues. Before distribution, what we need to be taking care of, these are the issues you have highlighted. Thank you very much, sir. I'll be inviting now Dr. Nitin Jain from Department of Biotechnology. He will be speaking on biosafety issues in preclinical trials with regard to biologicals in general and also specific to COVID-19 vaccines. Dr. Nitin Jain.
Yeah, thank you, Dr. Madhvi, and good afternoon, everyone. And I thank all panelists for excellent discussion and these points raised during the panel discussion, during their talk. So as a Department of Biotechnology has a mandate for biosafety and biosecurity issues, so I will limit my presentation on in general biosafety and biosecurity issues, and Some of my slides are specific to the COVID-19, how we dealt the COVID-19 application and how we facilitate the Indian industry to come up and do R&D in for development of COVID-19 vaccines. So next, please. Next slide, please. So we have several strengths in terms of biotechnology or biosciences infrastructure. We have more than, I think, 50 bioincubators, biotech park. We have very vibrant biotechnology industry in our country. And as a country, we are major global player in vaccine supply. And there is boom in bioscience research in public and private institutions. Department of Biotechnology itself is supporting 16 state-of-the-art autonomous institutions which are engaged in high-end research, basic research, and translational research. However, there are challenges. On the one hand, there is need to foster the technology and encourage the practices. On the other hand, we must ensure biosafety and biosecurity while using modern biotechnology. So for leveraging the modern biotechnology for sustainable growth and development requires its regulation in a manner that can ensure biosafety and biosecurity and also assess the risk associated with these issues. Next slide, please. Yeah. In India, biosafety regulations are governed by the rules 1989 framed under Environment Protection Act 1986. Rules mandate protection of human health and environment from harm, if any, caused by the activities involving use of genetically modified organism and hazardous microorganisms. So this rules 1989 prescribes 6 statutory committees. So I have mentioned 3 committees on the slide. First one is Institutional Biosafety Committee. Second one is Review Committee on Genetic Manipulation. And third one is Genetic Engineering Appraisal Committee. Other committees are State Biotechnology Coordination Committee, District Level Committee, and Recombinant DNA Advisory Committee. So just I would like to discuss about Institutional Biosafety Committee, Review Committee on Genetic Manipulation, and GAC. So Institutional Biosafety Committee functions at the site of the host institution, which is undertaking research and development activities using recombinant DNA technology or using hazardous microorganisms. Review Committee on Genetic Manipulation functions in the Department of Biotechnology, and Genetic Engineering Appraisal Committee functions in the Ministry of Environment and Forest and Climate Change. GAC is responsible for the large-scale permissions. Review Committee on Genetic Manipulation basically has mandate to review the R&D activities using the recombinant DNA technology and hazardous microorganism. Next slide, please. Yeah. So RCGM, as per the rules 1989, is functioning in Department of Biotechnology and has mandate for protection of human health and environment from harm, if any, caused by the activities involving microorganisms, genetic engineering organisms, cells, and product thereof. So these rules covers manufacture, import, and storage of microorganism and gene technology product, GE organism, hazardous microorganism correspondingly to any substance, product, foodstuff, etc. These rules are also applicable for new gene technologies, CRISPR-Cas, zinc finger nucleases, and other emerging biotechnologies. And specific cases of cell, offer to cell, storage for purpose of cell, exportation and importation of genetic engineering cells or organism or hazardous microorganisms are also covered under the rules 1989. Next slide, please. Yeah, next slide, please. So just I would like to previous one, please. Yeah, I would like to share the recent updates we did in the Review Committee of Genetic Manipulation. So earlier we have 1990 guidelines, recombinant DNA safety guidelines, which was revised in 1994 and 1998. Recently, actually in 2017, during the meeting of state parties at Biological Weapon Convention, Geneva, we come out with regulatory guidelines and recombinant DNA biocontainment guideline 2017. This containment guidelines give the requirement of containment for safe work at microbes, animal, plants, insects. Also, it gives the information about the categorization of genetic engineering experiments. So 3 types of experiments are categorized: category 1, category 2, and category 3 type of experiments, which requires various level of approvals. Then risk assessment of GMO has been elaborated in the recent guidelines, and risk group classification of microorganism has been updated in 2017 biocontainment guidelines. Next slide, please. Yeah, next slide, please. Yeah. In January 2020, Department of Biotechnology, after approval of a review committee of genetic manipulation, issued a simplified procedure for import and export of biotechnology items for research and development purpose to facilitate the preclinical studies and product development of biopharma. So I was telling that institutional biosafety committee, which functions at the site of host institution, actually that committee was authorized to approve the import and export of biotechnology items for research and development purpose up to a fixed quantity. If quantity is more than whatever is notified in the simplified procedure, then RCGM approval will be required. So in short, actually, this process has cut down the time required for the approval of import and export permits. So most of the things, about 80% cases of import and export, may be dealt by the institutional biosafety committee, and they may issue the requisite permit. All the items belonging to risk group 3 and 4 transactions are required to be considered by the RCGM for the approval. Next slide, please. So now we come to the COVID-19 related issues. So recently we have operationalized the Indian Biosafety Knowledge Portal. However, the portal was launched in May 2019, but with from February, March, it has been made fully functional. So we are accepting the applications online and also issuing the authorization online. We have also issued rapid response regulatory framework where timelines have been fixed for dealing with the COVID-19 related product development applications. Then during the lockdown situation and prevailing COVID-19 situation, we allowed IBSCs to hold meeting online. Next slide, please.
Dr. Jain, you have 1 minute.
Yeah, ma'am, please. Yes, sure. So this is the development with respect to COVID-19 related applications. We have fixed the timeline. We are offering the permission for initiation of R&D work and import and export and exchange in 7 days. Also evaluating physicochemical molecular characterization related applications in 10 days. Then we also issued the checklist for recombinant DNA technology-based vaccines for COVID-19 and also interim guidelines for laboratory biosafety to handle COVID-19 specimen. So all these have been, a compilation has also been issued in this regard. Next slide, please. So this is regarding the applications we received for the COVID-19 related research and development work. From February 25th to till date, we have received 237 applications of COVID-19 related R&D work. Means in general, we are getting on an average 1 application per day. And we also address the queries of the applicant with respect to biocontainment requirement for conducting COVID-19 related R&D work. Next slide, please. This is the handbook of Institutional Biosafety Committee, which was issued in September 2020. So this is the general handbook and a revised version of the handbook, which was earlier issued in 2011. So it gives about the operational requirement of the IBSC's roles of the member secretary, chairman, and the outside member biosafety officers of the IBSCs. Next slide, please. So with this, I thanks all the panelists and organizer.
Thank you, Dr. Jain. Now I invite all the speakers for panel discussion. I request now Dr. Ishwar Reddy to answer some of the questions. Actually, with the regulations, when at a, within the short span, when the I mean products are being licensed, the issue comes: what is the threshold for a regulator point of view of an efficacy or safety that qualifies licensing of a vaccine? Can you tell us about this, whether what are the criteria based on this, which these thresholds of safety or efficacy are determined? Are there any such considerations for defining particular threshold for declaring that particular vaccine is safe or efficient, especially with respect to COVID-19 vaccines? This is number one. Another is, what kind of compensation is available for you said you will be monitoring, there will be monitoring of trial, vaccines for quite some time. What kind of mechanisms exist for the compensation? Who will pay for them? How do they determine whether it is a vaccine adversary reaction or not, whether compensation should be paid or not? Who will determine? How will it be decided? Is it from the regulator side, or are there any other committees that will be assessing those kind of safety issues or any kind of adverse events, or even with related to vaccine efficacy during the clinical trials? Hello? Hello? Yeah, am I audible? I can't, voice is breaking.
I think we've lost Dr. Reddy for a while here, I have a feeling, but Professor Ashok is actually ready to share his views if you allow.
Yeah, on the
can I just tell?
Yeah.
Yes, sir.
And we have Dr. Reddy back too.
Yeah. Achha.
Dr. Reddy, you need to unmute.
Yeah.
Yeah.
Yes.
Is it audible, Madhavi?
Yeah, now it is. I don't know whether you heard my questions or not, because
No,
I couldn't
heard
hear.
your question. Yeah, I heard your both questions. In fact, just last 30 seconds, only some problem with my net. But you know, Madhavi, in fact, this is a very great challenge to the Indian drug regulators about the ensuring the efficacy and the percentage of efficacy of the vaccine minimum at the time of approval. In fact, we are in consultation with various agencies and the organizations. We are also, in consultation with the ICMR, DBT, other experts in this area, and we are also in touch with our counterparts of US FDA and MHRE, other international regulatory authorities. We are also going through the guidelines, draft guidelines issued by the WHO on the efficacy of this corona vaccine. So at present, I think what our committee has suggested is that in principle, we would like to go by what WHO has suggested. So as per the WHO draft guidelines, the minimum, at least the preferred measure of efficacy should be at least 70% of the efficacy. That is what actually we are expecting. Otherwise, at the minimum should be. Otherwise, it is at least 50% of the estimated. But it is a continuous process because of the we need this vaccine at the earliest without compromising the safety and the efficacy of the vaccine. Whatever the best possible way based upon the data available, we will ensure this early accessibility of the vaccine. As Kang Madam said rightly, the safety efficacy, we have to keep it in mind before grant of any marketing authorization. But I am sure the way results are claiming at present by the manufacturers, of course, these claims has to yet to be reviewed by the regulator, and this data is yet to be published in the official the journals. Yeah, I think it maybe take some time, but as per the preliminary information, whatever available through media and the claims by the manufacturer, it is very encouraging, and I think very good results what we are understanding from them. But I'm sure as a regulator, we will ensure the safety and efficacy and immunogenicity of the vaccine before grant of any marketing authorization to the either local Indian domestic manufacturers or imported vaccines. So coming to your second question about the compensation, as I said in my initial remarks, we brought this mandatory provision of compensation in our new drug clinical trials and new drug rules 2019. Earlier, the formula for
conditional. I mean, does somebody has to prove that injury has occurred?
I'll come to that. So in fact, we have specified the timelines for reporting of serious adverse event by the sponsor, by the ethics committee, even by the principal investigator, and we have very clearly defined timelines for all the stakeholders of the clinical trials to submit the serious adverse events, including any grievous hurt or any death related. For this purpose, we have set up a serious adverse event monitoring expert committee. All these serious adverse events are reported to that committee, and committee will do the causality assessment. As you said rightly, whether this event is related to the IP investigational product or whether it is not related. So the committee will do the detailed causality assessment, and if any adverse event is proven to be it is because of the violation of the any clinical trial protocol or because of the IP product, then they had to provide the compensation. We have very clearly defined formula to determine the compensation. With well-established formula, well accepted by industry, patient associations, NGOs, and globally many other regulators are looking at a Indian formula for the compensation. And it is the responsibility of the applicant. Generally, it is a sponsor. It is responsible to pay the compensation. So it is legal mandatory now. So it is the responsibility of the sponsor has to pay. Thank you, Madhavi.
Thank you, sir. I have one more. Shall I ask you last question?
Madam, can I just answer this question?
Yeah, sure. Related to
that. When I saw the protocol in my hospital, there is no indemnity. There is no point of after the end of the study say what is the indemnity and what is the insurance and is the protocol. Protocol is approved by the ethics committee. I saw the AstraZeneca. There is a compensation or no? The AstraZeneca and Pfizer, there is no indemnity. The question is that when a protocol is approved, if the person is not, that protocol doesn't mention what is the compensation a person get, there is very bad legality. The question is that none of our protocols say in this study there is an indemnity. That should be insurance for the patient so that he dies or have an adverse, or he has a polio, he has a Guillain-Barré syndrome, he has a encephalitis. What will happen? I don't think there is a very clear-cut guideline in these protocols. And if you go to Pfizer and AstraZeneca website, there is nothing mentioned about indemnity. Thank you very much.
Just I want to convey the legal position. The 7th schedule of new drug clinical trials and new drugs 2019 clearly spell out the regulatory mandate of providing the compensation to the subjects by the sponsor, and also it is mandatory for them to submit an undertaking to the regulator along with the application to ensure that he will provide the compensation as defined under the law and as determined by the expert committee. And this is a part of the application. And also, as Saab said rightly, Mr. Ashok Kumar, this is also the mandatory to specify in the protocol and the informed consent form. These are the mandatory provisions. Thank you, Madhavi.
Thank you, sir. Dr. Kang, would you like to reflect on that from scientific perspective also? What should be the threshold for a vaccine to be, efficacy or safety also? Do you think there should be some ideal thing one should consider with regard to, we know there are a lot of knowledge gaps with respect to COVID-19 vaccine, but otherwise, what is your opinion on this?
Thank you. So I think the ideal vaccine is one where you give one shot, you get protection for life. It has absolutely no safety events. It's really cheap. It can be delivered very, very easily to everybody in the country. That's an ideal vaccine, but we actually don't have any ideal vaccine.
COVID-19,
Yes.
I think one is not sure.
Yeah.
And in fact, during this trial, I have another question to you. It seems during the trial, participants, they were told that after any time they can withdraw from this trial. If a participant has taken one dose once and then he goes away or he or she goes away, what is that participant is monitored for any other reactions? What would be we really do not know whether one dose will do any, give benefits or any risky situations would arise.
Madhavi, this happens all the time. Yeah, for a number of reasons, participants may not take both doses of a vaccine when they are supposed to take both doses. It is a choice of the participant. They have the freedom to withdraw at any time, and they don't need to give a reason for that. Their clinical care is not compromised in any way by their withdrawal. That is must be included in the informed consent form that they sign initially. Now, in terms of monitoring, the efficacy of a single dose as opposed to efficacy after 2 doses, this is something that the investigators will always request a participant. Even if you are withdrawing, would you be willing for us to follow up with you to see whether the vaccine is protecting with a single dose or not? The participant can say, no, I don't want to have any further contact with the study team, in which case there is nothing that the study team can do about that. It is the participant's decision to decide the level of engagement. So sometimes it does happen that if you have a large number of participants who've received only 1 dose of vaccine, you can get data on single dose efficacy, but usually that tends to happen when you look at effectiveness post licensure rather than when you're looking at efficacy in the context of a clinical trial. A clinical trial where a large proportion of participants do not complete the study, they drop out early, that is not a well-conducted study. because then it means that you didn't explain the study appropriately to the people who are participating in the study. So there is, when we do trials, and we do a lot of trials, the engagement with every person who is in the trial is the cornerstone of how you take these studies forward. You cannot be casual about this.
That's true. Thank you, Dr. Khan. Actually, given the even everywhere post-surveillance market studies are done, but in India, I think there are gaps in those protocols also. That's why there are concerns even after vaccination, especially with COVID-19 vaccine, how it is going to be monitored. So I'm just hoping, but whatever Dr. Ishwar Reddy also has said, that there is a system of monitoring continuously, and you also mentioned. So we are hoping to see that it will be taken care of.
If I can make one comment, in the questions and answers, Malini has raised a very important question, which is the idea of compensation in case of vaccine-related injury or vaccination-related injury post-licensure. What is the requirement for regulators, sponsors? What happens in programmatic use? Currently in India, we have no provision for this. So if a child develops polio after getting oral polio vaccine, there is no compensation that is paid by anybody. The program does not have a responsibility to pay compensation or look after that child. In other parts of the world, we actually have structures that provide support in case there is vaccine-related injury or vaccination-related injury, and the two are different. Now, in the US, you have a national vaccine injury compensation program that is funded by a tax on every dose of vaccine that is sold in the US. And this is a no-fault compensation. If the committee determines that this injury is related to the vaccine or the vaccination process, then there will be a quantum of compensation that is paid to that injured person. In India, we do not have such a structure, and I think it is high time that we begin to think about such structures being in place. In other parts of the world, there is actually a health system that looks after participants and determines the amount of care that is required to support children that are injured, children or adults that have one of these potential side effects of vaccines. Let's say Guillain-Barré syndrome after influenza vaccination. So in Europe, in high-income countries, this happens. In low and middle-income countries, this does not happen. And I think it's time that we thought about how we want to approach this issue. Thank you.
Thank you. Thank you, ma'am. I think we are running out of time, but a small question to Dr. Nitin Jain. Dr. Nitin, you said RCGM has cut down the timelines for the approvals. Did it do without compromising? How did it do without compromising on safety issues? And I think rest of the issues, I think you have anyway explained during your talk. What I understand is basically the committees are decided by at the institutional level. So institution will send you, or is it the burden is now on complete this submitting approvals with the institution lies that they have to submit in certain time frame, whatever assessment is being made on the applications.
Thank you, Dr. Madhuri. So just wanted to inform, actually, we have used multi-pronged strategy to cut down the timelines. So first thing is the online submission. Then second is actually we increase the frequency of RCGM meetings. So earlier we used to have monthly meeting. Then we reduced the time duration to 21 days, and now we are operating meetings, holding meetings every fortnightly. So third one is for COVID-related applications, we are means not waiting for the meetings. We are communicating with our members on email and getting approval of the chair and approving the applications. Regarding institutional biosafety, the power or authority delegated to institutional biosafety committee, I would like to mention here, every institutional biosafety committee has DBT nominee. So, and his presence is mandatory for taking any decision related to import and export related applications. So means there is no dilution in terms of safety, biosafety and environmental safety while fast tracking the decision. Over to you, Doctor.
Thank you, Dr. Nitin. I think we are out of time. I'm sorry because it's delay because of me also. Initially, I couldn't log in. But there are few questions to Dr. Reddy. I don't know whether we are permitted to take those questions. Nidhi, can we go
yes,
ahead?
Actually, we've already gone ahead of time. So if you don't mind, yes. Thank you so much. Thank you so much for understanding.
Thank you very much. Thank you very much to all the panelists and also all the organizers for giving me this opportunities to interact with all the well-informed people on this important session. Thank you very much.
Thank you so much.
Thank you. Thank you very much, madam.
Thank you.
Thank you very much, panelists. The next session is on showcasing innovative technologies for the last mile delivery of vaccines. It is my pleasure to invite Dr. Manish Diwan, Head, Strategic Partnership and Entrepreneurship Development, BIRAC, to preside over this session. Dr. Manish Diwan, over to you.
Thank you very much. Very glad to be to participate in this session. And this particular session has been specifically carved out to reflect what innovation technologies that have been spearheaded by innovations done by entrepreneurs, startups, and the early medium scale industry that can contribute towards the challenge of delivery of the vaccines at the last mile. When you look at in the beginning, we had challenge to prevent COVID spread, and we were looking at sanitation, PPE kits, masks, etc. We also went through a phase where we were wanting to detect COVID patients and likelihood of infections. So we were working and we were looking at solutions which are diagnostic kits, imported diagnostic kits, indigenized diagnostic kits, and availability of such diagnostic kits, testing centers, and covering as much as population of India. Then we also started covering the therapeutic arm. There was a phase when we were looking at repurposing of existing molecules and drugs to making those drugs, making available not only for India, for the entire world. And the vaccine initiative. So we have, in the last 10 months, we have reached to a position where we have been able to move from as a front runner, as a contributor in many of these sections. And some sections where we were initially started as net importers, we have become self-sufficient, Atmanirbhar, as well as we are importing, including PPE kits, the drugs, hydroxychloroquine, remdesivir, and N95 masks. This phase, now we have moved into where we are looking at vaccine delivery to the last mile. And the very fact that we are today talking about and having this conversation is because there are expectations. Expectations not only from Indian population, but world at large. Looking at India, can India contribute, and innovations can emerge from the Indian ecosystem, which can help in the delivery of the last mile of the vaccines, be it candidates which are emerging from India or outside India. So today I'm very happy and pleased to introduce, we have a interesting panel in which there are few technologies which have been which are on the anvil of development, while there are a couple of them which are already developed. So I'm joined here with can I see my panel? Can you provide the panel, all the panelists in one frame so that everybody can see to the organizers?
Absolutely, sir. If you could just give us. Yes, sir.
So in next,
can you see everybody?
Yes, maybe if you can put it on the frame so that everybody can see only the panelists, 6 of us, and that way we can have a conversation also. Anyways,
absolutely.
So we will have
yes, so there you are, and it's only the host and co-host along with your panel.
All right. Thank you so much. Thank you so much. I can see that most of our panel members are here, and yeah, so we have like professors who have contributed and created knowledge in the academic setting. We have young innovators, startups, medium scale, which have actually delivered and created the technologies, as well as both from India as well as abroad. So in the next 1 hour, what I'll do is I'll provide each one a 10-minute exposure where you can share, if you have slide deck, to the forum, and I will introduce, and then maybe we can begin with that. May I introduce Dr. Atul Sardana first, and he can show. Atul is a surgeon, and he has been associated in the innovation and delivery of solutions, including laparoscopy, trocar, coated hernia mesh. But today he will be specifically talking about the safety syringe that he and his team under Alpha Corpuscles have developed. Over to you, Atul, and you will have 8 to 10 minutes to share your invention with us. Thank you. We can see your slides. You can begin as soon as you're ready. But we can't hear you, Atul.
Did you unmute?
Okay. Am I audible now?
Yes. Go ahead, please.
Thank you, sir. Okay. So what if I was to say that, there is a technology available which can deliver the COVID vaccine to the last mile very safely, very effectively, without generating any hazardous biomedical waste at a much lower cost, and can deliver twice as much vaccine per individual provider than what we are currently planning. So as we prepare to undertake one of the world's largest vaccination drive, a lot needs to be considered in selecting the most appropriate vaccine delivery technology. India needs to cover a population of 1.3 billion, and currently media reports indicate that 2 shots would be required, and the government is allocating a budget of estimate around $7 billion. We are estimating that 2 vaccines, $2 per vaccine would be required, and another $2 in the infrastructure cost. So we are putting a total of $6 per individual over here. Now, we need to move up the value chain for COVID-19 vaccine delivery. What we are currently looking, as I heard the regulator talking about safety syringes, I'm very happy that the regulators are aware of such technologies. But unfortunately, current focus is on AD syringes, which is a very old generation technology which just locks the syringe, or you can break the plunger after use, and it does not address to the needle. And it is actually the needle which carries the infected blood from one patient. And it is the reuse of needles which is the cause of infections rather than the syringes itself. Obviously, we have other technologies such as pre-filled syringes available, but then there are certain problems associated with them. So I am here to present to you a technology which is 10 steps ahead for quick, safe, accurate, and cost-effective COVID vaccine delivery. Now we're talking about a very special safety syringe which has been developed only for vaccine delivery. It is a cartridge load safety syringe. Here, the same cold chain space can carry 10 times more doses as compared to a pre-filled syringe, thereby reducing the cold chain cost per dose to 10%. Also, it reduces the associated failures by packaging in smaller boxes, which are easy to carry to remote areas. Because we are looking at delivering a vaccine to the farthest areas in India in a very short period of time to get maximum coverage. So if we estimate the cold chain cost per dose to be 60 cents, it would be reduced to 6 cents rather than 60 cents. This technology saves 10% of the vaccine cost by reducing the need to overpack and compensate for the filling and injection losses. As Dr. Mohapatra was speaking in the last panel, he said we haven't considered breakages, filling losses, and so this is a technology which could save those losses. He had estimated 20%, but I am putting it at a conservative 10%. So we save the estimated cost of vaccine per person is $4. We can reduce it to $3.6 immediately. It also saves on the breakage, which is estimated to be around 1%, because the cartridge over here is a polymer cartridge and not a glass cartridge, though we can develop the same technology in glass if there are any regulatory issues. But the polymer itself has been tested to -50 degrees and can further be tested to -70 degrees in case we are looking at an mRNA vaccine. It would save 20% on the freight cost due to lower weight of the cartridge and as compared to the vials and the pre-filled syringes. It would take 50% less time per injection as compared to vials and syringes. Hence, more number of people can be vaccinated in the same time. So same staff, same hospital can inject twice as many patients per day, thereby reducing the coverage time to half number of days. There are zero chances of contamination while filling, so that there is no residual infection to take care of after the vaccination drive. A lot of vaccination drives in the past have actually witnessed reports coming up saying there was a vaccination camp in so-and-so village, and 1 year down the line, we find the entire village is HIV positive. So there are no chances of this thing happening. It also ensures 100% consistency in administering the dose as compared to syringes, thereby reducing the variability in the immune response, which could be due to the dose variability. It has 100% safety integrated into it, which prevents reuse and accidental needle stick injury. Now we all know that reuse of syringes and accidental needle stick injury puts a direct cost of more than $600 billion worldwide each year to manage the diseases spread by bloodborne infections from such unsafe injections such as HIV, hepatitis B, and hepatitis C. India itself has about 78 lakh infections every year from unsafe injections, 3 lakh deaths, and a direct medical cost of 700 crore rupees. If you look at the global figures, is 1.2 million early deaths. That, if you put on a time scale, is 1 death in every 24 seconds, which is higher than the toll of most of the lethal diseases that we have. The use of this syringe requires minimal or no training. It does not require any user participation to activate the safety features. Once the dose is complete, the safety features are deploy themselves automatically. There is no requirement for sharp disposal boxes. Now imagine the number of people we need to vaccinate. We need to carry the empty sharp disposal boxes. carry them back with us. That is going to save time, because once the syringe locks up, there is no part or no sharp part which is there which could injure anybody. So you could simply carry the biomedical waste in bags and then have them disposed as per the guidelines. So there is an effective reduction in the biomedical waste because the boxes go away. The design is 100% tamper evident, so you get unparalleled safety and security. The design is compliant to WHO and the relevant ISO standards, and the cartridge itself can go into existing filling line for all pharma manufacturers. The cost of this is estimated at less than 15 cents. This technology is now ready, available, and it has been developed with financial assistance from BIRAC, and we have done a clinical trial covering 2,000 patients in India with assistance from ICMR. For any further details, you can contact us. I would also like to show you the syringe itself. This is the cartridge. This is the cartridge. This is the only part that stays in the cold chain, not the entire pre-filled syringe. And it takes almost 1/10 the space as compared to pre-filled syringes, and it provides the safety and efficacy of a pre-filled syringe or a pre-filled safety syringe. It's a single step to load the cartridge inside. These cartridges can go into existing filling lines, which are there available with the pharma manufacturers. Thank you. I'm open for any questions now.
Thank you so much, Atul. I think you clearly brought out that a technology intervention like this can potentially save the precious doses of vaccine by reducing as much as 10% overages, which are required for distribution in the unit packages, as well as the safety syringe can potentially prevent the inadvertent needle-related injuries when we are looking at mass vaccination at such a large volume. Thank you for bringing it up.
And 1/10 of the cold chain space, sir, which of course is one of the biggest pain points currently we have with this vaccine.
So that makes me bring and introduce our next speaker, Dr. Samit from Plus Technologies. He and his team has brought in and working on the energy excess, and they have been able to build a first-in-class Mira cradle for babies that has been able to keep the baby cool in up to three days. And they've also created a product for fine chemical deliveries in the pharma sector, the CellSure, and maybe he will want to showcase and reflect more how it can facilitate the last mile delivery of the vaccine. Over to you, Dr. Samit.
Thank you, Dr. Manish Devan, and thanks BSMA for this opportunity. I will quickly share my screen and walk you through what we have done. So is the screen visible to everybody?
Yes, please go ahead.
Right. So what we as a company have been specializing in is temperature control across sectors. So as Dr. Manish mentioned, we did a product for keeping babies cool, that is treating babies born with birth asphyxia. So we have done medical devices, we are looking at logistics, buildings, etc., wherever we need temperature control. And we do this using special materials that we excel in, which are called as phase change materials. We have looked at neonatal death, we have looked at building energy efficiency, we have looked at food wastage. All of it needs temperature control, and current focus is on the vaccine wastage or the vaccine delivery, which could need different temperatures, right from -70, as we are talking of the Pfizer vaccine, for example, or a lot of other vaccines at -20 to -30, and the traditional vaccines, which we have always been used to and delivering and administering at the 2 to 8 degrees Celsius range. I will not spend time on the challenges. We've talked a lot about it through the day. What we are now looking at is looking at freeze-safe vaccine carriers for a lot of the vaccines which need to be at 2 to 8 degrees. And when you use conventional ice or ice packs, the chances that the vaccine goes below 2 is very high. And that itself makes the vaccine ineffective. So we have used our materials to create a box which will always keep the vaccine above 2 degrees Celsius. We are now looking at -20, and we're also looking at -70. And these are possible using these materials, which we define as phase change materials. They change phase from solid to liquid and liquid to solid. Water is the best example that we are familiar with. You freeze water, you get ice. You melt the ice, the product that the ice is put into becomes cool because the heat is either absorbed or released. But that happens at 0 degrees Celsius. So we have designed materials right from -30 currently to +100. And depending on what temperature we want to maintain, we use the appropriate phase change material. And these are also often referred to as thermal batteries because they store thermal energy. It's essentially a thermal battery, a temperature regulator, and a good heat exchanger, the way you design the whole thing, and that together forms the phase change material. So the three most common temperature ranges one is looking at is 2 to 8 degrees Celsius, 15 to 25 for a lot of pharmaceutical products, -15 to -25, and now, as I said, -70. And for these three different categories, we use three different phase change materials as against either cold water, dry ice, or gel packs or ice packs that people typically have been using. So we have developed several solutions. You can see some pictures on the right. The bag that you see is currently being used by the likes of, let's say, Dr. Lal Path Labs and others to start collecting the samples that you're doing for testing. It has a backup of 10 to 12 hours and can maintain a temperature between 2 to 8 degrees Celsius. We are now working on a vaccine carrier, which we hope to launch in 2 or 3 months' time, which will ensure that the last mile vaccine delivery will never be below 2 degrees Celsius, especially when you look at polio vaccines, you look at DPT, measles, etc. They all need the 2 to 8 temperature. We are looking at hard case boxes, which can be for as long as 24 to 48 hours, and even beyond that, we have tested till about 120 hours. This product is under the brand name CellSure, and in the last 2 years, we have started working with a lot of pharma companies for the first mile, where from the manufacturing unit till the distributor, the vaccines are packed and then distributed at the right temperature. So for example, if you're shipping from, let's say, Hyderabad to Africa or Hyderabad to South America, you're looking at 4 or 5 days of temperature maintenance in a passive way. These have been tested as per the standard test methods followed with backup durations of up to 120 hours. These boxes have also been integrated with a lot of smart sensing to real-time monitor the temperature, the location, the vibrations. The box shouldn't break, the vaccine vial should break. Very often light penetration could also affect the medicine that is inside, for example, or the vaccine. So these can easily be monitored and notifications sent on an app on your phone. These are some validations I'll show you to indicate the kind of temperatures these have been tested against. The red color tells you the atmospheric temperature varying from 20 degrees to 35, and you get a backup of 120 hours, and the temperature never goes below 2 or above 8. This is at a -5 degree ambient. The red color again is showing you a temperature which is there, and the blue color, which is the temperature that is maintained inside the box. Again, a backup of more than 115 hours or so. This is a customer validation that was done with varying temperatures, right from plus 20 degrees to as high as plus 40. But the temperature inside the box remains above 2 degrees Celsius and below 8 degrees Celsius for as long as 150 hours. At the minus 15 to minus 25 range, in an ambient of 35 degrees Celsius, for example, the temperature is still between minus 15 to minus 20 for about 120, 130 hours. What we are looking at now are better insulation materials. We are all familiar with the vacuum flasks that we use. So we are looking at using vacuum insulation panels to be able to create the box, which could be lighter, which would be probably much more easier to handle, less space. And as you see in the picture, something like, a polyurethane foam that we are used to, 145 mm foam can be replaced with a 35 millimeter vacuum insulation panel. Costs, of course, will be a challenge, but then a lot of vaccines which are very expensive, for example, or medicines which are expensive, it would really prove useful. We are looking at more user-friendly ergonomic designs for the last mile delivery, how it can be, for example, mounted on a two-wheeler more easily with different chambers that can be done. So a lot of ergonomic designs are necessary to ensure that the work becomes very easy for the last mile worker that we have, who has to go from door to door and administer the vaccines. This is another last mile delivery solution that is being done, extremely rugged and using phase change material liners. The yellow green color that you see is going to be a liner inside the box to ensure, along with the conventional ice packs, which is in the blue color, to ensure that your vaccine remains above 2 degrees Celsius at all points. So this is being done in partnership with PATH, and we hope to be able to launch it. And most of the COVID-19 vaccines also, while it will be stored at minus 70 or minus 20, the last 24 hours will always be at 2 to 8, because you cannot quite inject something at minus 70 degrees straight into the body, right? So there would be a huge requirement, we foresee, for the 2 to 8 degree solutions at the last mile. What we also did for the Tata Medical and Diagnostics, for the CRISPR kit that they have launched, the Tata MD Check Feluda based kit. So this is the box. From the outside, looks like any other box, but inside we are able to maintain the minus 20 degrees Celsius using the phase change material. And one section has a 2 to 8 degree for the reagents that they carry. So this has been done in a record time of about 2 months, working very closely with Tata Medical for getting the solution. In fact, Delhi today said that they will start using the Feluda kits effective today or tomorrow. So we see that it is really possible to use advanced materials, move away from dry ice or move away from regular ice packs to ensure the right temperature maintenance. We've been working with DBT funding for a lot of our medical device products. We've been working with UNIDO as well as CII on a lot of these projects, and I'm open to any questions.
Thank you, Dr. Samit. Would you also like to let us know about the price point of this particular delivery device?
So we are looking at prices when you're looking at, let's say, something like a 5-day or a 6-day maintenance, and you're looking at a capacity, a vaccine carrying capacity of, let's say, about 7 to 10 liters. You're looking at a price of 3,000 to 5,000 rupees for a box. So when you're shipping vaccines from Hyderabad to, let's say, South America, as I mentioned, and you want a 5-day duration, that's the kind of cost you may be looking at. When you look at the reusable solutions we are talking about for the last mile, we are again looking at something like 1,500 to 2,000 rupees, but then it's reusable, so it's going to be pretty economical in the long run. So costs will vary between 2,000 to 10,000, depending on the size and the durations that you typically look at.
All right. Thank you so much. I think connected with this in a similar thought process, I would now introduce Mayur Shetty, who is the founder and CEO for Black Frog Technologies. His team is also, his startup has also come up with a solution which can carry vaccines and perishable biologics in the ambient temperature. Over to you, Mayur.
Yeah, thank you, Dr. Diwan. Just please give me a moment while I share my screen. Host, may I share the screen?
Yes, we can
Absolutely,
see the
yes.
slides. Go ahead.
But you can go ahead and share the screen as well. Please go ahead, Ms. Mayur.
Okay. Yeah, my screen is visible, right?
Yes.
Yeah. Hi, hello everybody. I'm Mayur Shetty. I'm CEO of Black Frog Technologies. We are a technology startup company based out of a small town called Manipal in coastal Karnataka. A little bit of background on our work. In about 2017, BIRAC funded us to develop a portable medical grade system to address the last mile problems associated with the delivery of vaccines. And I'm pleased to state that we're now live in 3 states in India, and the product has won us about 6 national awards, and we've represented India in 2 international events as well. I'll just briefly talk about the context of the problem that we're solving. It was quite extensively discussed today. The vaccine supply chain is very well understood, but BIRAC in 2017 entrusted us with finding a viable replacement for the ice boxes or passively cooled containers, which have typically and been used over a century now for transport of all thermally sensitive biologicals. The problem is that while temperatures drop below 2 degrees Celsius, there's also no accountability or form of active monitoring inside this particular chambers. India has had a very successful universal immunization program. It's deemed as one of the most successful public health interventions all across the world. But there's also a slightly darker side to this, where when we go about administering polio vaccines, we know that the recommended dosage is about 3 times, but there have been reports of going 8, 9, 10 times as well, because we know that the vaccines that we've been administering could possibly be thermally degraded before the time it's administered. The Immunization Technical Support Unit under the Health Ministry claims close to 25% of all vaccines go to waste before they're administered, and almost 73% of this degradation happens in the last mile, and that's predominantly because of use of ice boxes. So while we've had the factors of time and resources in place for mitigating any other vaccine preventable diseases in the past, that's not the case right now with the COVID-19 vaccine in the horizon. It's not only a limited resource, but to give an unviable vaccine while people are expecting a magic bullet is probably the nightmare scenario. And that's what we are trying to address with a actively cooled portable device. And I'm very proud to announce that we've been successful at it over 3 years of R&D on this, where we've developed a portable and rugged battery-powered system that can maintain a preset temperature between 2 and 8 degrees Celsius for up to 12 hours in the field. The device weighs just 5.5 kilograms. It fits into a backpack, can be worn as a sling bag as well. We've designed the cold chamber in the same form that a typical blue box commissioned from UNICEF is able to carry. It's about 2 liters in capacity. That's usually the day-long transport limit. And 2 to 8 degrees Celsius is what we focused on because, just from the earlier conversation as well, Dr. Harish Iyer mentioned about Pfizer's vaccine and Moderna's vaccine as well. All of them, regardless of what the storage temperature is, the last mile is still going to be 2 to 8 degrees Celsius. Pfizer's vaccine is thermostable at 2 to 8 degrees for up to 5 days. I believe Moderna's is up to 30 days as well. So end of the day, it's going to come down to passively cooled devices or ice boxes that have to transport from primary and sub-health centers till the point of administering. And the reason that we worked on a solid state cooling, actively cooled product is that it brings about 2 distinct advantages. One is the fact that there is uniform cooling all throughout the cold chamber, which means there are no hot spots or cold spots. All of the vaccines are assured a temperature between 2 and 8 degrees Celsius. And secondly, and most importantly, a ground reality when you administer vaccine is that an A&M or a healthcare worker has to open the device every now and then to retrieve the vaccine to administer, which means every time you open the vaccine, you subject all of the contents to the ambient air. So this enormous amount of freeze-thaw cycles happening. So now that's where an active cooling device comes in, where every time you shut it, our system is able to bring the temperature, stabilize it back to safe limits, that's 2 to 8 degrees Celsius, over 96% faster than a passively cooled system can. And this is very critical because apart from thermal degradation directly because of prolonged periods of exposure, it's freeze-thaw cycles which degrade the biologicals as well. And we've had some successful results from our field trials that we've been implementing over the past 2 years. Just like to point out one of them where we're working with Kasturba Hospital for transport of routine vaccines. So we use these data loggers in their system, and we carried out the same trial with our device as well, where wireless temperature loggers were used in the system. And then the blue line is the 2 degrees Celsius mark, and the red line is the 8 degrees Celsius mark. So on the left, you can see that the icebox commissioned from UNICEF is constantly dropping the temperature below 0 degrees Celsius and freezing the vaccines. So this translates to about $7.5 million worth of vaccine wastage every single year in India alone because of using ice-based system. And this is a pre-COVID scenario. So we can totally understand the kind of ramification it will have when we'll have a temperature control dependent COVID vaccine in the horizon now. On the right, you can see our system is able to maintain a very stable 4 degrees Celsius platform with an error of less than 0.5 degrees Celsius. And we developed this about mid 2019, and we started deployment towards the end of the year. And I'd just like to pinpoint some of the use cases. So earliest customers were Selco Foundation, and one of the deployments was a very interesting use case in a remote hospital called Sargur in Mysore, where they're using our device to transport routine vaccines to a local tribal community who are otherwise inaccessible and kind of cut off from civilization. So now they're able to transport vaccines and immunize twice as many kids every single day because, due to change of vaccine transport from ice boxes to an actively cooled device. So they have a mobile health unit with a solar powered system on board. So they're able to reuse the system every day, and not to mention they're able to bring back the vaccines that are left over at the end of the day. So they're claiming a savings of about 13,000 rupees worth of vaccines every single month from use of our device. And towards the beginning of this year, when we were scaling up our production capability, that's when the COVID-19 outbreak hit us. Fortunately, we were at the right place at the right time because COVID-19 specimens, the nasal and throat swabs require the same temperature. And we gave out a couple of the units to the district health administration as well. So they found the product very utilitarian in that there were a lot of concerns about false negatives arising because of samples degrading while transport. So that's how we kind of picked up traction. And now we're at a point where we're delivering to Jharkhand and Orissa for transport of veterinary vaccines as well. Our objective right now moving ahead is to scale up our production capability so that we are able to cater to the vaccine requirements that is upcoming over the next 2 to 3 years right now. Our focus would remain integration into the Electronic Vaccine Intelligence Network, EVIN program, which has been very successful by the UNDP and MOHFW. So this provides clear traceability and temperature RTM for up to the cold chain point or the primary health center. So now we have a battery powered system that is integrated to a dashboard. So there's a lot of potential to integrate our API with the EVIN network itself. So this will provide end-to-end traceability for MOHFW to ensure where the vaccines are coming from and exactly where it's going. The location and other vital statistics that we're transmitting will help with it will help with figuring out the immunization coverage, where the device is going, kind of understanding and helping with the mapping the outbreak of disease over time as well. What areas are being immunized, what are being left out. So all of these are very crucial and vital data for informing value chain decisions. So this is part of our plan right now. And BIRAC, I'm very proud to say that they've just funded us with an ongoing project right now where we are upping the R&D on the product. So this is a battery powered system that is going to the point of administering. which means there's a lot of potential for incorporating a lot of existing technology on board. For example, NFC and RFID scanners. So US FDA and CDC had thought about integrating 2D barcodes on each of the individual vials. So this is a program that is just picking up force right now. And our vision right now is to have a vaccine schedule card, which is already being implemented with data on what vaccines you are due and what vaccines you have already been administered. And then there is vaccine vial information or vaccine vial information on each of these particular vials. So every time you administer a vaccine, you touch the vial to the device, you touch the patient card to the device. This card can be a NFC based card, which is the current practice, but I think MOHFW is moving towards making the Aadhaar program itself compatible with this, so that on a cloud level, there is clear hand-holding of who got which vaccine from which manufacturer, which lot. So this will provide a lot of value when there is an adverse drug reaction arising from a particular vaccine. It will help the pharmacovigilance team in understanding where the drugs are going. And it will ensure that there are no counterfeit drugs or any black market arising, which is a real possibility with COVID-19 vaccine being a limited resource now. There's no risk of hepatitis A or hepatitis instead of hepatitis B being administered by mistake, because the device itself is going to be providing alert mechanism. Yeah. So this is, I'm going to just abruptly stop at this point. We're just, as part of our longer vision, we're hoping to be a part of the bigger program of delivering efficacious vaccines to the farthest corners of the country. Thank you, Dr. Devan. Thank you for providing me with this opportunity. I'd love to take any questions. Thank you, sir.
Thank you, Mayur. I think that was a very clear presentation. And I think both Celsior and Emvolio presents a view that precious vaccine wastage, which would be like shameful to have that in case of COVID vaccine, where we need to cover such a large population, and we are looking at more than one doses to cover the population. And solutions like this could actually preserve the wastage of the vaccines. Even the pre-filled cartridges, which Alpha Corpuscles Atul mentioned, I think these solutions create value and create opportunities which can implement and bring value for this. I now move to other interesting case, and I'm very happy to introduce Dr. Pravanshu Mohanty and Laura, where they are providing a solution with excipients that can actually obviate the need of carrying vaccines at low temperatures. And it's very exciting solutions by Upkar. Is that the right way to pronounce it, or you want me to pronounce it as Upkara Technologies? So over to you, Dr. Pravanshu and Dr. Laura.
No, Upkar is the right word, but
right.
it has been anglicized. But Upkar is the correct word as Indian origin. You can understand that.
Kindly go ahead. Stage is yours.
All right.
Well, good afternoon, everybody. So I'm Dr. Laura Bronzer, and I'm the program manager for Upkara. And I'd like to introduce Dr. Pravanshu Mohanty. He's the founder of our company. So Upkara, as was stated before, is interested in biopreservation as a technology, particularly for the global market. So what has been discussed quite heavily today is that cold chain logistics are going to be a major issue in the distribution of vaccines, in particular COVID. In the case of a pandemic where you want to be able to reach every community, including the rural communities, getting vaccines to the area where they've been maintained at the proper temperature is crucial. This is going to be extremely evident with COVID, where a large majority of the candidates require storage at very low temperature extremes, so -70, -80. And those type of extremes, currently there isn't the infrastructure to support them. There's also financial limitations when it comes to cold chain distribution of vaccines. So when you consider the pharmaceutical industry as a whole, it cost about $18.6 billion in 2022. That's an estimate for the distribution of vaccines that require cold chain. And there's thought to be about $35 billion lost in revenue due to temperature excursions and the impacts those have on clinical trials and the loss of product. And finally, because of cold chain requirements, transportation has to be done by air transport versus sea transport, and that costs about 700% more. And what this results in is that vaccines cost more than what they could cost, and that reduces the ability to vaccinate large communities or rural communities. So there was a study conducted where they modeled just the removal of the cold chain from the last mile, as you've been discussing. What would be the cost to vaccinate an individual if you didn't have to have cold chain during that last mile? And that actually reduced the cost of vaccination from 24 cents a person down to 12 cents a person. So just that last mile had the impact of reducing the cost by 50%. So where our technology comes in is our anhydrophobic vitrification process can eliminate cold chain entirely from the system. Basically, it is able to preserve proteins and nucleic acids at ambient temperatures using benign excipients and proprietary scaffolds. The technology is readily scalable for mass production and requires minimal reagent and capital equipment. So this makes it a financially attractive option compared to similar technologies right now, which are heavily revenue dependent. And then I'm going to pass it over to Dr. Pravansu Mohanty to talk a little bit about the technology and the background of the science.
So the idea behind this technology is just turning the liquid that has the suspension of the molecule into a glass format. And the idea of a glass forming from liquid is not new. It has been used in many, many applications. And liquid nitrogen, sloshed liquid nitrogen freezing is one of the techniques that is used in biology and stabilizing biological samples. So essentially, the idea is you just reduce the molecular mobility, and you do it so fast that you prevent any crystallization, and it turns into a glass. And it is typically done by rapid cooling. But where our technology comes, it's actually the ambient processing technology, where we rapidly desiccate the carrier liquid so that we avoid or bypass any crystallization, and we form a gel or glass. So when I talk about the glass, I'm more talking about an amorphous material rather than the glass we typically know. And that is the background of the technology. And it is done by an excipient formulation plus a desiccation method that prevents any separation or crystallization. So can you go to the next slide? So the comparative technology, if you look at that, the lyophilization has been used. It's a gold standard in stabilizing drugs. So the primary process is basically you freeze, and then after that you do the primary drying and then secondary drying, and you end up in producing a powder product. In our case, what we do, we don't have any freezing involved. The process occurs at ambient temperature above the freezing point. And the idea here, essentially, you take the liquid formulation and rapidly desiccate and form a gel or a glass. And there are significant differences in terms of, because freezing is not involved, there are many sensitive molecules that are actually get damaged due to freezing. So we can deal with many, many different biologics that are freeze sensitive. Then the processing time in lyophilization, optimization and control is a key parameter. And the key step, basically, that's where a lot of effort goes. In our case, the processing is very fast. Actually, depending on the type of biologic material, the process time varies from almost 15 minutes to an hour max. And we can scale the process to very, very large amount of processing because freezing is not involved in that. So we'll show you some examples what we have been working on. Laura, can you take from there? Yeah.
So the applications for this technology are very, very broad. They include a lot of your protein-based therapeutics, so antibodies, insulin. They also include assays, tissue biopsy preservation, vaccines, and blood products. So we're going to describe a little bit of an example using messenger RNA, especially since that is particularly important in terms of COVID-related vaccines. Messenger RNA are a prime candidate for multiple COVID-related vaccines, and they are also the ones that require storage at -70. So this is just an outline of our experimental process. So we have green fluorescent protein encoding messenger RNA. So essentially what this enables you to do is if you were to transfect cells with this messenger RNA, they would translate that into green fluorescent protein, and then you can image for the fluorescence using a fluorescent plate reader or using a microscope. So what we've done is we've taken this green fluorescent protein, messenger RNA that encodes the protein, we vitrify it using our technology. Then we stored the vitrified product or unvitrified control product at -20 Celsius, 28 and 55 degrees Celsius. Following storage, we then elute the messenger RNA that had been vitrified. We perform a lipofectamine protocol, and then we transfect CHO cells and detect the green fluorescence protein. So this bar graph is just data that's demonstrating our ability to retain green fluorescent protein messenger RNA expression following storage at various temperatures. So the y-axis indicates the relative fluorescent unit, so that's indicating how much GFP is there. And then the x-axis is broken up into two groups. We have our not vitrified group, so those were our control groups that were stored in the normal matrix that comes from the manufacturer at -20, at 28 or 55. And then we had the vitrified group where we vitrified the messenger RNA using our system and process, and then stored those samples at -20, 28, and 55. And what you can see is there's a red dashed line. So this data is presented as relative to as stored in accordance with manufacturer specifications, which is -70. So the red line is messenger RNA that was stored at -70. So that's our gold standard. And what you can see is even at -20, the unvitrified product, even after only 3 days of storage, had shown significant reduction in signal intensity. And that reduction only became more apparent with progressive storage. So 3 days, there was about 80% signal intensity. 7 days, that has dropped down to about 60%. And then by 14 days, that was 50%. And that reduction in signal intensity only becomes more extreme when you store at higher temperatures. So at 28 degrees, we're looking at about 50% signal intensity following 3 days of storage, and so on. Storage at 55 resulted in complete loss of messenger RNA expression and green fluorescence protein for all samples, even after 3 days of storage. Whereas for a vitrified product, you can see we retain green fluorescent protein expression for all storage temperatures from -20 all the way to 55, from 3 days all the way to 14 days. And we're currently doing a longer term stability study at this point. So that was just pure messenger RNA. So that messenger RNA wasn't stored encapsulated in lipofectamine. So a lot of the messenger RNA vaccines that are out there are encapsulated. So we wanted to do, this is a very early stage pilot experiment looking at can we vitrify and stabilize encapsulated messenger RNA. It's a very similar experimental design, except for this time, we performed the lipofectamine protocol before vitrification. So same product, JFP encoding messenger RNA, performed the lipofectamine protocol to encapsulate that messenger RNA, vitrified that product using our process, stored that vitrified product at -20 or 28, also stored unvitrified controls, and then we transfected CHO cells and detected green fluorescent protein by fluorescent plate reader. So this is our preliminary results from that work. And again, y-axis is relative fluorescent units. The two bars on the left indicate samples that were stored at 20 degrees. The 2 bars on the right indicate samples that were stored at 28. The dark blue is the unvitrified control. So this was a sample that was not vitrified and stored at -20 or 28. And then the orange indicates our vitrified product. So what you can see is Messenger RNA that's been encapsulated with lipofectamine does have a reduction in signal when it has not been vitrified that our vitrified product is able to protect. And then 28, with storage at 28, you lose all messenger RNA encoding of green fluorescent protein. In our vitrified product, you retain that ability. So we're currently working on this further and exploring other lipid nanoparticles moving forward.
Thank you.
So that's our current state of affairs. We think that there's a lot of potential for this technology to reduce or eliminate cold chain requirements for a variety of products from vaccines, biologics, in a variety of temperatures, whether it's protecting from freezing or protecting from extreme environmental heat. And we look forward to exploring this technology further. And if you guys have any questions, please let me know. We'd be happy to address them.
Yeah, thank you so much, Dr. Laura, Dr. Prabhanshu. I think huge potential, as you rightly said, waiting to be unleashed. I think some probably you might already be doing the chemical stability, the formulation, safety studies, and might want to get integrated with vaccines so that preclinical and clinical safety assessment get into way so that it can see light of the day for deployment quickly. If it works, you have it like $1 billion proposition sitting to be explored. Thank you so much. I think very similar technology I was told that Professor Raghavan is also working on. So maybe at this point I would request Professor Raghavan to come in and maybe share his expertise and his technology. Professor Raghavan, if you can unmute and turn on your video also. Thank you so much.
Sure.
Yeah, we can see you now.
Okay. Just a second. Okay, can you see my screen?
Yes, kindly go ahead, please.
So I will talk about work we have been doing on generating a thermotolerant formulation for a SARS-CoV-2 vaccine. And so everybody knows that there's been a lot of success recently with some phase 3 trial data, and there are a number of vaccine candidates in advanced stages of development. And virtually all current formulations require low temperature storage prior to administration. So there have been a number of formulations that have been shown to be immunogenic, both in animals as well as more recently in humans. And in animals, they have been shown to protect from severe lung pathology. And humans also, there's early evidence of protection. But how long the protection will last, we still don't know. And all the current formulations do indeed require low temperature, some lower than others. So we have been looking, like some others, at the receptor binding domain of the SARS-CoV-2 virus. So just a second. This is the spike protein of the virus. In red is the receptor binding domain, which binds to the ACE2 receptor. And in recent months, it's been increasingly clear that there are neutralizing antibodies which bind to many regions of the RBD. So colored here are different neutralizing antibody epitopes, and shown in blue are places where at least over a month ago, neutralizing antibodies had not been found. So they're mainly at the N and C terminal regions of this. So what we did was to make a fragment of the receptor binding domain, and we put an extra glycosylation site at this region to shield it from eliciting what might be non-neutralizing antibodies. And we expressed it in mammalian cells, insect cells, and pichia, and found that the protein was highly thermotolerant as well as immunogenic. And in hamster challenge studies, which we have done so far with the insect cell expressed RBD, they conferred protection against weight loss and lung damage against very high titers of the virus. So this is just a little bit of the biophysical characterization of a couple of variants of the protein. They are monomeric and they have a stability of about a TM of about 50 degrees or so. They bind well to the ACE2 receptor as well as another neutralizing antibody, so they are conformationally intact. This is the insect cell protein. We subjected it to various kinds of thermal stresses, and it retained its functionality. And once again, it shows the appropriate binding properties, and it's a clean peak by gel filtration. Next, we subjected the RBD to lyophilization and long-term thermal stress. So before and after lyophilization and redissolution, the protein remains intact, and even the lyophilized protein can be subjected to quite high temperatures for reasonable amounts of time. And in water, it remains stable at 37 degrees for a few days at least, which is about all we really need. But when lyophilized, we've subjected the protein to 37-degree temperatures for more than 4 weeks, and it retains its properties. So shown here are the binding properties, where again it shows very clean binding despite long temperature, long time high temperature storage. So we also looked at the immunogenicity, and in guinea pigs, you can just look at the neutralization titers. So we got neutralization titers with a very stringent neutralization assay, which are comparable to several vaccine candidates, which are currently in various stages of clinical development. So the dashed line is where we are, and these are, so other than probably the Novavax, it's difficult to compare because these are all with different neutralization assays. At any rate, we next carried out a hamster viral challenge, and where we challenge with a high dose of the virus. And you can see that the G6 group, which is our candidate antigen, were completely protected. They gained weight. These are the days after challenge, like the unchallenged animals, whereas the challenged animals lost weight. And this is animals immunized with the full-length spike antigen. So in addition, we don't really have time to go through this, but the cytokine profiles were also favorable. And you can see here, these are the lungs from the immunized and challenged animals. These are from the control animals. So, and if you look at the viral load, there's essentially no virus in the lungs of the immunized animals, and these are in the control animals and with another antigen. So these animals were well protected from challenge. They showed no weight loss and very little lung pathology. And ones immunized with the spike ectodomain, surprisingly, didn't do so well. So this is again just a histopathology, and so in blue is with our antigen, and they showed much better scores with very little disease evidence compared to the virus control, which is in green. So I'll just conclude here. We designed a monomeric glycan engineered RBD fragment that is expressed in high yield in a number of different expression systems. It had identical thermal stability profiles before and after lyophilization. It's resistant to long-term thermal stress in solution, at least up to 50 degrees. And the lyophilized RBD was stable to transient exposure, even as high as 100 degrees centigrade. And at 37 degrees, over 4 weeks, it retained all its properties. We expressed similar protein in Pichia, but there the results were unfortunately not so good. And the sera in guinea pigs neutralized SARS-CoV-2 virus with quite high titers. This is against replicative virus, not pseudovirus as many other studies use. And in the hamster challenge studies, they showed very good protection. And essentially, such thermotolerant RBD derivatives show a lot of promise to combat COVID-19. So this was done with a number of collaborators from my lab, ICER Trivandrum, THSTI, and Minvax, which is a Bangalore-based startup, which was really instrumental in carrying out all the guinea pig and mouse immunizations and the serology studies. The challenge studies were done at THSTI. So this is all published in JBC, and it really has received a lot of attention in the media.
Indeed, Professor Raghavan, I think it was a wonderful work and a very good lead that we will all wish you good luck to develop and translate soon.
Okay. So,
at this point, I would request my next panelist, Dr. Suman, who is a professor at IIT Kharagpur, and he and his team is developing an improvised next level of LAMP-based diagnostic test. And we would love to hear the advantages over and above the existing diagnostic kits. Thank you for waiting, Dr. Suman. Over to you.
Yeah, so thank you so much. I just want to share my screen.
Yeah, if you could come closer to your microphone, your voice is a little feeble.
Is it better now?
A lot better. Thank you.
Yeah. Thank you very much. I am grateful to the organizers, and to be very frank, I'm not an expert in vaccine development, but I primarily work in diagnostic technologies. But I have listened to all the expert talks on vaccine development, and interestingly, I find a lot of synergistic similarities between various aspects of developing diagnostic technologies and vaccination technologies. And I presume that these technologies need to go hand in hand because vaccination is important, very, very critical, but diagnostics also should continue. So the major challenge that we have realized over the years in the Indian scenario is the extreme centralized facilities in specialized healthcare, which means that majority of the nation is deprived of even the very basic primary healthcare amenities and facilities. So these will include everything starting from basic vaccination to diagnostics to advanced treatment. We all talk about the shortages of doctors, nurses, technicians, other barriers to access, and several other socio-economic factors. But we often forget that technology happens to be the most critical barrier here, because the conventional ones do not work in these extreme point of care environment. So I just wanted to give this little bit broader perspective, because the issues of vaccine delivery and issues of diagnostics can be connected by this broad philosophy or structure of a rural health kiosk in which I personally work as a team member in coordination with medical doctors and other entrepreneurs. So this is essentially an electronically enabled support system via telemedicine, where the primary health workers interface with the patients, tabulate or enlist the issues faced by the patient in the form of a user interface in a tab or a laptop computer, or it could be a smartphone. And these are disseminated to experts who are sitting in the big city, and the advisory of the expert at the first instance is commonly some drugs, could be injection, could be oral, and of course some diagnostics. Now there comes the bottleneck, because there are issues associated with inaccuracy, delay to distance related factors, and issues of reagent stability. Why I am talking about these is because some of these issues are equally important for diagnostics and also important for vaccine delivery. The innovations which are specifically required here include the non-availability of high quality power, the environment where we have extreme heat, dust, humidity, the reagent storage which is so critical for vaccination. It is equally critical also for diagnostic master mixes or kits. So the specialized air conditioners and refrigerators for controlled environment, they are not there at resource limited settings, and this could lead to degradation of reagents. The supply chain, which is very, very important again, both for these kind of disruptive diagnostic technologies as well as vaccination technologies, it may not exist. Trained technicians may not be available, and price sensitivity is very, very critical. So keeping all this in mind, when we started looking into the COVID-19 testing, I mean, before that I had a significant experience in developing diagnostic devices for rural healthcare, but primarily for non-viral testing. But this was the first time I was doing a viral testing, and I realized that an obvious easy solution could be the rapid antigen based kit, the so-called rapid kit, which gives very quick results, but the results are not very reliable, typically at early stages of the detection. Therefore, we decided to go for a technology for detecting the viral RNA, but somewhat different from the current diagnostic tests which are available. In this perspective, because there are so many tests, so many technologies, so far as I understand, currently more than 600 numbers of COVID tests, different kinds of COVID tests are already there in the market, but people are confused whether the test is screening or confirmatory, whether the cost of the kit is representative of the cost of the test, or there are other hidden costs. Cheaper the better, quicker the better. Are there compelling issues of reagent contamination? Are the reagents stable? Are there cross reactivities? Are the methods resource intensive? Are they user friendly? In the act of making them user friendly, does it still remain sensitive and specific? And are we unnecessarily using fancy electronics or indirect sensing and deviating too much from clinical gold standards? So in the way, what we wanted to do is summarized in the form of this slide. We all know that the RT lamp based technologies, the so-called isothermal technologies for rapid diagnostics, these technologies are primarily based on certain steps which are conceptually very similar to what is done in the RT-PCR test. That is, you still extract the RNA, either you extract or you isolate by certain simplifications from swab or saliva. You still do the amplification, that is, amplify. Instead of using a thermocycler, you use isothermal technology, and still you have to detect the amplification products. We wanted to combine all these with a very, very specialized DNA-based probing step, which is very, very different from the RNA-based probing step that the CRISPR or the so-called Feluda kit and the other devices do. So this is different from CRISPR in the way that it is a DNA-based specific probing, which enhances the specificity of the test, at the same time doesn't compromise with the stability, which is which may be vulnerable if it is RNA mediated, and the entire collection of events starting from sample to the solution is integrated in this portable device, which we call as CoviWrap box. So here we have a pre-programmable unit where you could pre-program the electronics of this unit and the thermal unit so that you could have as many number of isothermal steps in the reaction, in which there will be reaction participating in this specified isothermal condition, followed by a seamless dispensing in a paper microfluidic strip for smartphone-based readout and dissemination. So as per ICMR guidelines, this was tested and validated at the ICMR NICET, certified ICMR lab to do this validation. And the results were very, very encouraging, and we got a very high level of sensitivity and specificity, considering the extreme simple nature of this device, which in US dollar costs within $100 cost per instrument, which is a fixed cost, and then per test it will be around $6 to $7 US. So we wanted to have a journey of this from lab to the field. Because of interest of time, I will not show the video, but the entire crux of the story is we wanted to bring down the extremely advanced premises of molecular diagnostics from high-end lab to the field where there are extreme limited resources and uncontrolled laboratory environment. So in this way, not only for COVID-19, we wanted to have a paradigm shift with a simplified device unit for a RNA-based diagnostic procedure. Today it is COVID. Everybody is bothered about COVID. There are other diseases which might be equally important and severe for some individuals, and tomorrow it will be something else. So once we have such a structured machine unit and a generic method, the technology that comes in the backbone is not just going to help for us to face these kinds of pandemics in the long run, but in the process, these technologies may also be effective in simultaneously developing, the storage, the specialized reagent management and supply chain, also for developing novel vaccination strategies. So I wanted to acknowledge my entire team who did this work, and of course the ministry, the government of India, and the ICMR unit who did these validation studies. So thank you very much, and it was a pleasure in presenting my work.
Thank you, Dr. Suman. Thank you for taking us over a platform technology that can be made more affordable and simplified, covering the last mile. We wish you good luck to get it rolled out. And in the audience, anybody interested in technology transfer for this, Dr. Suman would be very happy to interact with. I think I thank my panel speakers. We were able to bring a glimpse of the innovation quotient which is thriving in the to be unleashed and to be recognized, and all the examples starting from the LAMP PCR test that we just talked about, promising lead candidate Professor Raghavan spoke about, the Upkara's excipient which can obviate the need of lyophilization or keeping cold chain deliveries at minus 50 degrees to ambient temperatures. And in the existing solutions, existing vaccines rightfully delivered at cold temperatures through Emvolio and CellSure technologies. And at the mass vaccination scale, we can also recognize the relevance of safely injecting using safety syringes that can address the the limitation of use of overages in the unit doses, and we can look at bulk and cartridge deployment at multiple dose level. So I think there is a great potential, and I firmly believe that these expectations can be met and the new opportunities can be created from many such affordable, useful solutions which can emerge from Indian innovation ecosystem. So congratulations to all the organizers for putting such an valuable theme for the conference, and I think it was a very knowledgeable, and I personally learned a lot through this conference. Thank you. Over to you, Dr. Swagat and Dr. Bhargava, to take us to the concluding session. Thank you.
Well, thank you so much, everyone. With pleasure, I would like to invite Professor Bhaskar Thorat, Director ICT IOC Bhubaneswar, and Dr. Swagat Mohapatra, UGC Assistant Professor, ICT Mumbai IOC Bhubaneswar, to wrap up the conference and deliver vote of thanks. Sir, Professor Bhaskar, you need to unmute.
Unmute.
Okay, yes. Sir, we can't still hear you.
Can you hear now?
Yes, now we can.
Okay, all right, fine. Thank you, everybody. Thank you, Nidhi. This has been a wonderful learning for me for last 6 to 7 hours. I've been learning for every second, every minute, various accumulated knowledge from amongst 40 speakers. That's a mind-boggling number, which eventually, brought together by 2 of the giants, 3 of the giants who, because of whom this program, we could arrange it, Dr. Damodar Acharya, then Redana and Devendra Mishraji. So I must thank them profusely. With respect to the summing up of this, the webinar, I must put some observations which are from the technology point of view, in the sense that since I'm asked to summarize it, it talks about the challenges that we faces, and a lot of challenges which were thrown by the COVID has been tried to be addressed by many speakers. However, there is a lot of scope for each one of you to move ahead. Everybody knows that the vaccine takes anywhere between 10 to 15 years to bring it to the efficacious use. Last few decades, we have seen in last couple of decades, the Ebola was responsible to bring down this period to about 5 years. And in an unprecedented manner, the COVID is going to be tested within 14 to 15 months. So this is a big challenge. Looking at the process, the manufacturing process, which we are up to some extent, I'm very happy that I could get something from Mr. Dr. Vera Prasad Reddy of Shanta Biotech, then Lakshmi Narayan Neti of the Biological E, Krishna Ella as usual, and my friend Raju Dhere from the Serum Institute. Well, we'll not go into the details of what they talked about, but I have certain points which I have gone through it. And these are the 3 areas or 3 ways that we can address the problem. One is by looking at the live and attenuated vaccines, which are tried and tested, safe. However, they are unproven. Is going to take much of the time. The second one is inactivated whole organisms. The third one is the mRNA, DNA, or some kind of an ad vectors, where everyone has a limited experience. However, they could be more safe than the other 2. And with the hope that, these are the things which our biotechnologists, biologists are going to bring into the picture so that everybody can benefit about that. Well, in terms of the other aspects which could have been discussed, where some of the recent advances that have been taken in the manufacturing, but that we can discuss it during the another session. So all in all, I would like to thank each one of you, each one of the speakers for bringing about the recent work done by them. Particularly, I was very impressed when somebody said that the convergence of technology is the mantra of the today, and I can see the holding hands, various companies holding hands together, with a leading example coming from Glaxo and Sanofi joining together for the adjuvant technology, RNA-based. So I'm looking forward to the magnanimous contribution coming from the Indian companies, which are known to provide 60% of the vaccines to the world, and about, in terms of valuation, 80% of the generic drugs, 20% in volume. I'm sure this challenge which is posed to us, we will take it to the next level. And this program happens to be one of the first leading program initiated by the stalwarts from IIT Kharagpur, alumnus of IIT Kharagpur, ICT, Institute of Chemical Technology, which I am representing. And I'm sure the participation coming from all ends, including the Mr. Harish Iyer, who spoke so elegantly, giving us the various ways that the Gates Foundation is involved to such a large extent, extending the help to even Moderna to the tune of about $500 million and so on and so forth. So all in all, I would thank once again to everybody, and I would like to hand over the mic to Mr. Swagat, my colleague, to propose a vote of thanks.
Thank you so much, Professor Thorat. Thanks, Nidhi. Every good thing comes to an end, and so has this international conference addressing the greatest challenge faced by our country. We thank the eminent leaders from the government, industry, and academia who have shared their extraordinary genius to help us get prepared for their war on the coronavirus, which has been taking human lives. We express our deep felt appreciation to the sponsors who have championed cutting-edge services and solutions to build this supply chain necessary. We are grateful to all of you, the participants, for joining the mission we are on. Finally, I wish to recognize all the prestigious members of this various organizing committee, our moderators, and particularly Nidhi and Meenakshi, to our host and co-host, who worked diligently to build this event. We pray for your safety, wellness. Let us eradicate this deadly virus to restore our health and economy. Thank you so much.
Well, it has been a pleasure hosting this event today. Thank you, each one of you who've been able to join us today and reap the benefits of this conference, and have a good day ahead.
I should say one more thing. We are soon sending you a small memento to all of our organizers, co-organizers, speakers, panelists, moderators soon. So I may request everyone to send their shipping address, maybe like in a day or two. Thank you so much.
Thank you, everyone. Bye-bye.
Bye-bye. Thank you. Bye-bye. Bye there.
Bye.
Bye.
Bye-bye.
Thanks, Manish.
Thank you.
For a
Bye.
wonderful conduct of the meetings.
Thank you, Redana sir. Bye-bye. Thank you for staying up.
And so congratulations to Nidhi, Meenakshi, Swagat, of course, guidance from Professor Damodar Acharya, Professor Bhaskar, and Dr. Satish, a number of others, and the main support coming from the FABA office, Dr. Sharma, Professor Vijay Kumar.
Thank you.
Everybody, I think. Okay, I think all of you have to take rest. For more than a month.
I'm really very, very happy to see that it is almost dead of the night in your place, but still you are here. So this was a long but commitment and very smooth inspiration to all of us. And of course, the prime mover for all these things is our Dr. Mishra. I think he may be doing this thing from his
Okay. Thank you very much.
Thank you, sir.
Good. We could finish in time.
Bye.
It was properly maintained.
Yeah, every session I think they.
Overall, it was excellent.
Excellent. Everything went very smoothly. There was no power breakdown.
On dot, they have.
Yes.
Selected. The highlight is the last session. Yeah, innovative technologies. I think that was really the highlight.
No, innovative technologies, all of them are excellent. Very good.
Yeah. Very good. Very good.
That mock trial, that was also one.
Which one?
The mock trial, vaccine.
Yeah, of course, vaccine.
Good takeaway. We can try.
Yeah.
Whole chain circuit that we can know.
Digital technologies also went on very well.
Topic selected very well. I think that was.
So each and every session, I think, good came up very well.
Lot of background knowledge.
Yeah. Good. Thank you. Thank you, everyone.
Bring out a sort of publication out of it, that what hasn't really happened.
Yeah, I think we need to come up with the outcome of all the entire conference.
Good for this concept.
And which will be published in Biospectrum, Biotech Express, Pharma BioWorld.
No, all these things are within your domain. You can publish everything.
Yeah.
Dr. Redana, can I request something to you?
Yeah, please.
We have presentations, and I could get a lot of innovative points in that. And somehow these points are not in the literature also, published literature.
Okay.
Yeah, so since these are all the issues which are of paramount importance, it's good that we can collate and put them in the right perspective, right format, and in your biospectrum. And also, Swagat, can you share with me the presentations of all the people?
No, we don't have them. I mean,
maybe
one or two.
Whatever you have, just share with me. So, and the rest, I think I'm not sure whether Nidhi has it. Nidhi, she must have gone.
Professor Thorat is telling, generally we make a comparative sort of thing.
Yeah.
The video recording will be available.
Okay.
Yes, sir.
Video recording will be available, which on YouTube we will be uploading.
Yes, sir. So actually we have had YouTube live throughout. That will be there on YouTube by default.
Okay, fantastic.
That will be good, because then we will not lose the point. That is what Professor Thorat is.
Yes, correct. So I'll take care of that. I'll put 1 or 2 students for that, and whatever is possible from Redana your end, you can do it. No? Yeah.
It will be useful.
See, once you compile from through your students,
the
highlights of this.
Yeah, sure.
Then I know the